Good. I'm just putting, just starting the stream on YouTube and Facebook. So just a second before. Good afternoon. Welcome everyone to this second day of the International Pediatric Brain Tumor course. And we have got an outstanding program with the excellent speakers from around the world. The first talk is going to be from Dr. George Jallo. And Dr. George Jallo, as you will all know, is a well-known pediatric neurosurgeon from Johns Hopkins All Children's Hospital in St. Petersburg, Florida. If I give him a full introduction, we will take up all of his time. So I just want to say he's the Vice Dean and Physician-in-Chief at the Johns Hopkins All Children's Hospital, as well as the Professor of Pediatric Neurosurgery there. So Professor Dr. George Jallo, may I please invite you to give your talk? We are greatly looking forward to it. Thank you, sir.
Thank you, Nir, and good morning, good afternoon, good evening for everyone. You know, the first day was tremendous. Looking forward to all the speakers today on the second course. Hopefully, you can see my screen as I'm sharing it.
Yeah,
and I do want to thank Naren for hosting this 3-day brain tumor conference. I think the format is just unbelievable to be able to get us all together via Zoom or WebEx, virtually, to be able to speak and learn from each other. The topic that I'm going to speak about this morning is really ependymomas, and just try to bring it up to date. I know there's some lectures yesterday on the pathology of brain tumors. I think hopefully today we'll discuss some of the clinical aspects. And I'll just jump in. I think, here's the first case that I do want to present. This is a 4-year-old girl, fourth ventricle tumor, presented with some mild hemiparesis and no other major deficits. You can see the MRIs there, the contrast axial, the contrasted sagittal T1, and the unenhanced axial T1 sequences. And you elect to do surgery, of course. And it's midline suboccipital craniotomy, and surgery goes well. Perform it with neurophysiological monitoring, and you're able to, I'd say you're able to get it all, but there's some residual that that you've left behind, and the postoperative MRI confirms that there's some residual there. Postoperatively, she's got a little rocky course, but she's extubated and is eventually discharged home in several days' time. And the question comes back is that She comes to see you back in the clinic in 10 days' time for her post-operative check. And the pathology comes back as an anaplastic ependymoma. And she's got no new deficits, and there's clear-cut tumor residual. And the family is going to ask about what are the next steps. And the question I have for the audience really is, what will you advise the parents to do? One, radiotherapy alone, chemotherapy, go straight to chemotherapy. Should you consider a second look surgery, aiming for a gross total resection, or should you look at a combination radiation and chemotherapy for this tumor? I guess I could have put E, observation, but I'm not sure any of us would consider observation in this higher grade aggressive malignant tumor. So, I think I tried to get a survey going, but I can't. I'd love to hear people's thoughts if they want to just pipe up to see, what people would do. Is it A, B, C, or D? Any thoughts? Okay, just keep that in mind, and maybe we can discuss it as we move along. That's that case. Here's another case. How about this 9-year-old girl presented with headaches and emesis, was found to be neurologically intact, except ideally, if you can put it in your chat, maybe that'd be great. Just recommend what you would do in the chat. There's some residual, let's just say there's residual that is left in the fourth ventricle that is accessible on that last case. The next case is this young girl with headaches and emesis, has a mild gait ataxia, and here's the CAT scan that you can see. Here's the MRI scan. You can see the flare sequences, the post-contrast axial T1, and here's the sagittal T1 and a coronal T1 with contrast. And the question come up is, what is the goal of surgery for this supratentorial tumor that is located in the parietal region? Is it a gross total resection? Would you consider a biopsy, or would one be more aggressive and try to achieve a total resection? And how would one perform this? So after surgery, here are the postoperative images. You can see that it was a left parietal occipital incision and achieved a gross total resection, and the pathology returned as a supratentorial ependymoma with the RELA fusion positive for her, and she went on to receive adjuvant radiation therapy. So, when we talk about ependymomas, I think we all recognize that the third most common pediatric CNS tumor, accounting for about 6 to 7% of all central nervous system tumors. They account for about 40% of tumors in children less than 3 years of age, and typically the mean age is somewhere between 50 to 70 months of age, and they can occur in the neuroaxis illustrated in the two cases. However, the majority are in the posterior fossa, with 60% in posterior fossa and less than a third occurring in the supratentorial. And then the spinal cord accounts for about 10% of these tumors. Histologically, these tumors, and I disagree with this, they've been, the grade 1 is the myxopapillary ependymoma and subependymoma. The grade 2s are your classic ependymomas with several different subtypes. And then your grade 3s are your anaplastic tumors. And then your RELA fusion positives can be either grade 2 or a grade 3. In the literature, I think some of the prognostic factors that have been discussed and written about has been the age younger children, location of the tumor, posterior fossa versus supratentorial location versus the spinal cord, the WHO grade 2, whether it's 2 versus a 3 versus a 1, really. It's, when we look at it, the extent of resection, I make that very bold, the use of adjuvant therapy, and then the molecular features of the tumor, whether it's the RELA fusion, the YAP1 fusion, or is it PFA1 or the posterior fossa B subtype, and then with the chromosomal gain on the 1q. So if we talk about just, the supratentorial ependymomas, I think, we can say that the RELA fusions are present in almost all the supratentorial tumors and can be considered diagnostic. The YAP1 fusion tends to lead to better prognosis. And I think really the significance of the non-RELA and the non-YAP fused ependymoma is not clearly known. And there's really efforts that are ongoing to determine if RELA fusion can be a therapeutically targeted using the NFKB inhibitors. And I know several groups are actively looking at this and trying to bring therapies to the market specifically for ependymomas. But I think right now, I think what we do know is that gross total resection, and if more than one surgery is needed, is probably critical in the best possible outcome for these supratentorial treatments. And I think, looking at the posterior fossa ependymomas, I think if we look at the paper from Mike Taylor's group and others back in 2011, that really found that the two molecular distinct subgroups of posterior fossa of ependymomas, and that the group B had a better overall survival as compared to the group A ependymomas in the posterior fossa. And you clearly see that here, as well as the progression-free survival. Looking at this, I think, this other paper in Nature in 2014, despite having an identical morphological appearance, it's that the posterior fossa A, which was typically more likely seen in younger children, infants, has a worse or poorer prognosis as compared to PFB, which tends to be seen in older children, and it tends to have a more favorable prognosis. And I think it was in 2015 that really looked at ependymomas and, stratified them almost into 9 groups. And, whether take it for better or worse, they grouped them by location, the supratentorial. And I do disagree with this because they put in the subependymoma group into their subtyping of these subgroups. But if you look at the supratentorial groups, you've got you've got your YAP1 fusion group, you've got your RELA fusion group in ependymomas. In the posterior fossa, you've got your subependymoma, you've got your posterior fossa ependymomas subtype A, your posterior fossa ependymoma subtype B in there. And then when you looked at the posterior fossa, they also put in the subependymomas in there. And then in the spinal cord, they grouped the myxopapillary ependymomas as well as ependymomas, and then they also added some ependymomas. And if you looked at this, they looked at the WHO grade, the age group, as well as the overall outcome. And I think, looking at this, they really looked at some ependymomas that can occur, whether it occurs in supratentorial, infratentorial, spinal. Of these 9 subtype, subgroups, 3 of them were subependymomas, accounting for the 3 locations. The others were the supratentorial, infratentorial tumors that accounted for the other subgroups in this. And I think what we realized is that this, it's a family of tumors that are not really close to each other. And I think this better defines it rather than, similar to that previous slide. I think, looking at this, and I apologize that my mouse is jumping around, looking at your supratentorial, really, you've got your relofusion group, which is typically seen in the younger children, regardless of the WHO grade. You've got your YAP1 fusion positive tumors seen in children in supratentorial, and I'm not going to discuss subependymomas. In the posterior fossa, you've got the group A, which is typically seen in the younger children and has a poor prognosis, as the group B ependymomas, which is seen in older adolescents and adults, and it has a better overall survival as the groups, and then the spinal ependymomas that can be seen in adults, and then the mixed papillary tumors, which I think should really be considered a different tumor. So looking at this subtypes, I think the treatment, again, should be really the maximal safe resection followed by focal radiation tumor. And then, looking at, does the WHO grade matter? I think we discussed that. When we looked, looking at the summary of trials, when complete resection followed by radiation, the 5-year progression-free survival is somewhere between 50 to 75%. Overall survival is somewhere between 70 to 80%. Incomplete resection, you can see there's a clear and statistically significant difference in progression-free survival, dropping to less than a quarter, and then the overall survival again dropping to less than 50%. So the questions one always asks is, as I said, does the WHO grade matter? Does the location matter? How young to give radiation? And should chemotherapy be used to delay or avoid radiation? And what's the strategy to increase the rate of complete resection? I think there's papers that looked at the histological grade as early as 10 years ago, looking at the European trials cohort. Even earlier, back when I was in New York, Juliet Hupkin, who's a fellow in neuro-oncology with Jeff Allen, and Fred Epstein, looked at the location as well as the extent of resection. And again, it wasn't about there's no molecular analysis here. It was just looking at classic histology, looking at ependymomas, the age, as well as the progression-free survival and the extent of resection and the location, and found that there's a clear difference between supratentorial versus the posterior fossa. And I think looking at the second look surgery, 5 patients with tumors that an experienced neurosurgeon could not resect on first attempt. Chemotherapy was given, followed by second look surgery. The chemotherapy was carboplatin etoposide. And looking at Alex Sanford from St. Jude's published this, as well as Nick Foreman. What they found was that the experienced surgeon was able to achieve a complete resection in 80% at the second look surgery. And I think this is the COG study from 2003 to 2007, looking at the outcomes of maximal surgical resection with conformal radiation therapy. I think the next paper, really this recent paper that looked at molecular grouping and the outcomes of young children with newly diagnosed ependymoma, the SIGI CO7 trial. I think looking at the bottom line is that they were able to achieve a near total or a gross total resection in close to 76% of the cases. And you can see that what they found was histologically that the majority were really a higher grade anaplastic, and the location is, as you would expect, 2/3 were posterior fossa compared to the supratentorial space. Looking at the overall survival by the histology, the anaplastics as compared to the WHO grade 2. You can see that the progression, the overall survival and the progression-free survival, there's not much of statistical significance looking at it based by histology, but when you did look at it by the molecular groups, looking at the YAP or the RELA fusions, you can, as well as the Plexus fossa A group versus the B, there's clearly a significance based on the molecular groups. So, you know, that it is important to understand the molecular subtyping of these tumors more so than just the histology during the resection of the tumors. So I think the conclusions of the study was, you know, looking at this 54 patients, the extent of resection was predictive. There's no difference in outcome by the histological grade. Chemotherapy can be used. Approximately half the relapses were metastatic. And again, the limitations were the numbers, and almost close to half did not have their planned therapy. And just, I think to summarize, I think what we can say is the current therapy strategies for pediatric ependymomas really include maximal safe surgical resection followed by adjuvant therapy. Aim for a gross total resection, even in case of repeated surgery. And that was as reported by the St. Jude's Children's Group, describing that gross total resection rate of greater than 80% using repeated resections in nearly half of the patients. And that a gross total resection has been shown to be a benefit in spinal cord ependymomas as compared to the subependymomas. And that proton beam radiotherapy for pediatric ependymomas is safe and can reduce radiation burden onto the normal brain tissue. And really, I think the histology alone is not sufficient to determine the overall prognosis. And I think just to conclude, I'm going to give you this reference paper that I was looking at that was just published last year in Child's Nervous System. I think it's a great review and overview of pediatric ependymomas, which is a very complex disease. And I think, you know, we've come a long way in terms of the understanding and the management, but I still think we have a long way in terms of the treatment for this disease in children. And I want to thank Naren and everyone here today for listening to me this morning. Thank you.
Thank you very much, Dr. Jallo, for that very lucid talk on a very complex area. We have got time, so can I just invite Dr. Cohen? Do you have any points or questions or comments, Dr. Cohen, on Dr. Jallo or Stoke on ependymoma in general? Thanks.
Hi, are you able to hear me?
Yes, we can hear you clearly. Yeah.
Calling in from the OR at Johns Hopkins in Baltimore. Dr. Jallo is Johns Hopkins down in sunny St. Petersburg, and I'm jealous, but it was a great talk as always. And I completely agree that these ependymomas are very troublesome and complex tumors. One of the things that I find most interesting is that the landscape continues to change. And as George was saying, the supratentorial tumors are now graded with RELA fusion versus YAP fusion. And previously, the RELA fusion was the group that did the worst. Now, the RELA fusion, with the new WHO classification, is called ZIFTA to make things confusing. And there's a recent study from the Children's Oncology Group. I don't know whether the people from St. Jude's are here, but Merchant and his group found that if you can give conformal radiation to these kids, the difference between the RELA and the YAP fusion goes away. The same in the posterior fossa A and B tumor. The A tumor tends to be the more aggressive in younger kids, but they've been giving conformal radiation therapy to kids even just over 1 year of age. And when they find they give the radiation therapy again, there's a feeling that the difference between these two categories goes away. But I think of all the tumors we deal with, this one is one where, as George said, the kids do better with a gross total resection, but that sometimes can come with a price, and that's the surgical judgment. Where is the tumor located? What's the deficit that's going to be created? But these tumors tend to do better with radiation, and even radiation in young kids. Chemotherapy is being explored. So far, I don't think it's made a significant advance in the field. And so I think there's a lot of work to be done. And as George was saying, maybe the ability to target some of these mutations that we see and methylation abnormalities may be the way of the future. But it was a great talk.
Thanks. Thank you, Dr. Cohen. George, do you have anything to add to what Dr. Cohen said?
No, I mean, I think, we honestly, it's interesting, Al, when I trained, Fred Epstein would say, the histology is wrong on these ependymomas. You take a posterior fossa ependymoma out, you take a spinal cord ependymoma out, you show it to the pathologist, they can't tell you where it came from. Why are we radiating the posterior fossa ependymoma and not the spinal cord ependymoma? And it was clearly, he was right. And this is 30 years ago. He recognized that the histologically, that our pathology, we were limited by our knowledge back then. And we needed a better understanding of these tumors. And I think we're starting to gain that, but I'm not sure that we're there yet, Darren, for ependymomas. I think we made advances on the astrocytomas, medulloblastomas, ependymomas. I think we still, we're making progress.
Thanks.
And I wouldn't be surprised. I wouldn't be surprised if chemotherapy, we won't find chemotherapeutic agents for these tumors.
Thanks, George. There's a question from Dr. Harshad Parekh from Mumbai. If there's a recurrence of tumor, then do you advise resection and again radically? Thanks.
I do. I mean, honestly, I do. I mean, I think that ependymomas is one of those tumors that's a surgical disease, not a radiotherapy or a chemotherapeutic disease. If it's accessible, I've always say surgery, surgery, surgery.
Thanks. Thank you very much. That's great. Thank you very much, Dr. Jallo. And
Thank you.
If there's any questions for Dr. Jallo, please put it on the chat box. So now we will move to the talk on choroid plexus tumors from Professor Nobuhito Morota. Professor Morota is professor and chairman of the Department of Pediatric Neurosurgery at the University of Kitasato. He is former president of the Japanese Society of Pediatric Neurosurgeons, a doyen of pediatric neurosurgery, and we are greatly looking forward to his talk on choroid plexus tumors. Thank you, Professor Morota.
Okay. Could you see my slides?
Yes, we can see it.
Okay, I'll start. Today I'm going to talk about surgery for choroid plexus tumors. This is a case of choroid plexus papilloma, choroid plexus cancer carcinoma. And this is after chemo. And I went to surgery after the chemotherapy and then removed nearly total. Yeah. So why choroid plexus tumors are a challenge for pediatric neurosurgeon? The first reason is the hypervascularity. And the perioperative mortality is reported to be 0 to 25%, usually 12 to 15%. And the young age of patients and the association of hydrocephalus. This often requires emergency surgery and the non-optimal circumstance. And permanent CSF diversion is said to be usually 20 to 25%. So today I'm going to talk about these topics: background of choroid plexus tumors and surgical anatomy, and case presentations for each location. And adjuvant treatment, I use recent papers to review the adjuvant treatment. So regarding the choroid plexus papilloma, it's about less than 1% of all brain tumors and 2 to 4% of brain tumor in children under 15 years old, and 10 to 20% brain tumor in the first year of life. And choroid plexus papilloma accounts for about 60% of the choroid plexus tumors. And the age distribution is very specific. Lateral and third ventricle, the median age of the patient is 1.5 years old, while the post ventricle is 22.5 years old. This means the post ventricle choroid plexus tumors distributed in all ages evenly, while the choroidal papilloma is usually distributed in the first decade. So the 80% lateral ventral choroidal tumors aged less than 20 years, and post-ventral choroidal papillomas evenly distributed and 70% in adult patients. And the rare location is reported in the CT angle, spinal cord, and ectopic cases are also reported. So this is the data. I used this the recent WHO classification, the 2021. So the papilloma is a grade 1, atypical papilloma grade 2, and carcinoma grade 3. And the papilloma takes about 60% of all choroidal plexus tumors, and the carcinoma is about 35%. And the papilloma usually localized supra-infra tentorial evenly, while these atypical and carcinoma, they are predominantly located in the lateral ventricle. And all present presentation is all usually the increased intracranial pressure by hydrocephalus. And in atypical papilloma and carcinoma, they had dissemination metastasis at the diagnosis around 20%. And regarding carcinoma, you have to think about the Lee-Frohman syndrome, the TP53 germline mutation. And the age distribution of the atypical choroidal papilloma is younger than choroidal papilloma. The average 8 to 10 months, while the choroidal papilloma is 2 to 3 years. And carcinoma, about 80% is developed during the childhood. And survival, the 5 years overall survival in gross total resection in papilloma is 97%, very good. And the atypical papilloma, 85%. But there is a strong correlation with the age. And the children less than 3 years had a better prognosis than elder children. And the carcinoma, the 5-year progression-free survival and overall survival is 38 and 62%. The extent of resection and the presence of TP53 mutation matters for the influence the long-term survival. So now I move on to the surgical anatomy of the choroidal plexus tumors. And this is I use this from the Lawton library. And this is from the third ventricle. There is a medial posterior choroidal artery line to the terrachoroidea. And here is the bilateral internal cellular veins. So these are very proximity as the tumor in the third ventricle choroidal papilloma develops. This is from the above. So you bisect the internal cellular vein, and you can see the flow of the third ventricle here, and medial posterior choroidal arteries in each side. And these vessels supply the tumor and drain to the internal cellular vein. So this is the anatomy of the temporal horn, and the anterior choroidal artery comes anterior, and the lateral posterior choroidal artery comes from the bottom, medial bottom side. So in the surgical view from the temporal obstacle approach, you will see the anterior choroidal artery coming from the anterior, and from the posterior or medial, the lateral posterior choroidal artery appears in this way. And the vascular supply to the choroidal plexus, this is the anterior choroidal artery usually comes from the trigon to temporal horn. This part anterior choroidal artery supplies, and the choroidal plexus in the trigon to body were supplied by the lateral posterior choroidal artery. And the medial posterior choroidal artery usually supplies the third ventricle here on the midline. There is an individual difference, but usually these vessels supply the tumor. So this comes to like this figure. This is the choroidal plexus, normal choroidal plexus in the temporal horn, supplied from the arterial choroidal artery from the anterior, and from major lateral posterior choroidal artery supplies. This comes to the tumor in the same way to supply this way. So in MRI, you will see this is a cisternal part of the anterior choroidal artery. This is the choroidal point, and the anterior choroidal artery comes into the ventricle and separates to the tumor in this way. Now, this is an 11-month-old boy with the choroidal papilloma. You will see the anterior choroidal artery coming to the tumor in this way. And the lateral posterior choroidal artery comes here from the bottom and separate to the tumor and drain to the internal cellular vein. This MR where overlaps the draining vein land on the surface of the tumor. So this is a interpretive picture, the choroidal tumor, partially removed, and then the pedicle of the vascular supply was clipped and removed. There is some remnant I'm going to take later. These veins in the ventricle are all preserved. This is a craniotomy in this case, the temporal occipital transcortical approach from this way. This is craniotomy and the total resection at peak. So you will see this is the approach to the relatively lower and temporal occipital approach and remove all the tumor. And this is 14-month-old boy with the choroidal carcinoma, very huge. And I did a biopsy surgery first in this way, relatively large craniotomy for the compression. And this is the biopsy site. And I had two courses of chemotherapy, ice and vincristine, carboplastin and etoposide. And the tumor shrink this way, and then tried the gross total resection in the secondary surgery. Still there is a large enlarged vein draining the tumor to the internal cellular vein. This is a corticotomy for the biopsy, and I use the same approach here from here. They expose the tumor and remove this way. So this is a post-op, nearly gross totally the tumor removed. And so in this case, I did the biopsy and the chemo 2 courses, and the tumor shrinked and gross total resection. This followed by the repeated chemo and finally the irradiation. However, this is a carcinoma, carcinoma. So at the end, the patient had this kind of dissemination all over the surrounding brain and succumbs to the disease 3 years after the initial diagnosis, unfortunately. This is a very rare case of the choroidal papilloma in the body of lateral ventricle, 3-year-old. And in this case, I approached from the interhemis transcallosal and removed all the tumor out about 5 hours, and the estimated blood was just 10 milliliters, very small. And regarding the approach to the choroidal papilloma in the trigon, this paper describes the superior parietal lobar approach. So this approach uses the approach from here. So compared with the standard approach I use like this, you will see the difference from this is more parietal side, this is more temporal side. And the point of the paper is the choroidal papilloma in the trigon like this. You tilt the head to the ipsilateral direction, and then the tumor tilts by the gravity. So if you approach here, you can get to the peduncle, vascular peduncle of the tumor first. So you shut off the vascular supply to the tumor first. So you can remove the tumor with very small blood loss. So if I have the same case next time, I will try this approach. So in the tumor in the third ventricle, we have to think about the approach. This is a case of craniopharyngiomas. But anyway, the approach to the third ventricle, we have these approaches. And the first is transporinitial. This is subchoroidal or infrachoroidal approach. This one, the supra or transchoroidal approach. And the interphorinitial approach. So this is a transporinitial. This is a subchoroidal. This is a transchoroidal. So as you see, these are medial posterior choroidal artery and internal vein, and the tumor usually comes here, supplied by the medial posterior choroidal artery from each side. So this is a case of 8-month-old boy and choroidal papilloma, and a transcranial approach chosen. So this is intraoperative photograph. First, I cut this septal vein, and you see this is a bilateral internal cerebral vein here. You see this is a internal medial posterior choroidal artery supplying the tumor. So you cut off these feeder vessels first before tumor resection. And this is after the tumor resection, and you see the aqueduct here. This is post-op. You see the approach here. Sorry. Okay. This is a. So this is a video in this case. So this is a ventricular drainage here. The approach to the corpus callosum and enter the lateral ventricle. And I just coagulate the choroid flex a little bit, and then make the septostomy. And then extend the septostomy a little bit more. And coagulate the right septal vein, only that side. And cut it. And open up the floor of the third ventricle. And the tumor is covered by terachoroid here. So you detach the tumor from the terachoroid, and that is the internal cerebral vein. And you see the bilateral internal cerebral vein, and this is the feeding artery of the medial posterior choroidal artery. So I coagulate both of them and cut it first. So detach the tumor from the terachoroid. And that's it, the connection to the, this is from the left internal cerebral vein. Detach the tumor. And then you can remove the tumor. So this is the end of the surgery. You see this is aqueduct and posterior commissure. And this is a master intermediate. And this is the end of the surgery. So this is another case of a 5-month-old boy with atypical choroid plexus papilloma. And in this case, you see here is a cavum septum pellucidum here. So I chose the transinterferential approach just on the midline to approach the tumor directly from the midline. So this is after exposing the tumor, the roof comes here and remove the tumor. This is the pre and post-op. This is again, I show you the video in this case. So open the cavum septum pellucidum on the midline, and immediately you can see the tumor at the bottom of the cavum septum pellucidum. And that is the terachoroid. And you see this feeding artery from the medial posterior choroidal artery. So that is the feeding artery and coagulate first and cut it. then separate the internal cellular vein from the tumor. Now, this is the right internal cellular vein. And this is the tumor from the choroid. And in this case, somehow a little bit piece by piece, I remove the tumor. But because you shut off the feeding artery first, there's only a small bleeding from the tumor. So this is the internal cellular vein here. So detach the internal cellular vein from the tumor. And putting up the tumor. And remove it. So this is the mass intermediate. And you see there is a remnant of the tumor here. You putting up the tumor and remove it. I think this is a contralateral normal cord plexus. So this is the end of the tumor resection. This is the right and left internal cellular vein, and at the bottom you see the aqueduct. So this is the approach to the tumor. So in this case, the surgical time is about 3 hours 50 minutes and 4 hours 70 minutes, and the blood loss is 15 and 20, not a lot. So the subventricular choroidal plexus tumors are like a grape. So you shut off the vascular supply at the bottom, at the neck, and you can take the whole tumor out. So the point of success for the surgery for the third ventricular choroidal plexus tumor is the early infiltration of bilateral medial posterior choroidal arteries and preservation of bilateral internal cellular veins. This is the key for the success in the removal of the third ventricular choroidal plexus tumor. So now I move on to the fourth ventricle. 2015, this book was published, and I wrote about the posterior fourth choroidal plexus tumors in this book. This is in this chapter, like this. And in this book, I described the anatomy of the choroidal plexus in the fourth ventricle. This is a pars scium, and the choroidal plexus usually comes to the caudal to the pars scium, and it's shaped like this, like a bat. And on the medial side was the rostral part and the caudal part, and the lateral segment was divided into medial part and lateral part. And this part was called the Bogdanov basket, and this is the origin of the CPR choroidal plexus tumor. On the midline, it is fourth ventricular choroidal plexus papilloma, sometimes embedded to the brainstem. And this is the case of CPR choroidal plexus papilloma. And in pediatric case, this is a paper from the Chicago Children's Medical Center, and they had this pediatric case, and they say there's no significant blood loss during the resection, and when the tumor embed to the brainstem, leave it and see if the region grows. And in their cases, there was no regrowth after the resection, partial resection of the choroidal plexus tumor, they say in this paper. So the management of choroidal plexus tumors described in this paper from the OC Vienna. They treated 36 cases, 70 children, 19 adults, and all adults cases located infratentorial, 4 CP angle tumor and 15 fourth ventricle location. And tumor recurrence or the survival rate depending on the histopathological grading and the extent of the tumor resection and the left median dissemination or the nearby infiltration. These matters for the long-term survival. These are clinical presentation in children, the increased ICPA and the increased head circumference, or the adult, the headache and gait disturbance was a predominant symptom for presentation. This is the location of the tumor in their case. And the survival rate correlates with the surgical extent of the resection and the histology. And interesting, the children has a higher grade. However, the long-term survival for children is better than adult. This probably due to the location of the adult choroid tumors mostly located in the fourth ventricle. This makes this difference. So what they say is choroid tumors are exclusively located in the infratemporal region in the adult case. And historical grading and the extent of surgery matters the survival rate. And this is a paper from the United Kingdom about the embolization. They had 30 patients, the 15 had the pre-op embolization and 15 had no embolization. And the embolization success rate was 87%, and gross total rate is 100% in embolized case, and estimated blood volume loss rate was 96%, much less than the non-embolized case. So you see, this is the embolized case, and this is a no-embolized case. So in the papilloma or carcinoma, both the bleeding is much less after the embolization. If you look at the completely embolized case and partially embolized case and a failed case, you know, the bleeding is so different in each case. So they concluded, although it is technically demanding, preoperative embolization results in a reduction in interrupted blood loss and improves the chance of achieving a gross total resection while reducing the overall mortality and morbidity. This is a case report from the United States, very interesting. This is a huge third ventricle plexus papilloma. This is before embolization. And after embolization, the tumor continued to shrink. This is a post-embolization 6 months. However, at 18 months, there's a newly developed cystic lesion around the tumor. So they decided to operate the case at 23 months. This is the MRI of the gross total resection. And you see that tumor was completely removed. And they concluded the embolization reduced tumor size and CSF production. And choroid papilloma embolization may represent a curative strategy or facilitate delayed surgical resection in case involving very young patients with large choroid papillomas. Regarding neoadjuvant chemotherapy, this is a paper from Toronto. And they included 22 children. 10 had no chemo, and 12 had 2 to 5 cycles of ICE treatment. And this means that also after chemo, the blood loss is so small, less blood loss that leads to the more gross total resection after chemotherapy. That means there's a better prognosis of the long-term survival. So the administration of neoadjuvant ICE chemotherapy was associated with dramatic reduction of internal blood loss, leading to the much higher incidence of gross total resection. And this neoadjuvant chemotherapy after diagnostic biopsy is recommended in patients who don't need emergent tumor volume reduction. And when developing inevitable at presentation, a second resection of the chemo is likely to result in the gross total resection for minimized blood loss and provides the best chance for long-term tumor-free survival. And last month in January, this paper was published, choroid tumor research. They included 158 patients. And this is the overall survival rate correlated with histopathology. And interestingly, this is the case of atypical choroid papilloma. The age less than 2 years and over 2 years. There's a big difference of overall survival, progression-free survival. So younger children better for the long-term survival. And regarding the chemo, carboplastin at the post of increasing in this treatment is much better than the cyclophosphamide and post-vincristine. And they, in this paper, they concluded that choroid papilloma, a low-grade tumor with a very high overall survival. However, they don't completely follow the characteristics of a benign tumor. For example, the postventricular choroid papilloma with metastasis. And half of the patients with choroid carcinoma died despite intensive treatment. And atypical choroid papilloma patient younger than 2 years shows a significantly better prognosis. And in contrast to the common belief, this prospective study didn't confirm the impact of complete resection in choroid carcinoma. This is likely the result of improved non-surgical treatment. And this study also supports the use of carboplastin for the chemo. And the irradiation, the role of irradiation remains constrained. And here is one case report about the purely endoscopic resection of the choroid papilloma of the third ventricle. But you know, the Mark Krieger, he's an expert of the endoscopic surgery. And so this is not the case for the standard procedure. And this put-op and post-op like this. I don't think I can try this purely endoscopic resection. I'll do that craniotomy and the direct approach to the tumor. Only the expert of the endoscopic surgery can allow to perform this procedure, I think. So the surgery of choroid tumors, the gross stabilization has been the most important predictor of overall survival regardless of histology grading choroid tumors. And advancement in neoadjuvant chemo may allow the treatment algorithm of choroid carcinoma in the future. Interventional location, tumor vascularization, and impaired CSF circulation have to be considered in the surgical approach. So the goal of the surgery is gross total resection. The papilloma and the atypical papilloma preoperative embolization to be indicated if possible. Or the carcinoma, neoadjuvant chemo, and preoperative embolization together with the stage surgery. This would be the desirable treatment to achieve the gross total resection. And management of hydrocephalus external ventricular drainage comes first. And VP shunt after tumor resection to be indicated if necessary. So the triangle, this pathology can be present and highly vascularized by anterior choroidal artery and lateral posterior choroidal artery. And both the lateral ventricle, maybe papilloma and atypical papilloma can exist. And less vascularized, probably. Lateral posterior choroidal or the medial posterior choroidal supplies the tumor. And inside the ventricle, choroidal papilloma or atypical papilloma, and less vascularized, and the medial posterior choroidal artery is the main feeder. And fourth ventricle, choroidal papilloma, atypical papilloma, usually. And less vascularized, and the PICA or ICA would be the feeder. And the other case comes to the 70%. So this is the end of my presentation slide. Pediatric choroid tumors predominantly located in the lateral ventricle, a blood supply from the anterior and lateral posterior choroidal arteries. LD obliteration of the vascular peduncle or feeding arteries is mandated to reduce massive blood loss. Gross totalization is a key for long-term survival. Neoadjuvant chemo would be recommended in case of choroid carcinomas. And embolization would be recommended in selected cases of choroid tumors. And the role of irradiation in the management of choroid tumors remains unclear. Thank you very much for your attention.
Thank you very much, Professor Morota, for that excellent talk. It was a fantastic talk, covering all the aspects and beautiful operative videos. You have got a couple of questions. One question is from Dr. Miranj Miranj. She's saying, do you use EVD post-operatively to assess the need for VP shunt?
Yeah. So the external ventricular usually comes first, and the weight after the surgery, if you really need the BP shunt or not, you decide after the total resection of the tumor.
Sure, absolutely. Dr. Jallo, do you have any questions, comments? Dr. Boop, do you have any questions or comments?
I would just say that it's a beautiful lecture. It's one of the best talks I've heard on this topic. And obviously, Nobu is a very good microsurgeon. The surgery video he showed is excellent. I'll make two comments. One is in the infants that present with the choroid plexus tumors, oftentimes they have massive hydrocephalus. And although we can resect the tumors when they're a few months old, once we open the corpus callosum, then post-operatively, we're open to cortical collapse or chronic subdurals that don't go away. And oftentimes those children do end up with a shunt, even though the tumor's gone. So the strategy of preoperative embolization for the choroid plexus papillomas is important because oftentimes that tumor will involute with embolization. And even if it doesn't completely go away, it may allow you to let the child grow to the point where their head is larger, their brain hydrocephalus is not so advanced, and then you can come back and resect the residual tumor when they're older and less subject to this craniocerebral disproportion. In the papillomas, in the carcinomas, they get the blood supply from the parenchyma, and so embolization of the choroidal vessels doesn't help with the bleeding so much. And I would agree with upfront chemotherapy is a good way to reduce the vascularity. We've had one child that we were giving chemotherapy trying to delay surgery who developed high output heart failure in that interim. And then we ended up having to take him to surgery when he was in heart failure. So it's important to monitor their cardiac status if you're delaying surgery for chemotherapy. But beautiful lecture.
Thank you very much.
Thank you very much, Dr. Boop. Thank you very much, Dr. Morota. I think there's a question on the chat box. If you have time, it's from Dr. Parak. I will be grateful if you could answer. But for reasons of time, we will now move to our next talk. It's from Dr. Nir Shimony. Dr. Shimony is a consultant pediatric neurosurgeon at Geisinger in Danville, Central Pennsylvania. He had done his fellowship in pediatric neurosurgery with Professor Shlomi Konstantini, and then his second fellowship with Dr. Jallo at the John Hopkins All Children's Hospital. So I'm really looking forward to his lecture on pilocytic astrocytomas. Thank you, Dr. Shimony. Would you be able to share your talk? Thanks. Just a second there. Sorry. Just a second. Yep, you should be able to now, Nir. Thanks.
Can you hear me now?
Yes, I can. Yeah.
Okay, let me see if I can share. Hello, everyone.
Hello.
And I will try to share my screen. I should be able to do it right.
And Dr. Boop, could you do the discussions at the end of this talk, please? Thanks.
Can you see my presentation?
Yes, we can.
Okay. So hello, everyone. I'm talking to you from the cold central Pennsylvania. We have an ice storm now. And Naran, thank you very much for this wonderful course and to be able to participate and be part of it. This is, as usual, your contribution to the field of pediatric neurosurgery is beyond words. So I was asked to discuss the pediatric pilocytic astrocytomas, which we'll do in the next 30 minutes or so. I have no disclosures. and I will jump right into it. And I'll be honest with you, when I look at the topic, my first and initial response was pilocytic astrocytoma. We have a lot of other tumors, important tumors to discuss about, right? We have all the advances in medulloblastoma and glioblastoma. I think there is someone with his speaker open, by the way. And started to dive into it because the initial response is usually, okay, it's a pilocytic astrocytoma. They do well. Prognosis is great, and you just do surgery. Is it really? Is it like, the poo, or is it the grizzly? And the answer is usually depends. And this is like 3 examples of cases that I encountered. I'm sure that everyone has their own cases. On the left, you see a 4-year-old at a posterior fossa mass, looks classic with pilocytic astrocytoma, got a gross total resection, and just follow up without any further treatment. The real question is, and you see the pathology, the histology is a pilocytic astrocytoma with a BRAF point mutation negative. The question is, for how long do you need to follow him? He's doing great. She's doing great. The middle one is a 5-year-old that we're going to discuss later on in the lecture as well, that had a partial resection in the past with what seems to be a large thalamo-peduncular tumor or location for tumor. Pathology was again the same, pilocytic astrocytoma negative for point mutation, but a Ki67 or MIB that was higher than the usual. Got chemotherapy by the CCG protocol, got progression, quite a bit of neurological deficit from the initial surgery, and we decided to go for a second resection rather than to progress for radiation, and she got a gross total resection and so far follow up and doing well. Was that the right decision? And the last one, I think at the other end of the spectrum of this tumor that usually we end up doing surgery on is a 5-year-old non-NF with a clearly optic pathway or hypothalamic glioma that had surgery for just decompression and take it away from the foramen of Monroe to and end up getting chemotherapy. The tumor didn't change much at all. The symptoms went away, and he has no shunt and doing well. The tumor pattern or features are pretty much the same. Again, BRAF negative, IDH negative, and Ki67 that is relatively low. So this is, I would say, kind of the spectrum of pilocytic astrocytoma and what can we take out of it. And this is just another example of what we just saw with the kiddo with the thalamo-peduncular tumor that we decided to often go for surgery and try to remove it all rather than to give radiation therapy. And that's part of the discussion, because not all the time these tumors are in a location that it's either comfortable or can end up without any new deficits. So it's a question, right? And I know the Dr. Rick Boop is on the line. One of his papers about this particular tumor we're going to discuss later on. And those are not all the time or in every case easy to get out. So what will be the open questions that I'll try to answer some of them. Surgery is still the best course for pilocytic astrocytoma. What do we know nowadays with all this exploding information regarding the molecular features regarding brain tumors? Do we have any other different solutions? What should we do next? And how long should we follow those kiddos with pilocytic astrocytomas? So I guess other people along this course discuss about the fact that unfortunately brain tumors now got the lead in terms of the most common form of solid tumors among pediatric patients, especially until the age of 14, and became like the leading cause for mortality-related cancer, for cancer-related mortality at the same age group. And we know there is a lot of research going on and quite a bit of information coming in the last, especially 5 years, regarding brain cancer or brain tumors, but still it seems to be that research on one end, but epidemiology on the other hand, and we have much more diagnosis of brain tumors in pediatric population, and we need to somehow speed up our treatment abilities. So when you look at the latest publication by Cibitrus, data from the the US in regards to epidemiology of brain tumors among pediatric population, the most common primary brain tumor going to be the pilocytic astrocytoma when you look at the age group of 5 to 14. But in general, this is one of the most common tumor type from 0 to 19 years of age, where the adolescents will have much more propensity to have tumors of the pituitary region. But for the young age, or especially the majority, the 5 to 14, is going to be pilocytic astrocytoma. And some facts that are well known, that the fact that this is a slow grow tumor, sometimes we can see that they even have a tendency to regress to some degree. The most popular sites will be the posterior fossa and the area of the chiasmatic hypothalamic region. Dissemination is very rare and uncommon. I know that there is a debate regarding the need to do a craniospinal diagnostic MRI before you take them for surgery or as part of the workup, especially for this kind of tumor, because it does not tend to disseminate. And maybe the use of the MRI or spinal MRI is unnecessary. The one pathology that goes hand in hand with pilocytic astrocytoma, as you know, is NF1 or neurofibromatosis, what is about 15% of those kiddos will develop some degree of pilocytic astrocytoma at early age, and usually will do well. And usually it's going to be in the optic pathway region. Now, the real question that we'll try to answer, what do you do with those that has partial resection or near total resection? Should we give treatment up ahead or go for surgery or just do follow-up? So for those, and we'll split that for those that are optic pathway related and not optic pathway related. So for those that are not in the optic pathway, usually will be in the posterior fossa cerebellar tumors, well circumscribed, will have a nice cyst that will go with it, so mural component and a large cyst. The cyst itself, it's not part of the tumor, just part of what the tumor does. Whereas in the optic pathway region, the tumor tend to be a little bit more hazy in appearance. We like to see that on FLAIR image. The borders are not that clear. And those tend to be less for a surgical solution, and we'll talk about that. Do we still need this, to use histology? The answer is, of course, still. With all the information that we have today regarding the molecular subtyping, we still need to get a good grasp about the histology part of the tumor. So some small features about that for the audience. So rosal fibers that were closely related to a lot of tumors, and part of it is pilocytic astrocytomas. Important to know, are not pathognomonic for pilocytic astrocytomas and nor necessary for diagnosis. The MIB, the MIB, can be, something that we use a lot of time for discussion regarding how aggressive is the tumor. In PA, in pilocytic astrocytomas, usually it's less than 4%, which means that not very aggressive tumor, not differentiate very quick, but it's not a helpful tool for differentiation. So we do need the newly diagnosis or the newly knowledge topics or findings that we use nowadays, and got into the latest classification by the WHO in regards to the I would say the RAS MAPK kinase or the MAP kinase pathway that we know today to delineate the two main features or patterns regarding the pilocytic astrocytomas, that goes with the KIAA1549 BRAF fusion gene. That is the most common one that we'll find in pilocytic astrocytoma. versus the BRAF point mutation, the BRAF V600E, that we talk quite a bit about it because of BRAF inhibitors, but it's much less common within the pilocytic astrocytoma group. We see that more commonly, for example, in gangliogliomas. So the whole idea of this very important cycle that is now becoming the mainstream of research regarding targeted treatment is with the idea that this cycle is heavily involved in the creation of, on one end, healthy cells, but on the other end, of tumor progression and cell proliferation. So the idea was that if we can target part of this cycle, we can definitely get to some kind of a hold or to stop the progression and proliferation of those tumors. And that's important because we see that in real life when we use BRAF inhibitors, that a lot of times when we stop using them, the tumor just come back. So the main rule, the main tool of BRAF inhibitors or MEK inhibitors can help us to control the tumor and a lot of times not to make it disappear completely. So the other component of what you see in this slide is the mTOR pathway, which is important as well. We see that in more aggressive tumor, a lot of times in high-grade tumors, but also in aggressive pilocytic astrocytomas that we'll need to take into consideration as part of the diagnosis. So the MAPK kinase or the ERK pathways are not the only one that are known today for pilocytic astrocytomas, and many others are being investigated and studies. One of them is, for example, the FGFR1 that we see more in the midline structures, but many others. Location matters. So the cerebellar pilocytic astrocytomas, the one that we usually get the gross total resection in, is heavily incorporated with tumors that has the fusion, the KI-AA fusion. We see that much more in this location, but we see it also in the optic pathway location. The BRAF V600E, which is less common in pilocytic astrocytomas, we see more in those hemispheric pilocytic astrocytomas or sometimes in the diencephalon region. The FGFR1 that we just discussed is related or associated with more poorer prognosis. But there is an asterisk for what I just said, or caveat, the fact that we talk about prognosis in relation to the molecular subtype. We used to say in many cases that a specific point mutation or fusion can tell us something about the prognosis. We now say that it's most likely related to the fact that if it's in a location that we can get in a better way to get a gross total resection or near total resection, and not necessarily regarding the actual molecular subtype. That's a nice slide that I took from a publication by Roger Packer in regard to the distribution of the BRAF fusion versus the BRAF point mutation. And you see the same picture that most of the BRAF fusion will be met in the cerebellum and the region of the posterior fossa, but also we'll see them in the part of the optic pathway gliomas as well. So is it good or bad? Can we use that or not? So I gave you a hint about it. And the answer is that until recently, we actually did. We said that KI-AA1549 fusion is associated with good prognosis. But we don't say that anymore because it seems to be that it's more related to the fact that most of the tumors find themselves in the cerebellum where we can achieve a more successful resection, either GTR or NTR, and hence the prognosis is better. The BRAF V600E was shown to be related to or associated with bad prognosis, but that's usually with gangliogliomas, which seems to be not related to pilocytic astrocytomas. So we need to be careful when we talk about prognosis in relation to these two major components now in the molecular subtyping of pilocytic astrocytomas. So it seems to be that we went a little bit forward with the new finding regarding the molecular subtyping, but we came a little bit backward in terms of discussion of surgery. Is that the real key for prognosis? And it seems to be that it is still the real key for prognosis. In terms of presentation, it's a nice publication that was recently in oncology regarding two age group, the very young ones, less than 4 years of age, and older kiddos above 4 years of age, and regarding the presentation with newly diagnosed tumors. This is specifically for low grade. And we see something that we see in clinic, that headaches that we tend to talk quite a bit about them are more important when the kid can actually verbalize himself or herself and talk about the headaches. In the young age group, we need to look for something more subtle. And for these kids that have repetitive visit with the pediatrician because of having nausea or vomiting, or I'm not even talking about the very end of the spectrum of failure to thrive, someone needs basically, usually the pediatrician or the PCP, to look in a broader picture regarding maybe there is something else and not a GI related problem here. The classic time lag that is being published in different papers coming from Europe, from Israel, from the US, is about 2 to 6 months for pilocytic astrocytomas, because usually the time course and the presentation is in some kind of a part of an indolent course until the patient get either with obstructive hydrocephalus or progression of his symptoms. From imaging perspective, as a small review, the classic picture is what you see on the right, some pictures that I took from the net. Basically a mural nodule that is vividly enhanced with gadolinium and will be usually hyperintense on T1 and T2, or sometimes isointense, but it's the mural node with a large cyst that comes with it. I bolded here something that I personally use is looking at the diffusion and the ADC map in order to see and delineate that from other type of tumors that we know that the more aggressive one tends to have hypointense or being dark or on ADC, whereas the pilocytic astrocytomas, they do not restrict and their ADC is usually hyperintense. So what is the treatment? So the classic treatment is usually surgery, with the exception of OPG, but usually it will involve some degree of surgery. And then the question will be, do we need to use chemotherapy, yes or no, radiation therapy, yes or no, proton versus photon beam? Then the question is, what do we do nowadays with the new treatment or targeted treatment regarding the BRAF inhibitors or MEK inhibitors? Because the overall survival altogether, and that's quite solid across the years, regardless of what we have, is about usually around 90% and more for pediatric patients. When those tumors are being diagnosed in adults older than 40 years of age, it's only about 70%. So usually the overall survival in kids is very good, regardless of what, which treatment avenue we choose. We do know that those that tend to give us the nice numbers of the prognosis goes with association to the degree of resection in this kind of tumors. So regarding the targeted treatment, we have a lot of them nowadays. We have the MEK inhibitors, the BRAF inhibitors, the mTOR inhibitors, and much more. And this is a nice slide to give some kind of an overview, but some of them in relation to the tumors and some of the studies that are out there nowadays. But this is basically keep on changing. And I think this is a slide from about a year and something ago, and then that's already something that is on the move, and some of it is already not as up to date as it's what is going on out there in terms of the research. So is that really the real promise, the targeted treatment? I know that a lot of people are debating about this question, and in Tumor Board, we a lot of time discuss, do we really need to use that as a first-hand tool after surgery? in those cases that we think that needs treatment. For example, OPG. You don't go for surgery for resection. A lot of times you do biopsy or debulking to move it from the CSF pathway, but eventually the treatment is not surgery. So do we need to use the targeted treatment as a first-line treatment? And it's debatable. In many cases, I think that the needle is now starting to steer towards this end that we'll start using the targeted treatment as a first line, but this is still very debatable. So a recent paper that used the brafenib, which is a BRAF inhibitor on a kiddo with optic pathway glioma, you see very nicely the change over time. The middle pictures show you 4 months on the brafenib with very nice response, and 1 year after continuous response on treatment. The overall response rate that's been published in different papers is about 44% or 50%, with a median progression-free survival of about almost 3 years. Yet, we need to understand which tumors are we talking about. We're talking about pilocytic astrocytomas that, to begin with, are very indolent and very slow progress. So we need to take this information carefully into discussion. Overall, it seems to be nowadays that the combination treatment of a combination of BRAF inhibitors and MEK inhibitors, sometimes at the same time, give us better solution or better results. So the question is still stands the same way. Should it be the first line of treatment? Should it be something that we think as an pre-adjuvant treatment at some cases to shrink down the tumor and then go for surgery and take it out? That's still debatable and still still being studied. Another very nice example of the use of targeted treatment. This is a patient, an 18 years old, that about 2 years ago got a biopsy and debulking to take it away from the Monroe, and then was found to have a BRAF point mutation, BRAF V600E point mutation. Was started on the brafenib, got some degree of response. The treatment was stopped, the tumor relapsed, and then was put again on the brafenib and MEK inhibitor combination. And this is a very recent picture, I guess a few days ago, with almost no residual. Now, she will stay on treatment. She had only very mild skin rash from time to time, but altogether she's doing very well. She doesn't have a shunt. She doesn't have any new symptoms, and altogether her visual fields are stable or even slightly improved. So, what is the solution here? Should she just live on this treatment, just stay on the BRAF inhibitor, MEK inhibitor? That's something that we need still to see where it's going. It's still too soon to discuss about the long-term results of the targeted treatment, but the results so far are very, very promising. So I wanted to give you some kind of a roadmap for treatment, the way that the literature show it and the way that I see it. When we have the cerebellum, the classic posterior fossa tumors, pilocytic astrocytoma, the surgery is still the main tool. And you need to aim for a gross total resection, or if not, near total resection. If there is any tumor that is left behind, if it's very small portion of it, follow-up is the legit option, very strict follow-up, or going back and do a second look surgery to remove whatever is left. Mutism as a complication of surgery for posterior fossa pilocytic astrocytoma is quite rare. Regarding the use of chemotherapy, targeted therapy, or radiation therapy for this specific location, it's usually unnecessary. And usually if you see some kind of residual that is progressing, you just need to go back and basically continue with, do another resection. In terms of prognosis is very good, with overall survival close to 100%. And the usual bad factors is something that we know from other kind of tumors, is if the patient eventually had a neurological deficit or needed for a shunt, or have any kind of low socioeconomical or lack of support for his condition. Whenever the tumor is in the optic pathway region or hypothalamic region, usually surgery is not the main tool. Sometimes we use it for biopsy purposes. It is important to delineate and differentiate if the patient has an NF1 or not. The NF1 patients usually tend to do better with OPG. The surgical solution as an actual resection is rarely being used, usually for very large tumor as part of either debulking and taking it away from the third ventricle, try to clean up the CSF pathway, and in rare cases for an actual treatment when everything else is failed. There are some case reports and case series regarding good prognosis and good results from surgical resection, but this is not the first line treatment for optic pathway gliomas. And the most important thing is to remember that eventually, even for those nice results for surgical resection that were published, the surgical resection does not lead to improve survival, does not lead to improve endocrine prognosis or better visual outcome. Chemotherapy is the first line. Now started to be questionable if we need to use the targeted therapy as first line as well. And some centers started to use targeted therapy as first line rather than chemotherapy. It is important to know that chemotherapy was shown to be a very good component in therapy of OPG, with tumor control around 80–90%, with some reports showing that bevacizumab can be a good option when the chemotherapy failed. And the question is always, when do we utilize radiation therapy? Usually we try to avoid that in NF patients, and we leave it for those that failed treatment. Nowadays, with the utilization of proton beam, it is questionable because there are some very nice results with proton beam, and it's something that will need to be cleared out. I'll help in the next few years. So in general, if the patient is not symptomatic and the tumor is not growing, just watch and do it very carefully and closely, especially if the patient is an NF1. You don't need to run and give treatment. If everything failed, do remember that radiation therapy leads to very nice results in terms of overall survival and progression-free survival. And for the subpopulation of infants, they usually have a poor prognosis, so we should consider to be a little bit more aggressive. In patients that require...
Dr. Shimony, you have got about 2 minutes left. Thanks. Sorry.
Okay, I'll speed it up. Thank you very much. In patients that are non-NF, usually the majority will have some kind of progression within 5 years. And we see that the same with NF, but less frequently. But overall, we need to remember that the overall survival is very high. So we need to be very careful regarding how much aggressiveness we put into the treatment. I will speed it up and will say that this for supratentorial hemispheric polycytic astrocytomas, it's pretty much like the posterior fossa with the same agenda regarding the treatment. And for midline structure, not DiPG, surgery is still the main tool. Even for those tumors like this one, the thalamopeduncular, and this from a paper by the group with Dr. Boop, that show that even in this location, if you take the technology into account and you use it very thoroughly before surgery, you can achieve gross total resection or near total resection, and basically very good results for the patient, almost without any deficits. And on the flip end, this is a very recent study, showed that for the same type of tumor, even for those that didn't get a gross total resection, the overall survival and the progression-free survival are very good. So basically, don't harm the patient. If you can reach gross total resection, great. If not, do a maximal self-resection, do a very strict follow-up, but do not harm the patient because the overall survival is, as you know, very good. Do we have another minute, Naren? Okay, I will take it as yes.
Sure. Yeah.
Thank you. So how long follow-up? Good question. It's still very debatable. Some centers will continue annual follow-up for years or even for life, and some will stop it after 5 to 10 years. A nice paper from back 2014 showed that for adult after subtotal resection in their past, they show that they saw some progression after even 25 years. Still the question, is it clinical significant or just a progression over imaging? So this is still open for discussion and debate. And I would say for conclusion, the overall survival is very good. So if you can achieve a gross total resection, this is the key component for prognosis. Targeted therapy seems to be a key component in treatment coming in the next few years. And we should start include that in our treatment regimens. And for OPG, don't treat the picture, treat the symptoms and treat the patient if the tumor is progressed. And I will conclude here. I say thank you very much for your attention.
Thank you very much, Dr. Shimony. That was a fantastic talk on this important and common and one with a good outcome. For want of a time, there are a few questions for you on the chat box, but can I ask Dr. Boop to make any comments, Dr. Boop? Thanks.
Well, thank you, Nir. And Nir, it's good to see you. That was a beautiful overview.
Thank you.
I think we're kind of in a purgatory with the targeted therapy agents. We've all seen kids who have dramatic responses to dabrafenib, trametinib. I would point out that some of those agents can cost as much as $20,000 a month for treatment. And so it's not something that is affordable worldwide, but it is an exciting avenue of therapy. More on that in the future. Low-grade chemotherapy, traditionally carboplatin, vincristine, vinblastine. Most children will show a response to treatment, but if you look at long-term cure rates for low-grade gliomas with those agents, it's on the order of 5%. So I think it's important to think of those as agents to control tumor growth for a period of time until children get old enough for other therapies, because it's generally not curative. And then the final thing I'll say is to the point of long-term growth. In Jeff Wissoff's big study on low-grade gliomas that had just surgery and no other treatment and were observed, 40% of the children who had residual pilocytic astrocytoma had no progression at 10 years. But we're seeing those kids get into their 20s and 30s, and once they become adults, that residual may start to progress. So when it does, I've had several of the children who progressed, we reoperated, it grew back, and they died. And so I think when kids have residual on imaging, you can never call them cured. You have to follow them the rest of their lives. Thank you.
I agree.
Thank you very much, Dr. Boop. That's very, very insightful. And once again, I thank Dr. Shimony. Dr. Shimony, I got a few questions on the chat box. If you have time, I'll appreciate that if you could answer it. So
yeah.
So the next speaker is Professor Muzumdar. It's a pleasure and honor to have him in our forum to talk about pediatric thalamic tumors. Professor Muzumdar is the chief pediatric neurosurgeon at the famous King Edward Memorial Hospital in Mumbai, and he's also the editor of the Pediatric Neurosciences Journal. So, Professor Muzumdar, thank you very much for contributing, and looking forward to your lecture. Thank you, sir. You have to unmute your microphone, Prof. Muzumdar.
Yeah. Now,
Great.
am I audible now? Yeah.
Yeah.
Thank you very much, Naren, and I'm very glad for this fantastic symposium that you have organized. And hello, everybody. So I have been given a difficult topic, which I will try to cover in the next 25 minutes. You see the thalamic tumors, which are referred to. So when we go from the hemisphere to the deep tumors, the prognosis starts becoming dimmer and dismal. And largely for many years to come, these tumors were not being addressed for the simple reason that we had very limited options. So the imaging was not appropriate, the surgical techniques not developed, and obviously the results were not good. These tumors were left alone, maybe just given radiation So the thalamus has a complex anatomy. So as you see here, the thalamus is a deep-seated region, and it is connected to almost all the regions of the brain, and it controls important functions. So as you see here, the anterior, lateral, and the posterior, the pulvinar, are the most important aspects of the thalamus. There is a medial nuclei also, and if you see the gross anatomy, the ventrolateral surface of the thalamus is the most important because it is connected to the internal capsule. As you see, the corticosonic tract, the anterior limb of the internal capsule is closely in connection with the thalamus. And obviously, it is on the left side. If you see, this is a schematic diagram which shows how the thalamus is connected very deeply to the deeper nuclei, the brainstem and the basal ganglia, to the frontal cortices, and it is important. It also controls memory, language, consciousness, and conjugate eye control. So the surgery in this region and challenge. These are the functions of the thalamus. You can see how it is almost concerned with it's a relay center, but it is concerned with almost all the functions of the brain. Also concerned with the memory, the emotion, language, speech, and hence tumors in this area become very challenging. Now, there could be something like thalamic intrinsic tumors and thalamic region tumors. They are often confused with tumors in the basal ganglia or in the brainstem. But with better imaging now, definitely we can reasonably dissect basal ganglionic tumors away from the thalamic tumors as well as from the brainstem tumors. And hence, in the past, if you see, most of the literature had adult and pediatric mixed tumors. They were all thalamic region tumors, and hence the outcome was quite confusing. So we were not exactly what was going on. So the past limitations. Here, the thalamic tumors form about 0.84 to 0.5.2% of the brain tumor pathology. They form 15% of all the malignant tumors, and usually they are infiltrating. They are difficult to resect completely. They have high morbidity and mortality, and overall they have a poor prognosis. So these were the limitations that we carried on earlier. But now, what is the current knowledge? With advanced imaging and advances in surgical technique, now we can differentiate the intrinsic thalamic tumors and thalamic region tumors. There is a clear anatomical picture of deep-seated tumors with advances in imaging with the diffuse tensor imaging, and there is in surgical technology. We can radically, safely excise these tumors, low-grade tumors more than the high-grade tumors. We can also have some amount of adjuvant therapy as radiotherapy and chemotherapy are modest, but they could lead to some enhanced survival and good quality of life in certain situations. So overall, now if you see, Even in incompletely resected tumors, the 5-year survival rate is greater than 80%. So the paradigm change in the last 25 years has been quite huge. And obviously, these tumors are challenging, formidable, and you need to have a good understanding of the anatomy. So how do they present? Now, I have reviewed the recent literature, and most present with the motor deficits, because it is, as I told you, it is connected with the internal capsule. So motor deficits are more common. The patient just could come with heavy paralysis. And in addition, it could have a raised intracranial pressure, maybe associated hydrocephalus, which also would lead to which patients can come with altered sensorium, and they could have some sensory deficits and visual problems as well. So if you see the imaging features of thalamic tumors, usually they could be homogeneous, they could be heterogeneous, they could have calcification, they could have inhomogeneous enhancement, there could be cyst, there could be obviously hydrocephalus because of the obstruction of the third vessel. They can be confined to the thalamus, they can extend to the brainstem, basal ganglia, and they can go to the contralateral side as well. So overall, if you see, it's a mixed bag, and these tumors have a complete different morphology. So Stephanie Puja had classified these tumors into 3 types, and that classification has been carried on by several authors in the publications, and it's a quite a very practical classification that she has given. So it could be that the tumor is confined to unilaterally to one thalamus, or it could be thalamo-peduncular, or it could be biothalamic, and something what we know now, what has the new terminology, incidentalomas. I would deal with each one of them briefly so that we get a brief overview of this. So what are the adjuncts for optimal tumor excision? When we are now operating in the deep-seated region, we obviously, in a thalamic region tumor, we need to have DTI as a primary sequence, because it is very helpful. And as I will just show you some examples from the available literature, that how it enhances and shows us the surrounding structures, including the corticospinal tract and the optic tract as well. So this is all to prevent to decide the approach, as well as to prevent to have minimum mobility and deficits. We have the stereotactic navigation, which helps us to localize the tumor. We can use intraoperative neuro monitoring, and obviously ultrasonic aspirator, which helps us to prevent damage to the surrounding tissue. So surgical approach varies. Now, the thalamus is a centrally situated, and it could be approached from various angles. So there are anterior versus posterior approaches and the lateral approach. So the anterior is it could be through transcortical, transventricular, or it could be the in hemispheric transtellosal. And the posterior approaches are also transcortical, transventricular, usually in the tumors. And sometimes you can use the Stein's approach, but the Stein's approach could be used only for the tumor is situated within 1 centimeter extent. You get a better view if you approach it from the contralateral side. Now, the reason is that the basalment of Rosenthals are the limiting factors for the extended section. So a small tumors near the avenula or the medial aspect of the pulmonary nerve can be approached by the Stein's approach. But more or less, the lateral approaches are quite popular. You can use the subtemporal approach for the thalamo-peduncular tumors, especially the subtemporal approach, transventricular, transchoroidal, or the transilvian approach if the tumor extends laterally. So here are some examples of, I've taken it from the literature, I have these examples. So if there are unilateral thalamic tumors, it could be confined with a homogeneous tumor which is confined to the thalamus, and you can see here that this is a pilocytic astrocytoma, which is a low-grade tumor, could be completely excised by a transfrontal approach. Sometimes the margins can be poorly defined, and you could resect. It's a midline tumor. You could go resect only partially, and if suppose this, because of the margins are indistinct. So if the tumor progresses on observation, you could go second and remove the tumor completely. So this is the extent of resection determines the prognosis in such cases. Sometimes, if you in the imaging, if you know that that is a high-grade tumor and it is infiltrated tumor, deep seated tumor, where the surgical excision would be difficult, you could resort to a stereotactic biopsy to confirm the diagnosis and use adjuvant chemotherapy or radiotherapy in such the high-grade astrocytoma, where the adjuvant therapy kept the tumor under check, but the prognosis is poor in these cases. So this is a case of a 12-year-old girl which I had operated about a few years back, who had a short history. She came with headaches and facial weakness and left hemiparesis. And as you see, there is a large cyst in the thalamus, and it is projecting into the middle incisional space and quite close to the temporal horn. So I used the middle temporal gyrus approach. I evacuated the cyst and I did a subtotal excision of the solid tumor, because there was no clear plane for me at that time, and I was just not ready to give her the deficits. I hadn't done the DTI at that time. The report came as pilocytic astrocytoma. So she was a 12-year-old girl. I thought that this was the section after the first surgery. After 1 month, she was sent for radiation. She completed her radiation, and after a month, she came with this tumor. So this was obviously a recurrence, and I had to go in the second time, and then I removed this to the same approach. I removed the posterior enhancing lesion, and the second surgery was relatively easy because there was the corridor which I had from the first surgery. And this is a patient who had residual hemiparesis for a few weeks, and she improved completely after 2 or 3 months, and she's now well. I have a follow-up about five years. Although it was a thalamic pilocytic astrocytoma, the prognosis is relatively good if the excision is done completely. So I don't know whether I should have resorted to radiation at that time or not. Since it was a myxoid component, the radiation oncologist advised for the radiation treatment. So here, if you see that this tumor is coming into the pulvinar region posteriorly, and you can easily use the Stein's approach and remove this tumor completely. Sometimes if you know that this is a high-grade GBM, and you could use a transventricular approach from posterior. But in these cases, you might give a new hemianopia to the patient after surgery. Thalamo-peduncular tumors, they arise at the junction of the inferior thalamus and cerebropeduncle, and again, they present with a progressive spastic hemiparesis. Preoperative tractography is extremely useful in this case. Low-grade gliomas, gross total resection results in a cure. The injury to the most important structures, the corticospinal tract, the optimal or the optic nerve, has proven challenging in these tumors. And in cases of there are high-grade lesions, the chemotherapy and radiotherapy has been used to treat this lesion where it's in close contact with the encephalon. Here you can see some examples of the thalamo-peduncular tumors, that they could be a solid tumor, it could be a cyst solid, or they could be a huge tumor which is encroaching into the middle incisional space and the brainstem and projecting laterally. So here there are some examples where you can see that the DTI is very important to know the position of the thalamus and the corticospinal tract. For example, here the optic tract is deviated superiorly and lateral to the tumor. You can see here the arrow, and the tumor is pushing the aspect of the peduncle underneath the thalamus. So normal thalamus is pushed posteriorly. Now here, since the tumor is, the optic tract is superior and lateral to the tumor, and the corticospinal tract is deviated anteriorly and laterally, you cannot come from anterior, you cannot come from posterior. In this case, the only approach that you can have is a middle temporal gyrus approach, where you could approach the tumor posterior to the corticospinal tract. So the DTI gives you relevant information about the important structures in the vicinity. Similarly, if you see that here, the corticospinal tract is passing through the tumor, and that is beautifully demonstrated by the diffuse tensor imaging. And in this case, there is the corticospinal tracts are disrupted, and there is a high chance that you might injure the worsen the hemiparesis. So you need to be careful when you approach these tumors from the anterior route. Here in this case, if you see the corticospinal tracts are displaced medial to the tumor. If the corticospinal tracts are displaced medial, you can have a lateral approach and come from the middle temporal gyrus. Again, if the displacement of the thalamus is anterior and posterior to the tumor, sometimes it is anterior as well as posterior to the tumor, and the corticospinal tracts are draped around the tumor. Here, again, coming from medial, from posterior or lateral is not possible. So here you can have to resort to a transfrontal corticotomy and resect the tumor. Bithalamic tumors, as you know, they are formidable. You cannot operate them, resect them completely. So these are inoperable tumors. So apart from diagnostic biopsy, there is hardly that we can offer. If they cause hydrocephalus, we can do some form of CSF diversion. They are less responsive to radiotherapy and chemotherapy. Consequently, they have a poor outcome. Some papers in the literature say that they have some patients who have bithalamic tumors who have had a considerable survival, but the ultimate prognosis remains uncertain. There are frequent the midline tumors, as just Dr. Sinma had mentioned about the various molecular markers, but the molecular markers of BRAF 600 EVE and the KI1549 are not usually seen in thalamic tumors. Most of the thalamic tumors have the rare H3K27 mutations and frequent EGFR mutations. So these are more common in thalamic tumors, and they are a possible risk factor for malignant transformation. And they have they have a potential sensitivity to targeted kinase inhibition, but the response still it is in infancy. So the reason is that this kind of tumors, they display the histology is quite variable, and they could have the PXA type, the pilocytic type, or ependymal type morphology. So here the diagnostic biopsy is important in bithalamic tumors. Even though, because we need to know the H3K27 mutation, we have to correlate with the histology. So it could be used for research purposes as well. So bithalamic tumors, we have very little to offer. There is something like pediatric thalamic incidentallomas. Now, because we are using MR imaging, and the modern neuroimaging is quite frequently done for many non-tumoral reasons. So we can detect incidental thalamic lesions. Thalamic lesions could be either low grade or high grade. So what do we do in such cases? There is an incidental thalamic lesion which is detected. So the conclusion, there was a paper which was recently published in Journal of Neurosurgery, and it was an 8-center publication where the results were pooled. There were 58 patients of incidentallomas. In some patients, they were about which 47 patients were followed up and 11 patients were operated. And they could find that there is a mix of low-grade and high-grade tumors. So the reason is that since these patients could be diagnosed for unrelated conditions, so it could be unrelated headaches, seizures, trauma-related, or some endocrine dysfunction. They have a mixed bag of low-grade and high-grade. So the reason that the incidentallomas need to be closely monitored. So in some patients, they require upfront surgery, some patients they require to be closely monitored. So not each and every patient need to be operated. So as I mentioned, the conclusion that the study gave was that a close and long-term radiological follow-up is warranted in patients who do not need immediate surgery, because tumor progression can occur. So now, incidentally, if we have detected something, we need to follow them up and not send them off because they are not related to the present condition which they are presented with. So also we might get some more knowledge about the histopathology and molecular profile if we biopsy or these tumors to detect any malignant transformation. Hydrocephalus is very common. So hydrocephalus it can be caused by the obstruction of the posterior ventricle of the foramen Monro. Also obstructs the hydrocephalus. The other causes for hydrocephalus could be that there could be a bleed in the tumor, or that it could be post-surgical or it could be related to the infection or dissemination. These are the other causes of hydrocephalus. And the hydrocephalus is a significant component of thalamic tumors. So they have a significant cause of morbidity. You can resort to either ETV with septostomy. At the same time, sometimes you can do a biopsy of the tumor also, or sometimes if ETV is not possible or some reason ETV is not possible in a particular center, a VP shunt is also quite good. What about the adjuvant therapy in thalamic tumors? So chemotherapy is primary treatment for non-surgical patients with low-grade glioma. Low-grade glioma, the treatment is usually surgical. If you, for some reason, if you want to postpone or omit radiotherapy, you can give chemotherapy. In small children and infants, where radiotherapy cannot be given, you want to delay surgery or replace the radiation therapy, it can be given. Low-grade gliomas that undergo incomplete resection or there is evidence of progression and surgery is not being offered for some reason, chemotherapy can be given, but the results with chemotherapy are modest. High radiation therapy is given for high-grade tumors independently of the extent of resection. Morbidity and mortality in thalamic tumors. So obviously these are deep-seated tumors. They come with their own bag of problems. So anterior approaches usually are a certain, especially on the dominant side, have a risk of aphasia. There could be a new hemiparesis or gaze palsies. Pulvinar is a source for speech disturbances, and because it is connected with the language centers. There could be a frontal lobe-like syndrome which can disturb the state of consciousness as well, because the anterior and the central thalamic nuclei are very susceptible to ischemia. The posterior approaches, when we go transventricular, you could disrupt the optic radiation, or it could since the fornices drape the thalama, you can have a memory issues. Largely, posterior approaches are favored more than the anterior approaches because the deficits seem to be a less problem in the posterior approaches. The long-term outcome, as Dr. Shimony just mentioned in the previous talk, that in no way that the patient can be worse than what he came for. So, although the pendulum has swung towards radical excision in thalamic tumors, it has to be accompanied by functional realization. The histology of the infiltrating tumor determines the prognosis, and if we know that there is invasion of pyramidal tract or brainstem, that's actually a negative criterion for surgical resection. Gross total resection has unequally proven to have better survival rate for lower grade tumors, and most patients need VP shunt for hydrocephalus. Long-term follow-up, recurrence, and dissemination even after successful resection have been reported for these tumors. So these are the references. I'm very glad I've referred to Professor extensively in this talk because they're quite informative and educative. And recently, in 2021, Renedo have given a very good brief review of thalamic tumors in children, and they conform to the same conclusions that I've mentioned. Thank you very much.
Thank you very much, Professor Muzumdar, for that fantastic talk on this complex area and your insightful comments. I just want to get Dr. Boop and if Dr. Jallo is there to give their comments. Thank you, Dr. Boop, first.
I think that was a great overview of the thalamic tumors. I don't really have much to say in addition to what he's already said. I do think the H3K histone mutated tumors are no longer a surgical tumor. And so if we do a biopsy or we do a partial resection and we see that marker, we know the prognosis is poor and those patients will do best with radiation and maybe chemotherapy, but it's no longer a surgical disease in most cases.
Thank you. Dr. Jallo, are you there? Let me just, there's a question for you, Professor Muzumdar from Dr. Jacinta Francis.
Yeah, there is the role for a definite role for targeted therapies, as I mentioned, Dr. Jallo, you want to comment?
That's okay, Prof. You can talk, then Dr. Jallo can.
Yeah. Yeah, so the role of targeted therapies in thalamic tumors is still modest. And as I just mentioned, the EGFR mutation is more, and the X3K27 mutation is more rampant than other astrocytomas elsewhere seen, as we mentioned, in the optic-chiasmal region or the posterior fossa. So there are targeted therapies which have been missing, but the results are not that robust. So we are awaiting the further information on this.
Thank you. Dr. Jallo, do you want to make any comments? Thanks.
I think that was an excellent presentation. I think, I think for us, just learning about, the approaches as well as the options for these, it was excellent, Dr. Datta. Thank you for sharing your experience.
Thank you very much. Thank you very much, Professor Muzumdar. Thank you, Dr. Jallo.
Thank you. Thank you.
Thanks. So we will move to the next lecture. It's from Dr. Lissa Baird. Dr. Lissa Baird is the lead for oncology, or in terms of neurosurgical oncology at the Boston Children's Hospital, and she also has got interest in vascular neurosurgery as well. And it's a real honor to have her, and we look forward to her lecture on DIPG, which is always a hot topic. Thank you, Dr. Baird. Cheers. Oh, sorry. You have to unmute, Dr. Baird. Yeah.
Thanks for having me. And it's an honor to be here and learn from all of you, and also speak a little bit. So I want to thank Naren for the invitation. And I'll try to go over some of the fundamentals of this very large topic in a short period of time. It is a topic that has kind of reached a period, I think, in our specialty where things are finally starting to evolve a little bit. So there are some interesting things going on, and I think a little bit more hope on the horizon for what has long been a very dismal prognosis for these children. So I have no disclosures. Population data that was released in 2014 revealed that brain cancer had surpassed all other cancers as the leading cause of death, as we all know. And some of that was an improvement in our treatments of leukemias, but it leads us to the situation where brain tumors are now the #1 cause of cancer death in children. And if you take a step back and look at all death in children, cancer death is the third most common cause, period, after firearms and motor vehicle accidents. And interestingly, it is the second most common cause in the age range where DIPG has the highest incidence. Of brain tumors that are now the main cause of childhood cancer death, high-grade gliomas are the main cause of death in children with brain tumors. So I think this is an important statistic, just to kind of take a step back and realize that this is a disease that really deserves the attention and resources of the medical and research community, and should really be a priority when we are trying to reduce medically related mortality in children. So pediatric high-grade gliomas has about a 1 in 100,000 incidence. There are about 20,000 cases worldwide. And of those high-grade gliomas, about half of them are DIPG. It's a diagnosis that is nearly exclusive in children. There are rare cases that have been seen in adults, but we almost universally see this diagnosis in kids. The peak incidence, as I mentioned, is between the ages of 5 to 9 years. And it accounts for about 10% of all pediatric brain tumors. As we know, the prognosis is very dismal. The classic clinical onset happens very quickly. Usually children present having had symptoms for less than a month. and they are most commonly related to cranial nerves and motor function. These tumors progress quickly, and it's usually makes it even more challenging when you're having these conversations with families, because it was only a very short while ago that their child was completely asymptomatic and just a normal, happy playing child. So these always come as a great shock with very rapid onset. So the management and outcome for these tumors really has not made any clinically significant progress in decades. Historically, these have been diagnosed based on clinical history and MRI imaging alone. DIPG technically is a radiographic diagnosis, and it is diagnosed by having a tumor core that is centered in the pons. At presentation, that tumor needs to occupy greater than 50% of the axial diameter of the pons. It commonly engulfs the basilar artery, which is a common radiographic indicator that points towards this diagnosis. And rarely metastasizes. They can grow along the fiber tracts to adjacent structures, but they don't tend to have distant metastases, as we can sometimes see with other types of gliomas. Gadolinium is variable. Most of these do not enhance at the time of presentation, but then later on as they progress, we'll pick up areas of enhancement, but there is some variability to that. So one of the reasons that there has been hesitation to biopsy these tumors is because it wasn't really needed for the diagnosis, and it didn't affect the management, and they had such a poor prognosis that it wasn't really felt that they needed anything other than that radiographic diagnosis. The prognosis data that we have right now is mean survival is about 9 months. The 2-year survival is 10%. And then it significantly drops off. 5-year survival, 5%, and long-term survival, less than 1%. And I think most of us would recognize now that those rare patients that have had long-term survival into adulthood probably did not have what we now consider these DMGs. But to the biopsy, yeah, there was no advantage for a long time. And I think this still remains a little bit controversial. To put these children through a biopsy, because it didn't change their outcome, it didn't change their treatment options, it didn't change their diagnosis. Standard treatment that still has not changed over the past decades continues to be radiation therapy. And radiation therapy will increase median survival by a modest amount, but mostly it improves their symptoms and therefore their quality of life. So these children go through about a 6-week period of receiving focal fractionated radiation, and they usually get a total of about 54 gray. And there's a little bit of data to support reirradiation as something that's effective at the first sign of tumor progression. And that, in this paper that I've noted here, has led to clinical improvement in about 80% of those patients. And again, a very modest survival benefit to about 13.7 months. And that survival benefit was mainly seen in the children who were able to go for a longer interval until they had clinical and radiographic progression. So if they were able to have an interval of about 6 months between their 2 radiation treatment periods, they were more likely to have a survival benefit with reirradiation. I put this slide up here as the side effects that we all worry about when young children are radiated, the secondary malignancy, endocrinopathies, the cognitive issues, and the vasculopathy problems. This has not been something that is really taken into a lot of consideration with this disease because of its very poor prognosis. And it may be something moving forward, if we are able to make strides with this disease, that may become more relevant as we think about long-term risk, especially with reirradiation. So outside of radiation therapy, we only have experimental treatments. And there have been about 300 clinical trials that have included treating DIPG, and all of them have failed to significantly change the prognosis. So why have these trials failed? It is probably a combination of reasons. the drugs may have been ineffective. They aren't getting into the tumor and crossing the blood-brain barrier, which we all recognize is a significant challenge with intracranial tumors. They may not be staying in the tumor at therapeutic concentrations, but ultimately, I think we have just had a very poor understanding of the biology of this disease up until recent years. And historically, all of these trials have been based on adult glioblastoma data. And they were originally thought to be high-grade tumors. They must be similar. But as we have learned, these tumors are very, very unique to adult GBMs and need to be managed differently. So that kind of leads us to where we are now in understanding the molecular biology of these tumors. This is a huge focus in our field right now. The last decade has dramatically changed our understanding of pediatric high-grade glioma with all of the genomic and epigenomic profiling we've been able to do. And we've been able to identify molecular drivers of many subtypes of tumors, not just in high-grade gliomas, but in many other types as well. And that allows us to try to develop subtype-specific therapies. So the use of these more targeted therapies really has the potential, I think, to improve survival in this patient population. And it's not something that we have seen yet, but we certainly have made strides in that direction. These treatments have the potential to have greater efficacy with less systemic toxicity. And we're seeing more and more that the clinical trials available to these patients are using treatment paradigms that incorporate the molecular characterization of the tumor and really try to be more specific at using what we know of the biology to drive our management. There have been both successes and disappointments, I think, with the targeted therapies, but we've seen enough of the successes and the outliers to really know that it's a strategy that we can probably optimize. What we don't know is kind of long-term, even with the patients that have had good success, we don't know the impact of keeping them on these targeted therapies for long periods of time, and we don't know how long they need to be on it. So many challenges to work out in this area, but something that, again, we're making progress on. This was a study that looked at a very large volume of tissue samples put out by Chris Jones' group that revealed a really diverse set of clinical and biologic subgroups in high-grade gliomas. They looked at an analysis of over 1,000 samples, and were able to demonstrate that some of these histone mutations will co-segregate with distinct alterations in their downstream pathways, and that the histone wild-type tumors are really more likely, not always, but more likely to resemble low-grade lesions. Also noted a very slight difference between the overall survival in the DIPGs and the thalamic midline tumors, 11 months to 14 months. So the thalamic tumors do tend to do a little bit better. But you can see on this survival curve in the center here, how the overall survival really does cluster with these histone subgroups quite well. So this also leads us to this new kind of move towards a change in our diagnostic classification of high-grade gliomas. And the nomenclature, I think, has changed enough over the last few years that it can become confusing, but we refer to many of these now as DMGs, diffuse midline gliomas. One of the really important differences is that DMG is classically a tissue diagnosis rather than a radiographic diagnosis. And it can be a glioma in any midline structure, so the thalamus, brainstem, and even the spinal cord. And DIPG really is a subtype of DMG for the tumors that are centered in the pons. So what we know of DMGs is that their behavior and prognosis are driven by histone mutations. The H3K27M mutation is found in at least 60% of GMGs. It has been reported in the literature that it's in over 80% of DIPGs, and that number is probably higher, maybe not specifically for the H3K27M mutation, but at least for alterations in that gene. Some of the initial data was taken from cadaveric autopsy specimens, and some of the treatment effects will cause that histone alteration to be lost in analysis. So that number really is probably something we're going to see go up as far as the proportion of H3K27M alterations in those tumors. And then the WHO classification guidelines that came out in 2021 changed these classifications again just a little bit. So we now break them down to either DMG, H3K27M altered, or wild type. And that was changed from mutated to altered because we are recognizing that there can be other variants of the mutation, and there can be methylation changes and other things that will keep them in that behavioral category. So the identification of these histone alterations has really allowed us to create these pediatric high-grade glioma molecular subgroups that cluster in both anatomic location and prognosis. This really was a very key discovery illustrating the unique biology of these tumors. We don't really see this in adult high-grade tumors, occasionally again, but it's very rare. This is primarily a childhood type of alteration and a young childhood type. And that probably relates to the oncogenic changes in the progenitor cells that originate early in neurodevelopment, which makes sense if you think about the function of histones with our DNA, which we'll talk about a little bit. It also has uncovered potential targets in the related pathways that really will hopefully lead to new treatment options for these patients. So histones, these are the proteins that the DNA winds around. They're critical for gene transcription. An alteration in the histone, the H3 histone tail, can lead to global epigenetic changes in the histone structure that can lead to turning on tumorigenic genes, to silencing tumor suppressor genes, and ultimately can make these cells tumorigenic. And while the H3K27M is most common, there are other variants that we see. So these variants, again, tend to cluster both anatomically and prognostically. There also can be variants in the methylation patterns, as I mentioned. And they also have a clustering of oncogenic drivers. And these aren't universal clusterings, but they do tend to follow the H3 category. So for instance, in the ACVR1 mutations, we've identified in about 30% of DIPGs, these tend to co-segregate with the H3.1 histone alterations. And that mutation will usually facilitate earlier tumor progression, but it's a good potential therapeutic target. The TP53 mutations have been identified in up to 40% of DIPGs. These frequently co-occur with PDGFR amplification, which is another potential target. So some of these secondary mutations hold targetable promise in these categories of histone variants. So back to the diagnosis. Having had this improved understanding about the molecular landscape of these tumors, it really brings us back to this question of, should we be biopsying these patients? And I think people still feel very strongly about this one way or the other. It is our practice here at Boston Children's to recommend biopsy for these tumors. And when talking to families and talking about why might this be worth it, especially given the standard of treatment really has not changed, I think there are a few reasons. One is it is worthwhile, I believe, to know if it is a DMG and if it has this histone mutation. Up to 30% of the atypical DIPGs do not end up being DMGs. So I've shown an image here that's an example of a very classic typical DIPG. But as we know, there are variants that frequently will be diagnosed as DIPG because they meet the criteria, but on tissue analysis end up being something different. So I think that is worth knowing. It potentially can change the treatment quite significantly. And it also can influence the prognosis, and those patients have different outcomes. So another reason is to potentially find other genetic alterations that may be targetable. And they may be targetable up front. It may be that it's something that down the road, there may be something in development that hopefully a trial will open for that family. But it is sometimes good to know that up front, see if there is something that is potentially there. So we might treat the child differently, and there may be a different diagnosis. And it may also make them eligible for specific clinical trials. So there are many clinical trials for DIPG now that require diagnosis because of the way we are designing these in a smarter fashion, hopefully. Also, the phase 0 clinical trial concept. I think one of the big questions and challenges we have with these tumors is knowing whether or not the drug is getting to the tumor. And so there is probably going to be an increase in seeing this phase 0 component to clinical trials, where we will enroll the patient, give them a dose of the drug, then they undergo the biopsy, and then part of that analysis includes assessing for the drug concentration in the tissue, which will hopefully give us some helpful information. So as far as performing these biopsies, this was a study that was put out in 2018 that many of us were a part of, that was primarily run by Nalan Gupta at UCSF and Mark Krieger here, and looking at the safety of biopsying DIPG. So it was a prospective multi-institutional study, looked at 53 patients, and the results ultimately were that 92% were diagnostic as far as the sample. And there was one patient that had a permanent deficit, which was a hemiparesis. And there were 2 other patients that had transient deficits. But only one patient was left with a permanent deficit. So it's not risk-free, as we all can imagine, but it is reasonably safe, and I think in many cases worthwhile. So I just throw this in here as an example of a patient who probably was not, almost certainly was not, a histone mutated DMG, but had an imaging diagnosis of DIPG. So this was a patient of mine who presented at 3 years of age, very classic presentation with cranial neuropathies, and underwent standard therapy. And she is now 7 years from diagnosis and has been very stable and is doing very well. And I think the likelihood that this is a true DMG, and she's never been biopsied, but it's very, very low. And, you know, it really changes these families' approach to things when they hear the prognosis for these tumors. They frequently will pull their kids out of school, or, you know, start focusing on the few months they have and things they can do with their child. And if we have a little bit better prognostic information, I think it can really help guide families and give them hope in situations where that may be warranted. And probably would have been the case with that child. The DIPG biopsies are performed through a paramedian burr hole, small incision. They are needle biopsies that go through the peduncle of the tumor and target the lateral aspect of the tumor using navigation. This is an example here up at the top of an atypical pontine tumor that radiographically would have been diagnosed as a DIPG, but I think we can all recognize that there are some atypical features there, kind of some loculation of tissue. That patient underwent a biopsy, and the diagnosis was a neuroepithelial tumor. So very different treatment from high-grade glioma. And that patient ended up having a partial tumor subtotal resection and chemotherapy, and is about 8 years out now and doing very well. So treated very differently than they would have been without the biopsy. So I think especially in atypical DIPGs, it's a very important thing to do. So the information we have gained from these biopsies has really been the critical factor in the explosion of information we have on DIPG that we've seen in the last decade. Again, we're getting smarter about designing these trials. I think, you know, after this 300 clinical trial failure list, our current trials are probably the most promising that we've seen. They're all very early phase, but they are more promising than we've seen before. There are different categories of trials, epigenetic therapies, convection-enhanced delivery. We've seen panobinostat phase 1 trial for that, and phase 2 trial will probably be starting soon. Molecular targeted therapies, many immunotherapies that I'll talk about just a bit more, and some alternative things like focused ultrasound. So lots of things that people are continuing to try with these trials. And I think one of the most important aspects of treating these children is really collaborations within our specialty. And these are so important, as I'm sure you all recognize. These are some of the major consortiums that we run clinical trials through, and many of them are focused on DiPG. And it really is the best way to really bring together the expertise in our specialty and power trials with enough patient volume to see statistical change and be able to make good decisions moving forward. So some of the immunomodulatory therapies, there are vaccine trials. We've yet to see really significant results with these trials, but there are some that are promising, especially the dendritic cell vaccines, and there are several trials open here. The antigen vaccines have really not been quite as efficacious at this point. And one of them was recently stopped because of significant pons edema. So that is one challenge with the immunotherapy options. CAR T-cell therapy, which really had modest success, or good success, excuse me, with the leukemias. We've really only seen modest success, but it is something where I think there is some promise. This is kind of teaching our immune cells to target the tumor, and something that we will probably, with some of the advances, technically become better at. The next generation CAR T cells really should be able to target multiple antigens, and the preclinical models I think are quite promising. So some of the future goals and challenges. One thing I didn't mention is looking at liquid biopsies. So liquid biopsy is kind of a in vogue topic with these tumors. It's challenging to know if a tumor is responding sometimes just based on the imaging, especially with these brainstem tumors. And being able to track that with cell-free circulating tumor DNA in either the serum or the CSF would be really helpful, and also avoid the impractical need to rebiopsy these patients. Also knowing if there is early recurrence or things like that, and eventually hopefully being able to completely avoid the risk of the biopsy if we are able to improve the liquid biopsy enough to make an accurate diagnosis. This is not currently used outside the research setting, and the problem is kind of looking for a needle in a haystack problem. The signal really needs to be amplified greater than it currently can be for this to be more accurate. Drug screening, as we know that this is something where there's high cost and slow pace for new drug development and discovery. And so there are new technologies looking at large scale drug screenings, hoping that we can repurpose some old drugs that will work in some of these pathways. I think we're seeing an improvement in our preclinical models, especially with some of the organoid models. There's some really fascinating work being done there that I think will help us with this disease. And ultimately expanding our clinical trial and translational work based on our ever improving understanding of the underlying molecular mechanisms of this tumor is hopefully going to lead us to a place where we really can have better options to offer these children. So thank you again, and happy to answer any questions.
Thank you very much, Dr. Baird.
Lissa, it's George Jallo. What percentage of kids do you biopsy with with these diffuse midline tumors, whether it be in the pons or in the thalamus?
I would say for the thalamic tumors, it's 100%. All of those patients get biopsied. For the pontine tumors, I think that number has been steadily increasing. And right now, just as a guess, it's probably close to 80% of them, maybe 90%.
And then and how many biopsies, you've got the single path trajectory. How many biopsies do you usually take, needle biopsies, cores?
At least 4, sometimes 6, and they need to be good cores. I think you try to target the periphery where the tumor cell density is probably a little bit lower. And one thing we always do is we'll take the 4 cores and then we will stop and go look at them with pathology and make sure that the tissue looks diagnostic. And if there's a question, then we may take a deeper core or take an extra.
Great. Thank you.
So that was a beautiful talk. You just said something that I think is very important. In the previous WHO classification of these tumors, the cellularity was important. And so the oncologist would ask us to biopsy the most malignant portion of the brainstem tumors, which is also the area that's most likely to hemorrhage or cause complications. In the new WHO classification, cellularity doesn't matter. It's all the molecular profile. And the point you made about biopsying the less cellular periphery of the tumor being much safer, I think is worth noting. Thanks for a great talk. That was beautiful.
Well, thank you. Yeah, and totally agree. Thanks.
Okay. Thank you very much, Dr. Baird. And if anyone has any questions, could you please put the questions to Dr. Baird on the chat box. Thank you very much again for that great talk on a very important topic. Thanks. So this now brings to Dr. George Jallo. As I mentioned earlier, Dr. George Jallo does not need an introduction to the pediatric neurosurgery community. About a couple of years ago, 2 years ago, he, with his co-authors, produced the definitive book on pediatric brainstem tumors. So here, Dr. Jallo is going to talk to us about brainstem tumors that are not diffuse midline. Thank you, sir. Cheers.
Thank you, Nir, and that was a great talk that Lissa gave. So I will just focus on the, I guess we'll call the non-diffuse midline or the non-DIPG tumors. And we want to just start off with this case. And really, this is a 3-year-old boy that presented with a very short history of gait imbalance and a 6th nerve palsy. And this was the MRI, the sagittal T1 with contrast. And you can see the axial images there as well as the coronal flare sequence. And I think, the question is really that comes up is, this is not, it's situated in the pons. It does not look like, it does not appear to be a diffuse tumor. So, the options are, 1, observation. I don't think that's a good approach. 2, does one do a needle biopsy, or does one approach it with the intent of doing a more radical resection for this tumor? Or 3, just treat it with radiation and or chemotherapy without obtaining tissue. And I think those are all reasonable approaches. Curious to see, what the approaches are. Elected to rather than just do a needle biopsy, looking at this tumor felt that we would approach it with an attempt to debug or radically remove as much of it as safely possible with neurophysiological monitoring. And that's, let's see if I can get that to move. And that's what we did. And I think we approached it through the middle cerebellar peduncle using a tubular device, whether it was the VIPE or the brain path. And surprisingly, the pathology returned as the embryonal tumor with multi-layered rosettes. I think I was thinking it was going to be more of more of the higher grade astrocytoma family, but this was the tumor falling into your primitive, what would have probably been previously called a primitive neuroectodermal tumor. And you can see the post-operative images there. Post-operatively, he had no new deficits, still had his 6th nerve palsy, and really did not even develop a new facial following surgery, and then went on to receive the adjuvant chemotherapy and radiation therapy. So I think looking at this, I think it's critical to talk about the anatomy when one considers these tumors in the brainstem, and really looking at the midbrain, the pons, and the medulla. And it is a very small area in both lengths and width, measuring at 6 by 3.5 centimeters wide. However, it's a highly complex area with the neural structures. And when we look at this, we're looking at the midbrain, the pons, as well as the medulla, and looking at all the important structures as well as relay structures that are coordinated through this area. I think it's critical to have a good understanding before any recommendations. I think what we got it going back on a little background, recognizing that when we look at tumors in this area, the brainstem really only comprises about less than 5% of all tumors in children less than 19. However, it comprises about 14–15% of tumors in children from 0 to 14 years of age. And I think, again, as Naren recommended that book, I do want to just, honor Jim Goodrich, who did write the history of brainstem glioma surgery as the first chapter in our book with Nir Shimony, just on brainstem tumors. And I think if I don't think you have to read this whole book on brainstem tumors, but if there's any chapter that you want to read, it's probably the history of brainstem glioma surgery that Jim wrote prior to his death in 2020. And just some thoughts about it. I think, Lissa did mention it. It's really, unless some effective treatment other than surgery is devised for brainstem, it's really a hopeless problem for treatment. That was the early 30s and as late as 70s. Regardless of this histology, they must be all considered as malignant tumors since the location in itself renders them inoperable. However, surgery was, first introduced in the early 60s by both Alvesi and Poole, and then it wasn't until the advent of CT in the 70s and then MRI that both Harold Hoffman in Toronto and Fred Epstein in New York, classified these tumors of the brainstem and recognized that not all brainstem tumors are alike, and some may benefit from surgery. And I think when we look at this, I think this cartoon depicts it, that you can have tumors that could be vascular malformations, inflammatory lesions, as well as infectious lesions that can occur in the brainstem, and one must be aware of that. And I think looking at the classification schemes, one has to recognize that not all brainstem tumors are alike, and some are amenable to surgery and may benefit from surgery. And here's artist's rendition of this, and looking at the classification schemes from the 80s all the way up to the early 2000s. I think probably the best classification scheme was in 1990 from the radiological literature, basing upon the location in the brainstem, whether it's focal or diffuse, the direction and extent of growth, the degree of brainstem enlargement, evidence of hydrocephalus or absence of hemorrhage or necrosis. And I think really today, it's really now you've got the anatomical or radiographic classification and the WHO classification, where we've come up with the best solution for these. And we've had several modifications, as Lissa has mentioned, from 2007, looking at these tumors. I think what I want to do, just focus on, is on these focal tumors, which really typically present with slow progression of symptoms, headache, vomiting, lethargy, typically raised intracranial pressure, sometimes focal cranial nerve deficits, depending upon the location, and can require an extensive medical evaluation and that hydrocephalus. MRI is the gold standard, and sometimes DTI sequences. Looking at these tumors, I think, when we break it down, midbrain tumors are your tectal tumors, your aqueductal tumors, purely aqueductal tumors, and then your tegmental tumors, your pons tumors, majority of which are going to be your diffuse. But as I did share, you can have isolated focal tumors in the pons, and then your medullary tumors, which could be dorsal exophytic, circummedullary, or focal intrinsic tumors in that location. And I think it's sometimes the key is identifying the location in relation to the brainstem nuclei in the tract. Sometimes it's helpful to have DTI and understanding the safe entry zones. And then understanding, is there an oncological meaning for surgical resection outside of these diffuse tumors? Here's an example of a tectal glioma that presented with obstructive hydrocephalus. Here's, as you can see here, and management was just an endoscopic third ventriculostomy. Here's another tumor within the aqueduct, and you can see that the tectal plate is indeed intact. And this turned out to be an ependymoma in the midbrain following surgery and removal. And you can see after the reconstitution of the aqueduct. Here's another focal midbrain tumor. You can see this more closer to the corticospinal tract. And you can see after a anterior, more of a, rather than just a lateral approach, but more of an approach from superiorly and superlateral approach to this, and the resection of this pilocytic tumor. This is of a focal medullary intrinsic ganglioglioma following the resection of this tumor as well. I think it's critical to use a diffusion tensor imaging to help locate the, which way your corticospinal tracts are going to be displaced, because sometimes the shortest way is not always the best one to approach these tumors. And really the key is to finding the approach to the tumor that will leave the patient with the least amount of deficits. And I think, the question that was brought up was to biopsy or not. And I think, it's critical that even for these focal tumors, sometimes it's reasonable to do a biopsy before proceeding with a resection. And, I think it was shared by Lissa, the biopsy profile for these diffuse tumors. This is a recent paper looking at the diagnostic and safety of stereotactic biopsy in pediatric brainstem tumors with the meta-analysis in 700 plus cases. And really looking at the more permanent morbidity is less than 1%, and diagnostic success is over 95%. And I think, I do want to say that there's several approaches. One can do a transfrontal approach, avoiding the ventricle, to do a brainstem biopsy, or one can do a more direct approach, and you do a transcerebellar through the peduncle to approach the brainstem for these. Moving on, I think, the question is, can you do brainstem surgery without neuromonitoring? I think, it's really, it helps level the playing field and try to avoid the landmines. I think in terms of neurophysiological monitoring, you can do direct stimulation of the floor of the brainstem, as well as intraoperative monitoring to help monitor the corticospinal tracts during the resection, as well as the brainstem auditory evokes and the nuclei. I think it's critical where neuromonitoring will, for these intrinsic tumors, will help guide the entry into the brainstem, as well as for some tumors, it helps guide the extent of the resection. It helps you stop the resection before injuring the cranial nerve nuclei, as seen here in this illustration. Looking at this, I think when we look at cranial nerve monitoring, I think for the midbrain, really looking at, you're looking for the oculomotor nerve nuclei at the level of the tectal plate, as well as corticospinal tract, and monitoring both motor evoked potentials as well as brainstem auditory evoked potentials. At the level of the pons, for these pontine tumors, you can map the facial folliculus in the floor of the fourth ventricle. One can monitor free-run EMGs as well as the facial motor evoked potentials. And for the lower brainstem in the medulla, one can monitor the lower cranial nerves 9 through 12, and can both map as well as monitor using free-run EMGs and monitor the corticobulbar MEP. And then there's some other monitoring techniques for the brainstem. You can see here some of the direct stimulation of the corticospinal tract in the cerebral peduncle during the resection of these tumors, as well as looking at the brainstem auditory potentials during the resection. I think it's critical to understand the surgical corridors during the resection of these tumors, knowing where the cranial nerve nuclei are, and knowing where the safe entry zones are. And I think, looking at this, looking at the midbrain of the pons and medulla, and it's been defined by many surgeons, many papers. I think in this table, it really defines where the entry zones are, both by location in the midbrain, the pons and the medulla. And I think, whether it's going to be an anterior approach, subtemporal, a retrosigmoid, or suboccipital approach, depending upon the location of the lesion. And I think in this table, I think try to define it by location here in the midbrain and the surgical approach. And when you look at it in terms of on the anatomical section, looking at the safe entry zones, both anteriorly as well as posteriorly for midbrain and laterally. Looking at the pons, here you can see the entry zones to enter, whether you're entering it through the floor of the fourth posteriorly, or if one's got a lateral approach to a pontine lesion. And then finally, looking at the floor of the fourth and entering it via the facial folliculi, or avoiding facial folliculi in the floor of the fourth, and then medulla via the anterior or the dorsal lateral, the dorsal approaches via the posterior median or the posterior intermedian sulci. Looking at this in this artist's depiction here. So I think, really, as I begin to try to summarize them, what can you use? You've got the microscope, the endoscope, you've got the exoscope, tubular retractors. I think there's no such thing as too many tools. And I think, does the extent of resection matter for some of these tumors, and why not just plan a biopsy? I think looking at pediatric brainstem tumors, this paper that was published in 2019, the conclusions were, looking at this, looking at a biopsy versus a more of a radical approach, that surgery yielded a more favorable outcome with patients receiving a more radical surgical resection rather than just a biopsy, with 1 year survivals closer to 97% as compared to less than 60%. And that held true at 5 years with more aggressive surgery for these brainstem tumors, especially given their focality. Again, we're talking about focal tumors rather than these diffuse tumors. And I think when we looked at this meta-analysis here of this, you can see even by, that by the age that the older children did do better than the younger children. And then in this recent paper that was just published last year, looking at the role of surgery for low-grade tumors of the brainstem, and they had a sample of close to 500, of which 236 were pediatric low-grade tumors. And what they did find in this study is when you looked at the pediatric low-grade tumors here, the overall survival was with surgical resection and adjuvant treatment was much better for the low-grade tumors using a gross total resection versus a less than a biopsy. I think it really does say that that in pediatric low-grade brainstem groups had the highest gross total resection rate and the most favorable clinical outcome, and that gross total resection can provide survival benefits for pediatric low-grade brainstem gliomas, as evident here. And I think just to conclude, just want to share this case of that you can see the films up there in 2013, underwent a needle biopsy. The histology returns to pilocytic. He underwent placement of EVD for hydrocephalus and then 7 days later required a ventricular peritoneal shunt. 2 weeks later, the cyst recurred, had another cyst aspiration, required another shunt revision, and the question was, what to do. He was having progressive symptoms and was now in a wheelchair at this time. Here he is. Here he is 3 months after surgery. And I apologize, I don't even have the films on there. Here he is after surgery. I don't show the film. And we did an aggressive resection of that, and we were able to achieve a near total resection. And he's been tumor. He's got a small residual, but has had no further adjuvant therapy, and he's completed his university studies. And I don't know why there it is. That's his follow-up imaging 5.5 years later without any further treatment. And you can see that there's a small residual, but he's out of the wheelchair. And if I can get this to play. And this was graduated college and everything like that. So again, I think there is a role for surgery there. And finally, I think here's another young boy that presented with, you can see the contrast enhanced studies. And you can see him, I'm not sure why it's not shown. You can see him post-operative 2 weeks after a radical resection. Here he is running, and there's his extraocular eye function as well as his facial function, hopefully. And there's the immediate postoperative film. There's a small residual there of the tumor. And here it is 2 years post-op, and there's some small residual right there, but no further adjuvant therapy. And he's just been followed for that. So I think really just to conclude, I think the key is understanding the tumors, consider maximal safe resection when feasible, more beneficial than just a biopsy, and that sometimes radiation therapy is helpful for the aggressive therapies. Thank you, Nir.
Thank you very much, Dr. Jallo. That's a very, very useful lecture on this complex tumor. Can I ask Dr. Boop to make any comments, observations, or questions? Thank you, Dr. Boop.
Well, thank you for asking. I don't really have much to add. That was a beautiful lecture and masterful surgery. I look forward to reading your book, George.
I'll have to send you one, Rick. Thank you.
That's great. And if anyone has any other questions to Dr. George Jallo, please put it on the chat box. So if that's okay, we will now move to the next lecture. It's from Professor Marek Madera. Professor Madera is the head of pediatric neurosurgery and pediatric professor at the University of Silesia in Katowice in Poland. He has got a very extensive craniopharyngiomas practice, and so it will be great to hear from him on transcranial approaches. Thank you, Professor Madera. Just you should be able to share your presentation. You need to unmute yourself, Dr. Madera. Great.
Okay, just a moment. I'm trying to do it. Moment. All right. Yeah, it's all right. Can you see it?
Yes, absolutely. Thanks.
Fine. Okay. So first of all, I would like to thank Naren for inviting me to give a talk on craniopharyngioma during the course. It's a great honor and pleasure for me. So thank you for this opportunity. By observing the history of craniopharyngioma treatment, we can see the competition between two approaches. The first, based on aggressive surgery with the aim of complete resection, and the second, more conservative one, with partial or subtotal resection of the tumor, supplemented plus with radiotherapy. In the 70s, Hoffman concluded his paper with a statement that conservative approaches become obsolete and that the expectation of cure, prevention of recurrence, and avoidance of the side effects of radiotherapy, due to these facts, total surgical resection is the treatment of choice. However, after 45 years, in 2013, Clark published a review of the literature on pediatric craniopharyngioma based on more than 100 papers and demonstrated no difference between in 1 or 5 year progression-free survival between the groups who underwent total resection or subtotal resection plus radiotherapy. The comparison of endocrinological deficits before and at follow-up after surgery showed clearly that the aggressive surgery for pediatric craniopharyngioma is associated with increased rates of anterior lobe and the metabolic dysfunction, what is clearly showed also in our experience of more than 50 patients. You see that the number of these deficits grew significantly after surgery at follow-up. So what we now know? Well, that not only no difference in 1 or 5 year progression-free survival between the groups who underwent gross total and subtotal resection plus radiotherapy exists, but also that aggressive resection can lead to increased postoperative neurological and endocrine deficits, and that quality of life following surgery is severely diminished by uncontrollable hyperphagia, obesity, and behavioral dysfunction. Moreover, even if the surgeon intends to achieve complete tumor resection, this goal is only possible in 50 to 79% of patients with craniopharyngioma. This is also confirmed by our experience with more than 101 patients, and we achieved 54% of complete tumor removal in our group of patients. So it's a half of the group, the complete tumor resection was obtained. There are three main obstacles to achieving gross total resection. The first two of them, significant calcification in relations to critical vessels, can be usually overcome. And here is an example of a big calcification like a stone, which makes it quite difficult to remove this part of the tumor between the optic nerve and carotid artery and branches, and you have to be very careful not to damage any of these structures. And maybe not involvement, but the neighborhood, very near neighborhood of the tumor to carotid artery and its branches, so Hoibner artery and posterior communicating artery. It sometimes makes also the tumor removal very difficult, however, possible. Hypothalamic involvement, however, is the most important obstacle to achieving gross total resection. So, accordingly, Stéphanie Pouget and the Paris group proposed a classification that may be helpful in choosing the optimal strategy. They based their algorithm on the degree of hypothalamic involvement with grade 0, where hypothalamus is not involved, grade 1, hypothalamus only displaced by the tumor, and grade 2 if hypothalamus is really involved by the tumor. And they recommended total tumor removal in patients grade 0 and grade 1, and in patients with grade 2, so if hypothalamus is involved, only then they recommended only partial resection with the preservation of hypothalamus. We find this algorithm very helpful and we use it in our practice. However, some doubts about this point of hypothalamus preservation exists, as what we precisely understand by hypothalamus sparing surgery and how much of the tumor can be removed without damaging the hypothalamus. And I think there is no answer for these questions. Anyway, in view of the above facts, our management of grade 2 craniopharyngiomas has changed since 2008 from total resection whenever possible to total resection if there is no hypothalamus involvement and partial resection if hypothalamus is involved. Of course, there are many potential approaches to the craniopharyngioma. I will skip the transsphenoidal approaches as they will be discussed in the next lecture and focus solely on the transcranial ones. Generally, we can divide them into the approaches from below, like pterional frontozygomatic, by pterional craniotomy or frontozygomatic craniotomy, and later frontolateral, and possibly if the tumor is growing to the third ventricle, translamina terminalis approach, or by bifrontal craniotomy, basal interhemispheric, and later also translamina terminalis approach. Or from above, and here we have one main approach by anterior interhemispheric spheric transcallosal approach. The choice of the axis depends on the size of the tumor and its anatomical relationship to surrounding structures. The most frequently we use pterional approach and later frontolateral approach, and after lifting the frontal lobe, we can remove the tumor using natural spaces, like the space between, maybe I will do it like this, between the carotid artery and third nerve, so laterally to the carotid artery, in the space between carotid artery and the optic nerve, optic radiation, or edge of the chiasm. Sometimes we can use also the space anterior to the optic chiasm, mainly if the chiasm is not very prefixed. And of course, if the tumor is growing to the third ventricle, we can penetrate the lamina terminalis and remove the tumor from the third ventricle by translamina terminalis approach. Less frequently than pterional, but also we use interhemispheric transcallosal approach. And what is important, after cutting the corpus callosum, the access to the third ventricle and the tumor can be obtained either through the foramen of Monro, especially if it is enlarged by the tumor, or especially if the leaves of the septum pellucidum are separated between the two fornices straight to the third ventricle. So we can go to the tumor or transforaminal approach or through the interfornical approach. So let's try to have a look on some various situations and consider the optimal surgical decisions. The decision seems to be very simple if you have tumors like in these two cases. We can remove the tumor totally by any approach, transsphenoidal or transcranial subfrontal transphenoidal approach. And how it's showed in both these short videos, the tumor can be quite easily removed totally, again here by transphenoidal approach and here by a transcranial subfrontal approach. Of course, since a few years, I have nearly abandoned the transcranial route for resection of such tumors in favor of transphenoidal approach. However, both possibilities are available. In this case, the situation is a little bit more difficult. We have a cystic tumor and the hypothalamus structures are not clearly seen. So it is possibly the craniopharyngioma grade 1. So what can we do? We can drain the cyst with subcutaneous reservoir and after reducing the cyst, possible evaluate if hypothalamus is involved and then decide about more or less aggressive surgery. Or we can resect the tumor in one stage by transcranial or a transphenoidal approach. In this case, we chose the last one and removed the tumor by transphenoidal approach. And on postoperative MRI, we see the tumor was completely removed, but the hypothalamus is not seen. So we should expect occurrence of undesirable consequences resulting from damaging of the hypothalamus. So maybe a less aggressive and more conservative approach in this case would be better. That's the question. The biggest problem, of course, is grade 2 tumor. And the presented surgery was performed before 2008 in the, let's call it, gross total resection era. So the surgeon attempted to remove the tumor completely with aggressive resection. This you see is a large tumor with a cystic part growing and involving the hypothalamus. And this is basal interhemispheric approach. Here is somewhere here is optic nerve. Here is the top of the cyst here. And the tumor is gradually pulled out of the ventricle. Again, the right optic nerve. Here is A1 seen, and step by step, the tumor is removed. Some calcification and the total removal of the tumor, basal artery and bifurcation, optic chiasm, and postoperative MRI showing complete removal of the tumor. And that's okay. However, what outcome did we obtain in this patient? So the patient has been free of relapse for 10 years. unfortunately, his quality of life has been diminished by panhypopituitarism, diabetes insipidus, and severe hyperphagia and obesity. So this quality of life was not very high. Well, the next case illustrates our current approach to treatment of craniopharyngioma. This is a 14-year-old girl who is also grade 2 large tumor involving hypothalamus. And in this case, we decided to be more conservative. So first, we make a surgery by terminal approach. Here is frontal lobe elevated, the optic chiasm, and the perforation of lamina terminalis. You can see typical for craniopharyngioma, oil-like yellow fluid going out of the third ventricle of the cyst of the tumor, and again, and slowly the tumor is dissected, again, oil-like fluid from the cyst of the cranium of the tumor. And we can try to remove also the part of the tumor anteriorly to the optic chiasm. However, here the optic chiasm is prefixed, so it's nearly impossible to this way. And again, between the optic nerve, edge of the chiasm and carotid artery, and laterally of the carotid artery, so between the carotid artery and somewhere here, the third nerve, the tumor can be also removed. And we can combine these approaches, helping pushing the tumor from this side and removing it through the hole in the lamina terminalis. Here we use the ultrasonic aspirator. However, we didn't try to remove the part of the tumor growing up into the hypothalamus. So, in postoperative MRI, we found, unfortunately, a large remnant of the tumor, especially in the third ventricle. So due to such unsatisfactory MRI scan, we decided about second surgery by transcallosal interfornical approach. And in the next stage, this is this surgery, interhemispheric approach, corpus callosum, which is cutting here. And the tumor just below the corpus callosum, a lot of calcifications. The corpus callosum is cutted about just posteriorly to the genome of the corpus callosum, and lots of calcifications gradually removed from the third ventricle using various tools like forceps, microdissector, and the solid part of the tumor in the more anterior part of the third ventricle, which is also removed. Okay. And the last stage of this surgery, some calcification in the anterior part of the third ventricle, the end of the tumor. However, again, we left the part of the tumor growing to the hypothalamus. And this is postoperative MRI. We see much smaller, only in the area of hypothalamus, so much smaller remnant of the tumor. And this picture was satisfactory for us. And the girl with the next step was radiotherapy. And 2 years after irradiation, it was in 2013, the tumor is stable or even a little bit decreased. And the girl is without relapse till today, so for almost 9 years, nearly 9 years, and without any significant deficits. And the last case This is a 3-year-old girl, so young child with also tumor grade 2, young child, so the possibility of radiotherapy is very reduced. So the child was treated surgically and by basal interhemispheric translaminar terminalis approach. The tumor was removed nearly completely. This is the last stage of the surgery, the left optic nerve, chiasm, large hole in the lamina terminalis. And again, the tumor is gradually removed. Okay. The remnant of the tumor. And the most difficult part was the moment, it will be possible to see it, not this one. Okay, removal yet. And here on the right, optic radiation, there was a small piece of a tumor that was very, very strictly connected with the optic radiation, so we left this part. And this is postoperative MRI. You see the small remnant of the tumor on the, it's here, you can see it on the optic radiation. So which strategy is the best? For grade 0 and grade 1, there is no doubt total surgical removal of the tumor is nearly always possible and should be preferred as the treatment of choice. However, in the craniopharyngiomas grade 2, so with hypothalamus involvement, there is no clear answer, and in my opinion, individualized decision in every patient should be undertaken. However, the main goal of our treatment is to preserve hypothalamus, to protect the child from the hypothalamic damage, and of course, optic structures. So the main aim of our treatment is quality of life. Thank you for your attention.
Thank you very much, Professor Madera. That was a real tour for 24s. Once again, can I please ask Dr. Jallo and Dr. Boop to make any comments and observations or questions? Thank you.
Dr. Madera, thank you. That was George Jallo. That's an excellent presentation. So is it, my understanding, is it your goal to achieve a gross total resection for these children in all cases, if possible, rather than do a biopsy or cyst drainage?
You mean a grade 2 craniopharyngioma, yeah? So
yes.
This is a very good question, as maybe sometimes there is no use to try to remove a lot of tumor, because the question is, how much can we remove so that the hypothalamus is not damaged, and how much is necessary to obtain better outcome, yeah? So maybe there is, in some cases, maybe radiotherapy can be the treatment of choice as the first treatment. However, till now, we rather don't do like this, and we nearly in every case try to remove as much as possible with the idea of preservation of hypothalamus.
Okay.
Dr. Boop, do you have any questions? Just get Dr. Boop.
Well, I have just another question. How often, in what percentage, Dr. Madera, what percentage of children do you recommend radiotherapy for craniopharyngiomas?
You mean early or late radiotherapy?
Late radiotherapy.
Yeah, I'm not convinced which approach is better, to use radiotherapy nearly immediately after surgery, or to wait, and if there is no progression, then not to use radiotherapy. If there is progression, use radiotherapy. As I know in the literature, there is no really significant evidence that early radiotherapy is better than late radiotherapy. However, not tomorrow, but the day after tomorrow, I will show the case of a child with the remnant of the tumor when radiotherapy was lately used, and we had a catastrophic progression of the tumor with several attempts to remove it or only partially removed, and at the end, the child died from the progression of craniopharyngioma. There is only one case I know about such progression of the disease. So maybe if radiotherapy was performed early in this child, maybe it would be better. However, I'm not convinced about that. And there is the subject of our studying with radiotherapies now.
Okay, thank you so much.
George, could you just take those two questions on the chat box to Professor Madera, please, if you can.
Certainly, I apologize.
Thank you.
I think there's two questions. The question is, in your experience of post-operative sudden severe hypotension, a predicted complication for aggressive surgery or radical resection of these craniopharyngiomas? And if yes, can you intraoperatively predict this and prevent this complication?
No, we haven't had any patient with sudden severe hypotension. Of course, many of our patients which were treated aggressively with total or near total resection, they had hypothalamic symptoms postoperatively, diabetes insipidus, and so on. However, no, I don't know any case with severe hypotension after surgery.
Okay, thank you. And I think the last question in the box was, is there a role for interferon therapy for residual craniopharyngiomas? I assume this is...
As I know, there is an option with interferon therapy. I have no experience with it. However, for example, Ezio Di Rocco, he used in some patients interferon intracystically with quite a good results. It's the same question about bleomycin. Yeah, bleomycin. We used it, I think, in 2 patients years ago, and we were not convinced of the good results of this treatment. However, if we have progression of the residual craniopharyngioma, especially the cyst, then maybe both interferon or bleomycin is possible choice of treatment.
Thank you. I think there's a question. Can you comment on the role of endoscope-assisted removal of these tumors during the transcranial resection? I know the next talk is going to be on endoscopic pharyngiomas, but do you use the endoscope to look around corners or to look for fragments?
Yeah, of course, we use in transsphenoidal surgery, which is more and more commonly used by us too. However, in transcranial surgery, we don't use endoscope, except for one situation that if I have some doubts, if there is remnant of the tumor in the part of the operative field that can be overlooked, that is easy to see in microscope, then I use Kevo, especially just for looking around the corner, for example, below the optic chiasm to check if there is no remnant of the tumor somewhere here. So I use it rarely, but as very only supportive tool.
Excellent. Thank you so much, Dr. Madera.
Thank you very much.
That is all the questions that we have. Naren, I think our next speaker.
Oh, sorry. Beg your pardon, I was mute. There's another question just come up. Can we repeat interferon course in case of regrowth of the cyst?
I cannot agree. I cannot answer this question because I have no experience with interferon. So, okay. There is no answer for this question.
Thanks. Thank you very much. I'm just trying to get the next speaker on the system. Let me see whether he's having some problem with the logging in. Just a second. Can we just, Professor Machado, just get Machado.
Yes.
Professor Machado, would you consider going next if that's okay with you?
No problem.
Oh, thank you very much, sir. Cheers. Sorry, beg your pardon. I'll just give you the host. Yep. You should be able to share your presentation.
Okay.
So Professor Machado is from Sao Paulo, one of the giants of pediatric neurosurgery, founders of the modern pediatric neurosurgery, which in Brazil, which is a very strong in Brazil. And Professor Machado has a vast experience in all aspects of neurosurgery. His passion is epilepsy surgery, as well as also the third ventricular tumor surgery. But here he's going to talk to us about tumors causing epilepsy. Thank you very much, Professor Machado.
Thank you, Nari. Thank you for having invited me and for the opportunity to discuss this kind of lesions, this kind of tumors, that they have a totally different approach from everything we have seen up to now, from yesterday up today. And I hope this can help you. I have nothing to disclose. So in my talk, I will present some definitions of the subject, many controversies, as I will mention. This is an ongoing problem. We have not all the answers for this kind of treatment. The classification, the importance of having a tissue biorepository for this kind of treatment, the etiology, the surgical technique used in our cases. Mainly, I will discuss the clinical workup. This is the situation where a multidisciplinary team is so important. The surgeon, as will discuss the tactic of surgery, will perform the surgery, but the decision will come from all the approach performed by a multidisciplinary team. So that's a big difference from when you see, for instance, craniopharyngiomas or for posterior fossa surgery. And then I will show you some clinical cases from my practice and the results of surgery and outcome and the conclusions. So what is important? This is considered the, just a second. Yeah, a low-grade developmental epilepsy associated to brain tumors. This is the name that is now done by the group of German people from Blanc, and I think it's very appropriate for this kind of situation. Sorry, it's not changing. Seizures is different from the rest of the tumors. Seizures probably is the only neurological sign in these children. These are benign tumors, and often you don't see localizatory signs, neurological signs. Seizures is what really it's the children complaints. The temporal lobe is mainly affected in these cases, and the duration of epilepsy is very high. In average, you see them 4.4 years, and this is the observation of a very large group of this German group with the 6,700 cases. So it's a long history of difficult to treat seizures. These tumors, they have glial and neuronal components. And what is interesting, they can be associated with the focal cortical dysplasia. And we'll discuss the implications of that. It is variable. It's described in the literature up to 80% of the cases, but I think it's at least in 50% of the cases, this is true. The real question is, what is the role of this cortical dysplasia? Is it related to the difficult to treat epilepsy in these cases, or epilepsy comes from the infiltrated peritumoral cortex? The histopathology of this LIAC cases is difficult, and because of the microscopic pictures. So this is an example that the neuropathologists, as we heard yesterday, neuropathology is part of this group, this multidisciplinary group, because the diagnosis is not easy to do. The controversies, there's a conceptual debate related to what are we treating? Is this a tumor surgery or an epilepsy surgery? And this varies depending on the service. If it's a service with experience in epilepsy, that is the case very frequently, it will be an epilepsy surgery. And what kind of surgery do we do? Lesionectomy versus the tailored resection. If the surgeons implicated in epilepsy, frequently we perform a tailored resection in these cases. The problem is that from the ethical point of view, it's not possible to do any prospective studies in these cases. So we rely on experienced centers of epilepsy that give their opinion, although we recognize that in many oncology centers, they also treat this these tumors that are almost 100% benign, and we'll discuss also the problem related to that. The other thing is what is the role of the electrophysiological studies that we perform intraoperatively in these cases. This relates to a better outcome concerning the seizure-free patients. I mean, the role of the electrocorticography of grids implantation, or more recently of stereo electroencephalography studies. This is a thing that we must answer. As I mentioned, the presence of cortical dysplasia will influence the outcome, And one very important thing is a long-term follow-up, neuropsychological follow-up of these children. We have in our favor the neuroplasticity, but what happens lately, I mentioned that this tumor occurs frequently in the temporal lobe, and frequently we are doing surgery in the left temporal region. Frequently we are performing surgery very close to the motor sensory region or language areas. What is the long-term result of that? If you see in the literature, frequently you see follow-up established in 1 or 2 years. This is too early for a child. We have to observe these children for a longer period of time, at least 5 years. And this is lacking in the literature. The other thing is the age of onset of seizures, the age at surgery and duration of epilepsy. We know that epileptic encephalopathy is a real problem in these children, and we have to deal with that. The other thing is mentioning that there's cases that we receive that have been operated elsewhere. They are addressed for failed surgery in non-specialized centers, mainly cases of left temporal lobe eloquent areas surgery. So this is another thing that we must deal with. This is the blue book. We heard of this yesterday, the classification, the 2021 classification of the brain tumors. You see that the glioneural tumors comprise the majority of these cases. Almost 70% of these cases are either ganglioglioma, DNTs, or more rarely papillary glioneural neuronal tumors. We have also, but more rarely, the angiocentric glioma and the diffuse low-grade glioma, MAP kinase pathway altered. So these 5 tumors comprise 73% of the cases that we normally deal with. And as you see, we treating these benign tumors, we are a little bit behind those that treat malignant tumors in children concerning the genetic signature of these tumors, but it's now in the last classification. We could see the molecular signature for these benign tumors. So we rely very much on the neuropathologists to classify this tumor. As Dr. Miller pointed out yesterday, this is a very growing list, a real growing list of tumors, of lesions, and this is growing in every classification that comes when we see it. The other thing is that these two main, this has been already stressed, these two main pathways, one related to the tumors and the other cortical dysplasia, they interconnect very frequently. And in the various of these points are now targets for treatment, even in these kind of tumors. In the cortical dysplasia, you see the mTOR inhibitors are now currently used in for treating TSC. And what is the importance of the tissue biorepository? It's so important because with this, the tissue that we take from surgery is so important to the classification of this tumor and for research or even for clinical use. We, for a long time, we have been associated with the UCLA with the Gary Mattern, or University of San Diego with the Joseph Gleason, mainly for studying cases of somatic mutations related to hemimegalencephaly, but also for cortical dysplasia. This is the cases that we have operated in our center in the last little bit more than 20 or almost 30 years. And you see that the pathology, the etiology of these cases are totally different from when you compare with the epilepsy surgery in adults. In adults, more than 80% of the cases are related to mesial temporal sclerosis. This is not what we see in children. We see our number one case is cortical dysplasia, and number two is the tumors. We, in our center, we have two separated groups, one especially for children with epilepsy surgery in children, and the other one for adults. It's so difficult for an adult neurosurgeon treating epilepsy, and very commonly operating on a temporal lobe and mesial temporal sclerosis to change immediately totally different pathology. And this is the same in the literature. The second most frequent cases are tumor cases just after cortical dysplasia. As I was saying, that's different for the adult neurosurgeon to being used to change the practice to hemispherotomies or to the other things, or lesion X or tailored surgery for tumors. And this is the reality in epilepsy surgery in children. And it's the same thing in the international literature. Well, as I mentioned, the clinical workup is a multidisciplinary team and follows the same rules as Luder stated more than 20 years ago. Initially, depicting the symptomatogenic and functional, clinically functional zone, and by studying with the video EEG, studying the irritative zone, and with image studies, we can see the epileptogenic lesion, in our case, a tumor, and the ictal onset zone and the epileptogenic zone is frequently, almost always, larger than the lesion itself. So the problem is this: we have to conclude with the studies that are performed in children if this surgery should extend beyond the lesion that is seen in the MR or not. So that's the real question that must be answered by this multidisciplinary team. So we start always with the clinical study of these children, followed by image studies, and one further step that I will comment if there is a need or not of invasive evaluation before proceeding to surgery in these children. The imaging studies is not easy. As I mentioned, the neuropathologist has an important role in defining the tumor, and even the neuroradiologist, but it's not easy. DNTs are very similar to gangliogliomas when we consider the aspect of these lesions in MR, and frequently even it's difficult to differentiate in some cases of cortical dysplasia type 2B. And we mainly, this diagnosis is made afterwards by the neuropathology. And other studies that we need sometimes respect with subtraction that's name of SysCom or PET scan using the metabolic alterations related to epilepsy. For instance, in this case, the 7-year-old a boy that had this lesion in the temporal lobe. This, after surgery, was thought to be a neuroepithelial kind of neuroepithelial tumor, but the revision of this case showed a diffuse low-grade glioma MAP kinase pathway altered. You see that the lesion is very similar to a ganglioma or a DNT. So it's difficult, almost impossible to raise the diagnostic. Because this other case, for instance, this 7-year-old boy, you see that this is typical. What is typical in these tumors, in these benign tumors, you don't see edema very much, but you see that the lesion that is done in the skull bone, showing that this is a long-term tumor in this lower part of the central region. So in this case, the child was studied concerning this, the exact situation of the related to the central region, and the diagnosis was an angiocentric tumor, and now characterized as angiocentric glioma. Again, it's quite difficult to make this diagnosis on MR isolated. And then after that discussion, as I mentioned, clinical discussion with all the plenary team, is the time for the neurosurgeon to define the tactic of this operation. And as we can imagine, you should have all the tools that you need. I think one of microsurgeries are mandatory, but I think neuronavigation is very important for us in this case, and to better approach these cases. The question about invasive evaluation. So intracranial examinations are very common. We do, as you see here, in focal cortical dysplasia, more than 80% of our cases are operated on with ECOG, electrocorticography alone. And this is the problem with this, that you should have someone expert in neurophysiology, because the decision is done during surgery. You cannot last too much long time observing the electrocorticography. So an experienced people is very important. Sometimes when you need a map, mainly concerning the motor region or when the language areas are concerned, we leave this grade and perform a long-term evaluation with the grids. For instance, in this child, a year and 6 month age girl that came to us with this tumor exactly over the region of the central region. And so as you can see, almost no edema surrounding the lesion. So in this case, a grid was placed, and the stimulation, you see the child, the response is small child when we stimulate the central motor region and the movement of the hand. And if the child is small like this one, the movement of the arm. And after that, the neurophysiologists give us a map that you come back to surgery, and you know that the region of resection and the displaced motor region, for instance, in this child, and you can perform the resection of surgery, resection of this lesion very cautiously. In this case, the tumor recurred many years after. You see that the functional MR showed the hand area is almost repeating the same map that we had previously, and the surgery could be done. This is more than 10 years now. The child is seizure-free with very mild hemiparesis. This was a benign tumor. As I mentioned, stereo EEG is now being performed, replacing the grades, and the results are very good for normally for normal MR. And for tumors, tumors are visible on MR. They are rarely performed in these cases, but it's part of our armamentarium now. Let's see some cases from our practice. This child, 11 years old, this child was not, the ECOG was not needed. The reason is that the distance between the tumor and the cortex, a cortical map would not give an important answer for us, because we would see the seizure widespread, and this so surgery can be performed without ECOG in this case. On the contrary, when you have the cases like this, the DNT, the temporal region, but these are cortical tumors, so you can rely on the ECOG. You see that the image of the tumor in the temporal lobe, and with ECOG, the area of the resection is much larger than the area of the lesion. That's why the patient becomes seizure-free after. Another interesting case is 10 years old, a boy with this insular tumor. You see in this situation like this. And after with the fMRI, you can locate the region, exactly the motor region of and perform the resection safely. Another case now in the frontal region, again, this is the tumor, and with ECOG, the area of the resection is much larger than the lesion itself. And so these are the cases where you can detect this cortical dysplasia. Now consider the type 3B, the association of tumor and cortical dysplasia. It had to be resected. And posterior region, you see that you have this image that resembles a transmental tract, but this is a tumor that's not cortical dysplasia. In these cases, we come close to the ventricle and we resect this part of probably the remnant of the tumor. Again, a new case, again, with the coming close to the ventricle to resect as much as possible this small tract. I mentioned this because this is another case, the tumor. You see this. In this case, I prepared the surgery not to resect this tract, and some years after that were where the tumor recurred. You see here. So be aware of this. This is not cortical dysplasia. This is tumor. In our cases, in our first 50 patients, and as mentioned in the literature, the duration of epilepsy is very large. The seizure frequency in this case is very big. And pathology, as I mentioned, frequently DNT ganglioma is the most frequent. and ECOG was used in 56% of our cases. This was enough to study the case. And as needed, functional cortical mapping also. In 13 of these 50 patients, we had cortical dysplasia associated, and only one patient was not seizure-free because of the recession was subtotal. The outcome of seizures in these cases is a preliminary experience that we had with these 50 patients who, following this type of approach of these cases, we had 84% of seizure-free. That is quite good follow-up. If you compare with the European bank that I mentioned in the beginning, with the children, you see that in more than 700 children, with long duration of epilepsy, you have 80% of seizure-free in these children. And pay attention that these malformations and hippocampus sclerosis even worse than the results of tumors. And in children, the results of surgery, of epilepsy surgery, is now better than what we observe in adults. That's the reason why we insist that pediatric neurosurgeon should be involved with this in these cases. One of the reasons is that we usually treat patients younger than 4 or 5 years. So that's our practice. This is not true for adults epilepsy surgeons. So I insist that it is important for the young generation to learn more and to be interested more in epilepsy surgery in children. So in conclusion, these tumors are associated with epilepsy and they lead to refractory epilepsy in children. And these tumors are benign and composed of a neuronal and glial tissue. And the classification is difficult to do, but in the recent classification, as I mentioned, this is much more studied, and with the molecular biology, we are gaining more experience with these lesions. They are frequently associated with focal cortical dysplasia, and by the criteria of International League Against Epilepsy, classified as type 3B. And the approach for these cases, as I mentioned, is multidisciplinary. We must depict the epileptogenic zone. The epileptogenic zone is an imaginary region, actually. You only know exactly that you have resected the epileptogenic zone when the patient is seizure-free after surgery, but you must study that before surgery. And total resection of this tumor, and if possible, with the epileptogenic zone, is necessary for keeping your child free of seizures. So thank you again, Nari, and congratulations for the work that you've been doing in so many years and with this kind of symposium. It's so important for the young generation to learn more about the concepts, the new concepts, mainly biology, molecular biology, helping us to understand what is our real practice. Thank you very much, and I finish here. Thank you.
Thank you very much, Professor Machado. It's a great lecture. These lesions are quite difficult whether epilepsy surgeon or tumor surgeon does it. Can I please ask Dr. Boop to comment and any questions from the chat box? Thanks, Prof. Thanks, Dr. Boop.
Yeah, thank you, Helio. That was a beautiful lecture. I think you and I are of similar generation and have a similar approach to tumors in children with epilepsy. There's a question in the chat room about the indications for invasive monitoring. And I know nowadays some centers are putting SIG electrodes in every patient. Some patients are being treated with laser interstitial thermal therapy and that sort of thing. Could you just comment on your thoughts there?
Yeah, thank you, Rick. Thank you. I know of your experience with these cases, and actually I follow your recommendations. This is a real problem because the neurologists and neurophysiologists, they tend to monitor every case. They are probably right. They want to know what they are doing and to try to as much as possible to depict this this zone that you need to resect in order to make the child seizure free. The real indication for this is for long-term, for invasive evaluation is when you have the lesion in proximity of or over the eloquent areas, mainly in the central region. As far as language is involved, we have in our favor the neuroplasticity. So when the child is less than 9 years of age, we are much more aggressive. And today we rely very much in fMRI concerning the language studies. So we can prepare our surgery frequently, avoiding an extra surgery for implantation of these grades. The SEEG is great, it's fantastic. We're now more and more using, but we reserve, this is not cheap technique, it's expensive. And again, you need another step for surgery. And you can implant 5 to 15 electrodes in any region of the brain, including the central region, the speech areas, and so on, and the insula. But we reserve these cases for difficult cases where you don't see a clear lesion on MR, but it's more or less like this. Thank you for your question. Nari?
Sorry, I was on the mute. Thank you very much, Professor Machado. That's a great lecture, and thank you for the answers. There are a few more questions for you on the chat box. If you could please, if you have time, answer them. That will be grateful. Thank you. So we now go back to thank you very much. We now go back to our program. So Mr. Kumar Abhinav, he's going to talk to us about endonasal endoscopic approach for craniopharyngiomas. He's a consultant a neurosurgeon, both adult and pediatrics in Bristol at the North Bristol Southmead Hospital and at the Bristol Royal Children's Hospital. He trained in Bristol and then did a 2-year fellowship in labs in Pittsburgh, and then 2-year fellowship in skull-base surgery, vascular surgery in Stanford. And he has come back, and it has been a great asset to Bristol with his new skills that he has learned. And I have seen his operations; they're fantastic, and look forward to his lecture. Thank you, Mr. Abhinav.
Thank you, Darren. Can you hear me okay?
Yes, absolutely. Yeah.
Okay, and I'm just going to try and get the slideshow going. So can you see that screen okay now?
Sure, yeah. Thanks.
So yeah, some of you may have heard the talk previously. Thank you for that introduction. So really going to talk about the technical aspects regarding resection of craniopharyngiomas and sort of translating the practice from laboratory to the operating room or the theater. And also, the parallels and the differences between resecting these tumors when you're dealing with the adult population versus you're dealing with the pediatric population. And so I've been doing this over the last couple of years at Bristol. We'll also present a bit of our preliminary experience and some of the select cases to highlight those points. So craniopharyngiomas, as you probably already heard many times, they're complex, formidable tumors. There are multiple challenging issues surrounding these tumors. Apart from neurovascular encasement, we worry about the calcification, the risk of hypothalamic and pituitary injury with long-term morbidity that comes with that, particularly in the pediatric population. We know the natural course of the disease is anything but benign. And we really see the downstream effects of that in kids as they go into adulthood. The advent of sort of endoscopic endonasal surgery, has been around for quite some time. What has changed technically is the use of more expanded approaches and lots more adjuncts, and as well as instrumentation, which permit a more safe, a safer and a gentler microdissection, much in the same way as you would do with an open surgical approach, but giving you better visualization of some of the areas in craniopharyngiomas which are typically sort of hidden from view when you go for an open approach. So this is our sort of brief experience with these craniopharyngioma cases over the last couple of years, and I'm going to present some of the representative cases and also the sort of anatomy, which is important for residents, fellows, as well as young neurosurgeons embarking upon this sort of surgery and knowing what's important. So there has been a bit of a paradigm shift. As we know, when the whole journey started, there was an attempted gross total resection. There was huge amounts of morbidity with that. Then we went to a subtotal resection, or partial debulking, followed by radiotherapy. More and more people now are talking about safe near total or gross total resection in these cases, and then use the open approaches in a complementary fashion when you need to. They're definitely not out of the equation at all. And when you get near total resection, people are talking about whether you should watch and wait or whether you should go for RT straight away. And a lot of the data we do have is still based on all the studies and operative paradigms. So, this is an exciting field which is going to continue to change both surgically in terms of molecular biology and other areas. From a surgical standpoint, certainly when you're approaching this endoscopically, I'll present the sort of investigation that we would routinely do. The first thing is really to look at the cellular anatomy. I expose the bilateral ICAs, the paraclinodal ICAs, in almost all cases, and other segments of the ICA if I need to, depending upon the extent of the craniopharyngioma. And then the primary workhorse approach for these sort of lesions is your standard supracellular exposure, much in the same way as pterional is for a lot of the skull-based lesions. And this is typically a transtuberculum, transchiasmatic sulcus approach. It's not so much a transplanum approach because there's no real advantage in going very forward along the skull base in these resections. All you do is you create a bigger defect, which you then have to repair, and it really does not add anything to your resection target or does not really help you with the resection. In terms of the imaging workup, all patients will get sort of dedicated views of the cellar, standard MRI, including paranasal sinuses, and almost all of them, I would put them through a CT angiogram, including navigation sequences. Then there are secondary approach considerations. Like with any surgical problem, you want to have other stuff in your armamentarium when you deal with pathologies. And sometimes if you have a functioning gland and you have a lot of retrocellular extension, you're thinking about transposition techniques, which I'll briefly touch on. And sometimes these lesions can go into the midclival area or even extend laterally. And then one has to think about how to lateralize the corridor or how to increase the corridor rostrocaudally. So this is the sort of anatomy picture that I present to all the residents or the fellows when they are thinking about endoscopic surgery. Extremely important to orientate yourself to the anatomy of the carotid from an endonasal perspective. Here is your foramen lacerum, and that's the Vidian nerve there. And that is your posterior genu, and horizontal paracellar ICA, anterior genu. And this is the clinoidal ICA, which, you know, we would typically expose in the surgery. And this is an endoscopic equivalent of the carotid cave that you would typically see after an open exposure when you would take down the clinoid, say from a proximal PCOM aneurysm or for an optic canal decompression. So you're seeing the other side of that carotid because this is your clinoidal ICA. This yellow line here, this really represents the level of your, what we call a carotidoclinoidal ligament, or effectively your proximal ring. So this is from the cavernous sinus paper that I put together with Juan Fernandez a long time ago. And this was really for cavernous sinus compartments for pituitary surgery, but it does have relevance to any endoscopic surgery. Some of the pictures from a paper that we did for tuberculum salameningioma, but again reflects some of those points about craniopharyngiomas surgery, that when you are operating for craniopharyngiomas, your bony dissection or removal of the bone only has to extend a little bit beyond the so-called limbus dura here. So here's your sella, this is your tuberculum, this is your chiasmatic sulcus between the tuberculum and the limbus sphenoidale, which is a nice landmark between the chiasmatic sulcus and the planum. And the extent of bony resection here really has to go just a little bit beyond that. And typically the carotids would be exposed because working angle or the working space is between the sella here and the limbus, i.e. this is your chiasmatic sulcus. And going forward here will only expose more of the orbitofrontal gyrus and the gyrus rectus, which is not where the tumor is. And again, that's an intradural view, and these are your superior hypophyseal perforators, undersurface of the chiasm and stalk, and again, demonstrates the importance that in this area, craniopharyngioma surgery is certainly all about, hugely about perforator preservation. And there are three sets of vessels that you are worried about, typically superior hypophyseal, PCOM, and thalamoperforators at the back. So if we start with a more basic example, so this is an adult, for example, where, you know, these lumps can be easier than dealing with heavily calcified, more difficult pediatric tumors with much narrower sphenoid sinuses. So this is a nice starting case, as it were. This chap does not have an endocrinopathy, and we were able to get a gross total resection with normalization of field and were able to preserve his stalk. So just to demonstrate those basic principles of the drilling and all that. So this is a case pretty much at the start of my consultant or attending job here. So here is that paraclinoidal ICA exposure. So you're exposing your carotid artery there. And the advantage of that is that it allows you to really cut the diaphragm and mobilize both the carotids away. Now here is that superior hypophyseal that you can see. Now, typically with craniopharyngiomas, you know, the descending diaphragmatic branches that you get from these hypophyseal, you can take those. But what you really want to preserve are the superior, the vessels that are going superiorly towards the chiasm. And you can't be too careful about it, because really you just don't know which perforator could lead to an ischemic insult or worsening of the visual function. So gradually, so in steps wise, once you've got both your carotids, you inspect your carotid membrane on either side, and then you're really following that nice arachnoid membrane. You're following the liliquis. Liliquis is generally intact with craniopharyngiomas. And then you go around the cavity, making sure in as much as possible, you've taken the capsule, that's your liliquis membrane there, that's coming into view at the back. You can see the stalk. This is a relatively easier one to preserve the stalk in. Not all cases are like this. And again, you can see that if this bony exposure was taken much more anteriorly and the dura was opened more anteriorly, there really will be no advantage. You'll just be looking at the frontal lobe. And here's a posterior communicating artery in the back. And this is the sort of final stage of the dissection where you're peeling the tumor off the undersurface of the chiasm bit by bit, dissecting it sharply and just being patient. So most of the work you want to do is really microsurgical dissection rather than, there is some controlled traction and controlled peeling, but you really want to minimize any too much traction, because traction is equal to potential injury, perforator avulsion, and that sort of problem. And then you can see you can inspect the landscape. There's a PCOM, liliquous membrane, undersurface of the third. Typically for reconstruction here, I would use Duragen, fascia lata, and then a near-septal flap followed by lumbar drain, similar to how I was taught by my mentor, Juan Fernandez. So, and then there's some of the problems. There's a case, for example, in an obese woman where there was concern about leak. She had undergone a previous anterolateral craniotomy, and then she had a massive recurrence of the craniopharyngiomas within a short period of time. And again, here, we were able to take the tumor out completely. She didn't have any hypothalamic dysfunction or leak issues. Now here, obviously, the stalk preservation was not an issue. She was already had the issues, the problems that comes with the craniopharyngioma. And after this, I'll go into an adult and a couple of peds cases. But this is another one that demonstrates that bony exposure nicely. And you're really trying to achieve that rhomboid sort of exposure, a wide exposure rather than an exposure which is narrow and the field and the light is constricted, because again, in skull base, that sort of exposure can lead to injury. So this is the cutting of the diaphragm and mobilizing the, what that allows you to do is to push the sella down and also mobilize the carotids away. This lady has already previously had operations, so you sequentially go in, you identify your right planes. And here it's actually relatively easier because you go in, you debulk, and then with gentle traction, you can start delivering the tumor content. And the wide exposure, the advantage of a wide exposure is that all the structures you are concerned about, you can keep that under direct inspection as you're performing the surgery. So you found what you're worried about injuring, and therefore you have better control on that. So I'm just going to fast forward that to demonstrate what's nice about going through the endonasal. You get a beautiful view of the third ventricle, and there is that egress of fluid from the third ventricle, and you deliver the capsule bit by bit. And then you have, with angle scopes, you then have the luxury of inspecting the whole of the third ventricle and the wall to make sure you've gotten as close to gross total as you can. Typically, I would also inspect the liliquist, because sometimes you can have a double membrane. So you can have a normal membrane of the liliquist, and then you have the craniopharyngioma capsule on that. So it's quite nice if you can peel that off. If you are peeling off the liliquist membrane, absolutely have to be careful that you don't inadvertently injure one of the thalamoperforators or perforators coming off the P1. So there's that inspection of the membrane, making sure that everything is clean down there, and then you can trim the capsule further. You can see that little bit of tumor capsule on top of the liliquist. So you can trim that further, and then you go into the third ventricle and inspect all the walls of the third ventricle, making sure it's all nice and clean. And then again, the reconstruction will be very similar. Very important to take all the blood out. And here's the undersurface and the view of the foramen and Monroe. Reconstruction follows the same pattern, whether it's an adult or child. And you perform we put in a lumbar drain. Here's an example that'll be more typical of, so that you see this is a slightly more challenging one because there's more in the way of calcification here. So this is where even before I've gone in, I've got a more guarded attitude to resection here. So I've done a similar sort of exposure because I'm worried about potentially injuring the hypothalamic function. Again, similar division of the diaphragm. You can see the carotid exposure on each side. And this is a lot more calcified, and you really have to battle it out here with the perforators on this side. The patient had not completely lost the stalk function, so we tried to protect the stalk. And you can see the difficulty. It's almost like a calcified tooth remnant, which is sitting on the just posterior to the stalk. So you gradually debulk that, keep working at it with kerosene punch, with the suction. And then once you've reduced the mass down, then this is top of the basilar, the P1, you're really working your way around the mass and gradually, bit by bit, finding the neural plane and removing it as much as you can. We were able to preserve the stalk function in this person miraculously, but towards the end of the resection, I did leave a cuff on the wall on the right side because it felt too adherent. And in that sense, I think the risk of potentially injuring and causing major dysfunction is too high. And you often get that mucinous plane with the hypothalamus, and you can resect it along there, but you can see on the left side, there's a lot more calcification, which I elected to actually leave behind. And again, you get a nice view of the third ventricle, and then we'll go ahead and reconstruct that in a similar fashion. And I've left that residual cuff on that side. So it's starting with duragen, fascia, and nasoseptal flap. So these cases kind of give you the confidence to deal with bigger and bigger craniopharyngioma. This is a lady where we got a gross total. This is a larger one. Didn't have any issues with the leak. She had gross hypothalamic. She already had cognitive dysfunction at the outset. So you build yourself up using these sorts of cases, and then you start dealing with the pediatric cases, which have their own challenges. So here, for example, is a 7-year-old child who's had previous transcallosal excision of a very large craniopharyngioma, and the debulking was quite nice, done from the top, and he's had radiotherapy, and then he comes in with this recurrence where you have this all basal active disease, and then a wall on in the third ventricle with contrast enhancement. And you can see this is going to be a tough case because the patient has been radiated. There is partial pneumatization of the sphenoid. The basal part is calcified. You have high posterior clinoid. So really, by doing more and more of these, what I have learned here is that you want, just like in adults, you want a wide exposure, drill the voma down. The gland function here is already gone, so you don't really have to do transposition, but it's important to take down the posterior clinoid here because that gives you a nice working angle, not only to remove the basal part, but to deal with the top part that's adherent in the third ventricle. And here we were able to do the basal part nicely. That all came out. That's a bit of fat, you can see, but what we couldn't do so well, it was the contrast enhancing bit, top part of it in the third ventricle, which felt far too adherent, and I was reluctant to pull that down and cause any potential injury. So that's being kept under surveillance. But these are the sort of, again, postoperatively, he did well. He had no CSF leak or issues. But these are the sort of challenges you face when we are inheriting a cohort of these patients who've had previous craniotomies, radiation, complex recurrences, and it really, they are very challenging cases where you have to be judicious with the extent of resection. What happens if you have an intact gland function? Well, really, then you have to worry about transpose the gland. And that's what this slide is demonstrating. Many craniopharyngiomas are obviously retrocellular, or they can go even more south. And if the gland is functioning, you need to figure out a strategy to transpose the gland. Typically, again, we're about to publish on this, but typically for craniopharyngiomas, you can do that intradurally. So it's almost like an intraaxial way of transposing the gland. There are other ways of transposing the gland, and this is from Juan Fernandez Miranda and his paper on ligaments, where you can go transcavernous and transpose the gland. But for craniopharyngiomas, we don't really recommend that. You either go intradural and transpose the gland, or if the gland is not functioning, you sacrifice it. And the third, the so-called infracellular transposition, where we're cutting the diaphragm and pushing the gland down, that's an important technical nuance because you need that to increase your working angle craniocaudally, and it really helps, as you saw in those videos. If the craniopharyngioma goes even further south and is in this sort of area or going more laterally, then much like when you're doing a petroclival meningioma or chordoma, chondrosarcoma, you have to bring in other strategies which involve either skeletonizing the paraclival ICA, transposition, drilling the midclivus. So it's almost stacking them up in a modular fashion such that you can deal with the tumor. Now here, for example, is a child who presented, again, previous open resection, significant recurrence. So this is all recurrent disease here, but that's not it. He's got disease going down to mid-clivus. So if I play the video, you can see that's all disease here. That's going down to the mid-clivus. And that's a difficult case to do because it's effectively multi-compartmental. It's going from suprasellar, going from the limbus spinodale to mid-clivus. And here, in order to get that lump, essentially, we have to do the suprasellar module. The gland wasn't functioning, so we removed the gland, and then we drilled all the way down to mid-clivus and even added in a called a luck, a sort of a transantral approach to look to one side. And we were able to get a gross total in this kid, as you can see on the lower slide. The difficulty we had in this kid, he got hydro and he developed leak. He had a large defect, and we struggled with that, and eventually had to do a lateral nasal wall flap to bolster the other flap, and then put a shunt in as well. So these cases are challenging at the time of doing it, and you also got to be prepared, particularly in the pediatric population, to potentially deal with problems that come with creating large cavities and resections. Last couple of slides, I just want to demonstrate that you can use these techniques. I showed this at one of the other meetings Naren had arranged to other pathologies in this region. This is an interesting case of a non-germinative germ cell tumor, which had mostly responded to craniospinal radiotherapy and chemotherapy, but there was still this residual nodule. Now it doesn't look that big, but you can see where that's sitting. That's sitting right on top of the thalamoperforatus, which are here. That's top of the basilar. The kid already does not have a functioning gland, and that you can see on a T2 axial. So again, we get a CTA in all of these cases, because here you can see there's a carotid clinoidal ring, and that puts you off against doing a full middle clinoidectomy or carotid exposure. So I'll just show the operative video. So a similar exposure, like in other cases, you do a clinoidectomy here. More and more now, I would encircle the ICA rather than just drill on the lower aspect of the ICA and then skeletonize. And you do that on that side. This side is more limited because of the ring. You can see here, we don't have to worry about the gland function, which is a luxury. And again, when you do that, when you divide the stalk, even in these cases, it's useful to divide it as close to the gland as you can, being very careful about the hypophyseals here. You mobilize that arachnoid membrane, and then once it's all clean, I made sure that there's no hypophyseal, I will cut the stalk. And now that gives me the time to open up the arachnoid membrane and start inspecting each of the perforating vessels and work out what's ending in this so-called tumor mass versus what's going into the chiasm. And then you find that plane with the hypothalamus, and it always tends to be this sort of a gelatinous, mucinous area. The difficulty in this case, as I said, the size is not everything, is that you can see the lower part is extremely adherent to top of the lilicus membrane. We are going for an oncological resection here. If this was a craniopharyngioma, if it was that adherent, I would bail. But in this case, you're aiming for oncological resection. So bit by bit, you identify what's ending in the tumor capsule versus what's transiting, much like you would like almost for an AVM. And then you sharply dissect. I think the key thing is to demonstrate that when you're operating in this region, it really is, you're always thinking carotid, hypophyseal, PCOM, and then the thalamoperforatus, and you're trying to dissect them sharply bit by bit. And here's identifying an end vessel into the capsule. And then you see that frees up the thalamoperforatus and the lilicus membrane. And then you take it out, and that's a total resection, view of the third ventricle, and then we reconstruct as usual. And if we look at the post-op scan, we were able to get all of that out, and kid needed a debridement for a more local nasal infection, but otherwise did well. So in conclusion, really, I think to work in this area, it's important to have appreciation of applied anatomy, good skull-based drilling technique, have tailored wide exposures, both mediolaterally and rostrocaudally, have other things in your armamentarium, your transposition techniques, clival approaches, and also be very comfortable doing open approaches when you need to, so that you're not guiding your resection based on approach. You can get to it and resect it as best as possible. The lessons I've learned last couple of years doing these, particularly having trained in these in centers like Stanford, where a lot of the work, particularly the post-operative care, was seamless. When you set this service up on your own in another place, you need to not only think about operation, which is extremely important, of course, but there are factors, multiple factors that go into making these successful. Intraoperatively, it's setup, it's efficiency, it's partnership with an ENT team. And for myself, I work with Warren Bennett, having a theater team or OR team that are comfortable with these operations. And sometimes I've even tried to stage them and done well with that, even though I was reluctant with the flap issues, particularly as I get quicker and improve and the team improves. It's something to consider. Mobilize the patients early. Post-operative fluid balance in these kids is notoriously difficult, and you really want a superb ICU, PICU team, as well as an endocrine team that can provide round-the-clock input. Otherwise, you have an iatrogenic insult from hyponatremia, and all your surgical results will be undone. CSF leak management remains challenging. Our results have been very good, thankfully, but I'm always aware how easy it is for this to fall apart, particularly in kids. So now we do things like what I picked up also from Jerry Grant at Stanford, who was the pediatric neurosurgeon there. We open the drain during extubation, which allows the kids to, if they cough, for the CSF to end up in the drain. You want to have very precise management with the drain targets, not under drain or over drain, because both of them can cause problems. Although in my fellowship, I didn't use Mericel. Now I do use Mericel in kids, and I leave that for 5 days with antibiotic prophylaxis as another extra level of cautionary measure. So really important to have a full 360 degree of, everything just has to be 100% and more right in order to get good results with these kind of cases, because it's bringing together all your skull-based, vascular, pediatric, and all the perioperative skill sets that you need to deal with these difficult cases. And finally, this is the team. Warren Bennett on my right, stellar pediatric team, Alison Cameron, who is our oncologist, and huge amounts of gratitude, as I do in all my talks recently, to Juan Fernandez Miranda, who trained me for 1.5 years as a clinical fellow and 2 years in the lab in Pittsburgh and Stanford, Gary, with whom I did a vascular fellowship, and Rick, who trained me during my residency. Thank you very much.
Thank you very much, Mr. Abhinav. That's a fantastic lecture and beautiful techniques. If Dr. Boop is there, Dr. Boop, do you have any questions or comments? If anyone else has any questions or comments to Mr. Abhinav, could you please put it on the chat box? In terms of these techniques are, as you said, that attacking craniopharyngiomas, you want to be able to have the full 360 degrees armamentarium. Just one question, if I may ask. I'm not, as you know, I'm not a pituitary surgeon or a craniopharyngioma surgeon, but in the last case that you showed, where you transected the stalk and then excised that craniopharyngioma, could you have approached that particular case with a what you call an anterior interhemispheric approach and come through the lamina terminalis? Without... Yeah,
I think you can do that. You can certainly, people have there are so many ways of getting there. Some people prefer going through the translamina terminalis approach and coming almost dead neutral interhemispheric sort of dissection. Some prefer going through the windows between the optic and the carotid, but I think each one of them, you have blind spots. the issue is obviously stalk preservation or not. So if a child did have stalk function, then I would try and preserve that in as much as possible. But if it is a situation where the child has, most of the pituitary function has failed, they've had radiation, they've had recurrence, then really you're better off potentially sacrificing the stalk, because in those cases, even if there is minimal function, by the end of the surgery, even if you've tried to preserve it, it likely or may well not work, and you may still have left more disease behind. So, and unfortunately, a lot of the pediatric case burden that we see, at least here in England, a lot of them have had other approaches, have had radiation, and most of them actually have lost their gland function.
Thanks, thank you. I'm just going to ask Professor Atul Goel his thoughts on that talk, Prof. Goel, and any questions for Mr. Abhinav.
Yeah.
Thanks.
Yeah, Mr. Abhinav, that was a wonderful lecture.
Well, thank you.
With small points and big points and various issues that you have discussed. Of course, craniopharyngiomas is an entity which is, the controversy continues, the discussion continues, the difficulties continue, and the management issues have various issues, as you mentioned. One is surgery and one is post-operative course, which is also needs to be absolutely fantastic. There is no question about it. And as you mentioned, the other thing is very important is if you have to do craniopharyngioma surgery beautifully, the first time is the best time.
That's right.
And as you mentioned, that recurrent or radiation, post-radiation are sometimes can be absolutely tricky, and you can the vascular injury is a big possibility. There's no discussion about this. The discussion which I feel, of course, endoscopic and transnasal surgery is becoming more and more and more popular, but transcranial surgery has its own advantages, and according to me, transcranial surgery and lamina terminalis surgery has absolutely huge role in cases of craniopharyngiomas, particularly where the sella is not enlarged. You see, you have shown, and many, not only you, many people like to do transnasal and endoscopic, and it has become almost like a most accepted way of treatment. But in my estimation, basal, frontal, translamina terminalis approach is a phenomenal approach for largish craniopharyngiomas, particularly those that are very huge and those grow in the brain in multi-compartments and things like that. The other issue is, the dissection. If, many people have talked about dissection techniques and how to preserve vessels and which vessels have to be preserved. In my calculation, craniopharyngioma surgery, the best surgery is where you have not coagulated even a single time. That is the best surgery, and that is possible in a number of cases. You see, you just hold the thing and gently, gradually put traction and gradually put traction, and the entire thing comes out like a placenta. And you realize that you have not coagulated even once. The most important thing that you have also discussed and mentioned, and everybody else discusses, is the preservation issue of preservation of the pituitary stalk. And pituitary stalk needs to be preserved, but it is an impossible task, at least in 50%, if not more number of cases. But you have to attempt and you have to try, and in a number of cases, you can actually preserve the pituitary stalk. And you can preserve in a small number of cases. One thing which I will like to mention, and which is very important in my estimation, is that many of these craniopharyngiomas, where you have to actually first time, not post-radiation, you have to cut the pituitary stalk, that is all right. But if you are doing for the first time and to resect, you have to cut the pituitary stalk. In those cases, I will say I will prefer to leave a bit of tumor on the capsule and on the pituitary stalk and maybe not cut the pituitary stalk.
Yeah.
And the last point which I want to make regarding craniopharyngioma is that we must know and we must not neglect the role of radiation treatment also is very prominent in craniopharyngioma in cases where we have not been able to do a good job, or we have done recurrences, or we have reoperated and reoperated. We must not forget the massive role and a very positive role of radiation in craniopharyngiomas, where you can control the rate of growth for a long period of time. So these are the few remarks which I wanted to make, Abhinav. But all in all, that was a very fantastic presentation. Your technique of dissection and your microsurgical technique, I liked it very much, and congratulations to you.
Thank you very much, Professor. Thank you very much. Yeah, no, those are wonderful points. And I think I really always make the point about particularly young neurosurgeons wanting to do this surgery, setting it up somewhere that you really have to make sure the post-operative care is perfect, because you can go to centers where that's looked after. And, we are all focused on the technical aspects. And then you realize that oftentimes it's the post-operative care that brings down the results. So you really have to make sure that is absolutely solid.
That's great. Thank you. Thank you very much, Professor Goel, and thank you very much, Mr. Abhinav. That was fantastic lecture and fantastic discussion. Brilliant. Thanks. I'm just going to go to the lecture from Mr. Ajay Sinha on pituitary adenoma. Mr. Ajay Sinha is actually in India at the moment, and he has sent me his lecture, which he has put audio in it, but he's having some tricky because he just landed with the getting online. So I'm just going to play his lecture. Let me just see whether I can get it going. Just a second. Mr. Ajay Sinha, as you all know, is at Alderhay in Liverpool. He's a very close. Abhinav, could you? Okay, I got it.
Naren, is the audio okay? Naren, I cannot hear properly.
Recording in progress. Based on certain factors we have referred to the years, this particular group of patients we have listed tend to be a lot more aggressive. Fortunately, with the thumb across the silent cortical breakup and one certain, but they are very rare disease. But this particular group of we have listed tend to be a lot more they require much more nurse from perhaps earlier. This is a study from my unit. This is one comprehensive study the behavior and this age group. Study cases on the study was that the sort of the platform and despite a 6-month treatment, they increased some cardiovascular risk in this age group of patients caused by obesity and infertility can be a consequence. But the same in this group. 29 the black normal like Hopkins and NHS and those there in children
Hello, I think we are having problem. I understand that you are not hearing the audio. I understand that you can't hear the audio. So what I will do is that I'll try it again. And if you can't hear the audio, then I will just send a link to download this presentation. Just a second. Okay. Okay, so I think we are having problem with the sound. Is that right, Dr. Gold? You are not hearing the sound?
No, no, not at all, not at all.
No
sound at all.
Am I right in saying that you can't hear the sound, Professor Gold?
No, I cannot hear. Naren.
Okay. Can someone just okay? We'll go to the next program and then we'll come back if it works. So let's go to Professor Ricardo Oliveira. Professor Oliveira, could you? Yeah. Do you want to share your presentation, Professor Oliveira? You need to unmute. You should be able to unmute.
Okay. Okay. Now it's okay. We will share my screen.
I can't hear you.
You can hear me?
Hello, Ricardo.
Hello.
Oh, brilliant. Excellent. Great.
Okay.
Thank you. So I'm Dr. Professor Ricardo de Oliveira. He's at Sao Paulo. He's a pediatric neurosurgeon from the school of Professor Machado. He's a past president of the Brazilian Pediatric Neurosurgery Society and the editor of the Archives of Pediatric Neurosurgery. So Professor De Oliveira is going to talk to us about atypical teratoid rhabdoid tumor. Thank you.
Thank you, Nari. It's a great pleasure for me sharing some thoughts about a typical teratoid rhabdoid tumor in this very amazing international pediatric brain tumor course. So I started with some key points about ATRT. So first of all, it's a rare, malignant, fast-growing tumor that begins in the brain and spinal cord, rarely in the spinal cord. It can be considered an embryonal tumor of the central nervous system and occurs in children, usually age 3 years and younger, although it can occur in older children and adults. However, it's very rarely occurrence in adults. And the ATRT presents certain genetic changes and may increase the risk of a typical teratoid rhabdoid tumor. And the signs and symptoms are usually associated with raised intracranial pressure in the brain because frequently by the size of the tumor. The first description on literature was done by Rourke and Packer and Beagle in 1996 and comprised 1–2% of all central nervous system tumors in childhood. ATRT is a primarily monogenic disease characterized by the biological loss of the SMARCB1 gene. Usually, it's supratentorial, and it has been a poor prognosis, and it's very common to disseminate it throughout the CSF. This is a very interesting illustration concerning how changed in the WHO classification of the tumors about the embryonal tumors. ATRT was described, as I said, in 96. So it appeared here for the first time. And then because of the molecular characterization in the most recent classification on WHO of the brain tumors, ATRT presented now with 3 subclassification according by molecular biology. And it remains the most common CNS embryonal tumor in children under 12 months of age. Another very interesting point about ATRT is the differential diagnosis. So it's very difficult to distinguish from other embryonal brain tumors as medulloblastoma, embryonal tumors with multi-layered rosettes, primitive neuroectodermal tumor, pineoblastoma, and pituitary blastoma. So it's very frequently, and it's a misdiagnosis because the pathologist is not easy to differentiate this tumor than this other in this slide. About the neurological images, this is a very common to see some calcification on CT and a large area on necrosis on the center of the lesion and the hyper-dense mass on CT and hyper-intense after gadolinium enhancement. And you can see it's very frequently a huge tumor. So it's very typical neurological appearance of the ATRT. On the posterior fossa, it's frequently on the midline and the same, some areas of necrosis, but as I told you, it's very difficult to differentiate in the posterior fossa than other typical tumors as, for instance, the medulloblastoma. This is 3 examples. One, PNET, the supratentorial PNET, an ATR2, and then a glioblastoma, multifocal glioblastoma. So you can see here how difficult it is to differentiate on neurological examination from embryonal tumors in PNET and ATRT. Concerning about histology, so the most common is to see a large and pleomorphic rhabdoid cells with abundant eosinophilic cytoplasm, often filamentous cytoplasm inclusions and vacuoles, eccentrically round nuclei and prominent nucleolus, may have mucinous background and may have epithelioid features with poorly formed glands or Flexner rosettes, as you can see here in this illustration. It's a very cellular tumor with a high mitotic index, as you can see here, comprised of primitive neuroepithelial cells with variable prominent regions with overtly rhabdoid that is characterized in this tumor. ATRT morphology is diverse with epithelial, mesenchymal, and neuroepithelial features. Rhabdoid cells that is considered the hallmark of nearly all rhabdoid tumors may account for only a very small percentage of the cells observed in ATRT. About immunochemistry, so the positive immunochemistry from vimentin AMA, smooth muscle actin, cytokeratin, neurofilament, focal, GFAP, as you can see here, variable synaptophysin and chromogranin. So it's very common to find on ATRT. So AMA positive, vimentin positive, and GFAP. In clinical practice, any CNS embryonal tumor in a pediatric patient should be routinely screened with SMRR CB1 immunochemistry to exclude ATRT. And how about the management? So there are 4 types of treatment for CNS atypical teratoid rhabdoid tumor. That is surgery, chemo, radiation, high-dose chemo, and recently target therapy. So some important points about surgery. Frequently, you can see huge tumor, so that frequently on the signs raise intracranial pressure in children. Usually presents in infants or in toddlers. And as you can see, in this age is intraoperative hemorrhage because this tumor is rarely vascularized tumor. So it could pose life-threatening clinical issues. We indicate for those tumors large craniotomy and to consider unblocked recession as much as possible. Intraoperative ultrasound, ultrasonic aspirator, and neuronavigation, electromagnetic neuronavigation. Just an illustrative case, we published our series in 2015 with giant brain supratentorial tumors. And we present here one case, as you can see here, on magnetic resonance, a large tumor, and the resection commences with cauterization of the corticopia surround the lesion with special attention to adjacent eloquent cortical areas that serve as limits for the resection. And the final results after almost an unblocked resection of the lesion preserve the motor cortex. And about the preoperative embolization. This is another case. It's a huge tumor. You can see here the arteriography, a deviation of the ACA, and the embolization in infants. The procedure had to be abandoned due to technical difficulties. We tried in our series in 4 patients from 23, but we couldn't proceed with the embolization. So what are the difficulties? During tumor resection, we can see early identification and cauterization of the blood supply of the tumor, allow neurosurgeons to better achieve maximal tumor resection and minimize surgical complication. When you see the vessels on infants is very small vessels, so it's very difficult, technical difficult to proceed embolization in children under 2 years of age. And about the adjuvant treatment, there is presently no standard treatment regimen for ATRT. Survival is estimated at 1 year of half of case. Age over 3 years at diagnosis correlates with better prognosis, probably due to radiotherapy associated with the chemo. Extent of surgery is still widely reported as a major prognosis indicator on better prognosis concerning ATRT. And about the chemo, usually high-dose chemotherapy with autologous stem cell rescue was initially adopted to defer craniospinal irradiation in patients under 3 years of age, and has become an increasingly popular mainstay of ATRT treatment. Radiotherapy, there is a little bit no consensus who received focal versus craniospinal irradiation. Intrathecal chemotherapy has also been explored both for prophylaxis and treatment of metastatic disease as an alternative to radiation of the craniospinal axis. And recently, some target therapy was published on literature. We know that there are 3 different groups about ATRT: the sonic hedgehog group subgroup, kinase subgroup, and MIC subgroup. So these different subgroups could be associated with different therapeutic sensitivity of ATRT. And clinical trials try to figure out how to manage the chemo for different groups of ATRT. And our final remarks: the last 2 decades have seen incredible advance in the understanding the ATRT biology and promising improvements in the treatment of the disease. The biology-driven therapies can be developed more effectively as in the subgroups of ATRT. And surgery still has an important role in the management of this tumor. Thank you so much.
Thank you very much, Professor De Oliveira. That's a fantastic talk. You touched on all aspects of ATRT, particularly including the molecular biology as well. In terms of, do you think that in 5 years, 10 years time, this will be more amenable to targeted therapy, or I think is in terms of the cases that I have seen with ATRT, they usually are very difficult, and you know, you are losing battle sometimes, most of the times, what do you think about targeted therapy? Do you think it's on the horizon, or is it still a long way away?
Yeah, no, right. The target therapy could be a very interesting method. So in ATRT, as you mentioned, it's a very rare tumor. Mm-hmm. You don't see commonly this tumor, and it's very difficult to have a significant clinical series to study. And in my opinion, only multi-centric studies joined a large or big number of cases, and to separate it in the 3 groups and to give some target therapies could improve effectively the prognosis in those children.
Thanks. Thank you very much. Thank you very much, Professor De Oliveira. If you have any questions for Professor De Oliveira, if you could please put it on the chat box. That's great. Thanks. So the next speaker is Professor Oliver Klein. Professor Klein is professor of neurosurgery, pediatric neurosurgery in Nancy in France. If I'm right, he trained in the famous Necker Children's Hospital in Paris. It's a real honor to have Professor Klein to give us a talk on spinal intramedullary tumors. Thank you, Professor Klein. You should be able to share your presentation. Thanks.
All right. Do you see the presentation?
Not yet, sir.
Not yet. So.
Yep, we can see that.
So I think it's better.
Great, fantastic.
Right. So thank you very much, Naren, for organizing this fantastic course. And thank you very much to give me the opportunity to talk about these sometimes very challenging tumors. So I will start by dedicating this lecture to my mentor and friend, Professor Michel Zera, who taught me so many things about intramedullary spinal cord surgery. So this talk will be focused upon intramedullary spinal cord tumors with exclusion of caudal equina tumors, lipomas, extradural tumors, and tumors of the bulbomedullary junction. All these tumors account nearly 25 to 35% of intraspinal tumors in children. And with an incidence rate of 1 to 2.6 per 1 million children, in a country like France, you have almost nearly 20 new cases a year. Differential diagnoses include myelitis, multiple sclerosis, and syrinx. That's the reason it's very important in front of a syrinx to have contrast enhancement MR, and sometimes can be misdiagnosed by trauma. Symptoms in descending order of frequency. Pain is occurs in 2/3 of cases, back pain. Sensory deficits, then motor deficits, they are present when the tumor is there for some months in 70% of the children. Scoliosis, head tilts.
Okay, folks, you've got your PowerPoint open and you're ready to record.
Sorry. Bladder issues. Do you hear me? All right. And sometimes 10% of cases, so rare but not so rare, hydrocephalus. So the first message is, with persistent back pain in children, should lead to MR, spinal MR. And the second message is, when you are faced with a painful or left-sided scoliosis, especially if it's a boy, then MR. So in summary, revelation of symptoms are often insidious and attention must be paid to scoliosis. Pain is the most common symptoms. Motor deficits appear early, but sphincter issues occur late. And as we will see later, pre-op modified McCormick scale is one of the predictors of the functional postoperative stages. Talking about pathology, 85 of these tumors are low-grade tumors, divided into pilocytic astrocytoma and ependymoma. And if you have a child with type 2 neurofibromatosis and a spinal cord tumors, this is an ependymoma. Sometimes high-grade tumors, for example, diffuse midline gliomas, with a median overall survival of less than 1 year, and other tumors, metastasis, mostly from medulloblastoma, anaplastic astrocytoma, and hemangioblastoma in case of von Hippel-Lindau disease, and sometimes ATRT. Most of these tumors are located in the thoracic levels, 5 levels on average. Some of them are thoracolumbar or cervicothoracic, and 19% of them are located in the cervical portion of the spinal cord. Here are some examples. When you see this side, you have an aspect of what radiologists call a big cord, big spinal cord. So that's most of the time, not only, but most of the time, it's an intramedullary spinal cord tumor. And it's like that with solid portions, with cystic portions, and with sometimes edema. Another example of a spinal cord tumor, of a thoracolumbar spinal cord tumor. Here, the postoperative aspects. Another example with contrast enhancement and axial view of this tumor. Another thoracic tumor, thoracolumbar. And sometimes it's very difficult to see the tumor because of the scoliosis. So you can see here the tumor in this aspect of big spinal cord and with a complete removal after surgery. It's not so easy sometimes. But nevertheless, the aim of surgery should be maximization of resection. For example, this cervical spinal cord tumor with brainstem edema and hollow cord cysts was treated with complete removal. It was an ependymoma. It's easier than pilocytic astrocytoma. So I will talk about surgical technique, prone position, sweeping holder, and very important to monitor the child. We sometimes monitor some muscles and anal sphincter, but the most important is motor evoked potential. It must be routinely done when you do such procedures. Here is the intraoperating monitoring. So, as I said before, we monitor some muscles and anal sphincter, but the most important remains motor evoked potentials. Then it is very important to do a laminotomy or laminoplasty. And under operative microscope, dura opening on the midline, and after that, identification of the posterior sulcus, the posterior fissure. You can coagulate sometimes the vessel on the posterior sulcus, and then do very gentle your myelotomy. I will show you a video. And then with bipolar forceps very gently go deeper to find the tumor. The debulking must be as complete as possible to identify the margins. I personally use ultrasound aspirator with a 1.14 millimeter needle, but other teams advocate en bloc removal of such tumors in the aim to avoid bleeding and avoid tumor spreading. But it's not so easy to do in clinical practice. Intraoperative ultrasound is very useful before opening the dura, and after opening the dura, you can put it very gently directly on the spinal cord, and then the dissection begins to find the margins. If it's easy, that's most of the time an ependymoma. If it's difficult with an incomplete resection, most of the time it will be a pilocytic astrocytoma. And then at the end of the procedures, I advise to close the myelotomy because it's very useful in case of recurrences with, for example, 7-0 stitches. So this is ultrasound guidance. This is done before dura opening. So you are the tumor here, the solid component of the tumor, and a cyst here and another cyst here. So it's very useful. You can see the cyst and the solid parts of the tumor. And this can be repeated after having opened the dura. So just to see you this aspect of big spinal cord. And this is a very recent case because we done it on the 15th of February. Here is the myelotomy after a very careful coagulation of the posterior fissure. And then with bipolar forceps, you will go very gently deeper, and you will see a very strange tumor here, orange in color, and a cyst here. It was a pilocytic astrocytoma that could be removed completely. So the procedure with the excision of the cyst wall. And this is the very beginning of the closure. You have just one stitch here. It is very important to close the spinal cord after the procedure, because if you are faced with a recurrence, sometimes the recurrence go on this side, on one side, and on the other side, and it's very difficult to find the midline again. So if you want to see the midline in case of recurrence, then it's very useful to have non-resorbable stitches on the spinal cord itself. So in summary, identify the midline before myelotomy, minimize spinal cord retraction, expose superior and inferior pole before deep resection under ultrasound guidance, avoid unnecessary bipolar coagulation, and remove the tumor. I really think en bloc may be very, very difficult to do, but the anterior part must be removed at the end of the procedures. You have to stop your manipulations if motor evoked potential decrease, and we consider a decrease amplitude of 50% from baseline as significant, or even worse, disappear. Then it is advised to have warm irrigation and induce mild hypertension. And if motor evoked potential are still not present, then to convert surgery to partial or subtotal resection, but not to complete resection, because there is a very high risk of postoperative neurological deficit. It's very rare, but we saw it 3 times. Sometimes you can see a tumor, accidental finding, and in France, we call it, we will follow the evolutionary personal profile. We are all different. Some of this tumor will grow and will require surgery, others not. So we advise a close follow-up, symptoms, and serial MR. The prognosis remains good in case of low-grade glioma, with complete resection around 70%, much better for ependymoma, less better for astrocytoma. And the oncological prognosis depends obviously on pathology, but on extent of resection as well. So this is our first series that was published now a long time ago. At this time we had 21 tumors. We are much more tumors now because we are center of reference in the east of France. And we found an overall survival at 5 years of 81% and a progression-free survival of 67%, again at 5 years. We use pre- and post-operatively the modified McCormick scale. It's very useful. It's from grade 1 intact neurologically to grade 5, the worst, with a child who is already paraplegic or quadriplegic. And when you study carefully your patient, and when we study the preoperative modified McCormick scale, the postoperative, and the scale at the end of follow-up, so we will see that you can gain 1 level, or sometimes you have -1 level. So it's not too bad, because you can say to the parents that there will be sometimes a worsening after surgery, but at the end of the day, you can improve and you can be better than before surgery. And sometimes, of course, it's with a neurological deficit. But anyway, we can, I think, minimize it nowadays. I will just point out something that is not so much published. Is the postoperative spinal deformities. In our series, sorry, we have an average delay of spinal deformities, post-op spinal deformities of 13 months. And 60% of them required surgical stabilization. Also, we performed an aminoplasty at first surgery. Of course, you can have pre-op deformities, but again, post-op deformities, you must check it for a very, very long time. And if the scoliosis is worse and worse, you can discuss costal distraction system or posterior, then posterior plus anterior fixations. So we studied one by one all our children. So I will just show 2 examples. It's the evolution of Cobb angle with time. For example, this child had a scoliosis. Nobody thought that it was an intramedullary spinal cord tumor. So there were no MR, then surgery, then fixation, then premature failure of prosthetic material, and then worsening and worsening aggravation of scoliosis. Another case, surgery very, very early, 18 months, then aggravation of scoliosis, then multiple tenotomy, costal distraction. So the scoliosis became better and improved, and then extension of costal distraction, radiotherapy, again extension of costal distraction and change of costal distraction, and all these surgical procedures were useful to have a scoliosis that is 50 degrees. So the third message is the follow-up of children on the long term is mandatory and check for spinal deformity. Very quickly, other treatments, chemotherapy and radiotherapy are both effective, but the gold standard should be maximization of resection. If the resection is only a biopsy, almost all these tumors will grow with time, and the problem will remain the same some months or 1 year after your first surgery. In case of recurrence, we have always to discuss surgery, sometimes chemotherapy, essentially for low-grade gliomas, sometimes radiotherapy, and we have to be very careful with new cysts. If you follow these children with serial MR and you notice that new cysts appear, most of the time is the beginning of a recurrence. In conclusion, there is a frequent diagnosis delay. Surgery is the gold standard and favor maximization of resection whenever possible. Try not to do a simple biopsy, please. Preserve neurological function as much as possible, and additional treatment, chemotherapy or radiotherapy, are mostly for high-grade lesions or tumor progression that is not attainable by a second-look surgery. Spinal deformities remain a frequent complication in the pediatric population, and overall survival and progression-free survival mostly depend on pathology. So thank you very much for your attention.
Thank you very much, Professor Klein. That was a very elegant and very comprehensive lecture on intramedullary tumors. I really enjoyed it. I'll just see whether Dr. Mark Krieger, Dr. Krieger, would you be able to unmute? Do you have any comments, questions for Dr. Professor Klein? While Dr. Krieger tries to unmute, I have got a few questions for you, Professor Klein. First of all, in terms of organization, you mentioned that you are the reference center for east of France. So is spinal tumors being centralized in France?
No, it's a very regional agreement. So we cover an area of 6.3 million people in the eastern France, and we are a center of reference for oncology, pediatric oncology, and with time we see much some, for example, craniofacial cases or chiari malformation and other.
Thanks. And in terms of in terms of CSF leaks, and also in terms of what you call, when the cord is rotated so much that you are trying to find the midline, can you your thoughts on the CSF leaks and the rotated cords? Do you have any comments on that? Thanks.
Well, the CSF leaks still remains a problem, but I think that the closure of the dura must be really obsessive in such situations. So really obsessive, and of course these tumors are challenging, and if you have a rotated spinal cord, it's more and more difficult. So in this case, it's sometimes very difficult to have a complete resection, but here again, ultrasound guidance can be very, very useful and can show you solid tumor remnants, at least at the beginning of the procedure. Later on, it's much difficult, but obviously it remains a very challenging situation.
Thanks. And one more question: in UK, sometimes we have different perspectives between the surgeon and the anesthetist. If the neurophysiology signals fall down, do you increase the blood pressure and try to see whether the signals come back?
Yes, that's the first thing. Yes.
And do you have any protocol by how much you increase or anything?
No. There is no written protocol with that. I'm confident with my anesthetist. It's not an important variation of pressure, but so I'm not sure it needs a real written proper protocol.
Brilliant. Thank you very much again.
Thank you very much, Naren.
That's fantastic. Thank you. So now it brings us to the next lecture. It's from Professor Mohammed El Beltagi. He's the professor of neurosurgery, pediatric neurosurgery, and the chair of pediatric neurosurgery at the Cairo Cancer Center with a huge experience. He has trained both in Europe and US as well. Professor Beltagi, can I please invite you to give you a talk on the important topic of medulloblastoma? Thank you, sir.
Thank you, Naren, for the invitation. Can you see my screen?
Yes, absolutely.
Okay, so I will be talking on medulloblastoma, the topic that was chosen. To start with, no disclosure. As a historical perspective, the primary malignant embryonal tumor of CNS has first described by Bailey and Cushing. This was in 1925 and was named after the medulloblastoma cerebelli. They are considered the most common pediatric malignant CNS tumor that account for 12 to 25% of all childhood CNS tumors. And in Egypt, it represents 18.7% of all brain tumor diagnosed in our center, according to a publication we published in 2016. According to the age, as you can see, the embryonal tumors are running mainly between 5 to 10 years, 10 and 1 to 5 years. That's the commonest age of this kind of tumor, and then start decreasing gradually with age. According to the prognostic factor and progression-free survival in 1969 was first described. This paper that has tried to classify the medulloblastomas according to the risk, stating the classification according to the metastasis and the tumor residual. And at that time, they considered that attempt at radical surgical resection of medulloblastomas should be avoided, and the post-operative radiotherapy should be started as soon as the patient condition permits. Despite that, they had a 50% overall survival for the 5 years and 60% for the 3 years old. In 1999, the prognostic factors has changed, and they start to say that a residual tumor that is more than 1.5 centimeter is considered high risk, and below 1.5 centimeter is considered a low risk. Also, the age was classified to above 3 years age or below 3 years of age. Then comes in 2012, the prognostic factor according to the molecular subgrouping, which was recently described. And according to this molecular subgrouping, they have shown that there are 4 subgroups of medulloblastomas. The WNT, which rarely metastasize and have very good prognosis. The sonic hedgehog, uncommonly metastasizing in infants, and they are intermediate in prognosis. And group 3 with frequent metastasis and very poor prognosis. and then group 4 with a frequent metastasis and intermediate prognosis. As most patients with Wnt medulloblastomas survive, it is possible that nowadays we are being over-treated with current therapies, which are quite morbid, and there is an active discussion of the clinical trial of therapy and de-escalation in this patient population. Why this tumor is still called the medulloblastomas? The term medulloblastoma is deeply ingrained in tumor terminology, and changing the name could be quite disruptive to clinical care and scientific experiments that rely on the prior data as well as epidemiological studies. The WHO changed the classification in 2016 with major restructuring of medulloblastomas with incorporation of the genetic defined entities that has been described. And this was the genetic profiling and histology in comparison to the prognosis, where we have these groups of medulloblastoma Wnt activated. They have the classic and large cell, medulloblastoma sonic hedgehog activated TP53 mutant with large cell anaplastic and desmoplastic nodular, and medulloblastoma sonic hedgehog activated TP53 wild type that has the 3 groups: classic large cell desmoplastic with extensive nodularity, medulloblastoma non-sonic non-Wnt group 3, or medulloblastoma non-sonic non-Wnt group 4. In 2021, the WHO classification ended up in the classification of medulloblastomas according to the subgrouping to the groups Wnt activated, sonic hedgehog activated TP53 wild type or TP53 mutant type, and group 3 and group 4. Our experience in medulloblastomas, as in our Children's Cancer Hospital between these 2007 and 2018, we had 2,073 CNS tumors in our center, and the patient presentation at that time were 4,169 cases with a 5-year overall survival 64.4% and event-free survival 50%. The location of the tumor have shown that posterior fossa tumor are 37.4% of all these tumors. Accordingly, we had 22% of the cases were embryonal tumors that has been presented to our center that constitutes 1,156 tumors of the posterior fossas. 49.1% were the embryonal tumors. The posterior fossa overall survival, when we compare, we find the embryonal tumor curve to be 5-year overall survival, as you can see in comparison to the glial neural tumor. And the event-free survival, again, of the medulloblastomas. This comes to the impact of extent of resection in this tumor. Again, the gross total resection has the best overall survival and progression-free survival, as shown in this curve. According to current data, 400 cases are diagnosed per year in the United States. The rate of cure reached 70% in the contemporary era, and the 5-year survival is reported from 65 to 80%. Medulloblastomas above 3 years of age represent 14.6% of all CNS tumors, and they account for 607 cases in total. Classic and anaplastic variant were the 2 most common subtypes, 493 cases. The progression-free survival in this classic variant is 61.5%, in the anaplastic large cell 60.4%, and in the desmoplastic is 57.5%, which is the worst. The overall survival, again, the classic variant 73.1%, comes next the anaplastic large cell 66.2%, and the least is desmoplastic variant. Infantile medulloblastomas under the age of 3 years at the presentation, mostly desmoplastic and anaplastic, or large cell medulloblastomas, which is considered grade 4 by the WHO old classification. These are the most common type of infantile medulloblastomas, and they have an overall and progression-free survival of 46.8 and 37.6 respectively. The 3-year overall survival for the desmoplastic type is 53.8, the large cell 27.3, and the classic 39.7. Infantile medulloblastoma event-free survival, desmoplastic 41.9, and large cell 26.1, and the classic 27.3. The medulloblastomas by molecular subgrouping, we started this in 2018 and shown that 27 out of 32 desmoplastic were sonic hedgehog. Most of the large cell variants were either group 3 or 4, 55.8, or sonic hedgehog 41.1. 38 out of 300 are less than 3 years old, 27 of them are sonic hedgehog, and 11 were group 3 and 4. The posterior fossa tumors in this type of medulloblastoma, we achieved a gross total resection of 78.1, which is 902 tumors, subtotal resection in 193 cases, and biopsy in 61 cases. The surgery should be as a better prognosis to be achieved to have a gross total resection having a complete clear field as shown in this figure with the aqueduct open and no gross residual tumor by surgery and after by MRI, but still there are surgical complications for the surgery. The commonest complication seen is the cerebellar mutism. This is considered 9%, bulbar palsy in 6%. Some cases had limb weakness of 4%, pseudomeningeocele of 4%, which is self-limited in half of these cases. The extent of resection had a significant impact on overall survival and on progression-free survival, regardless of the histology, age, or even the metastatic status. The medulloblastomas above 3 years, the comparison between anaplastic and large cell and classic medulloblastoma show no significant impact on either overall survival or event-free survival. While in the classic medulloblastoma patient treated by the standard risk protocol, they have a 5-year overall survival of 69 and event-free of 58.5. According to the risk stratification, there are 58.6 of the cases high risk and standard risk 37.4. The risk stratification is again stressed in this publication in 2021 at the Journal of Clinical Oncology, where they still have the cut point of 1.5 centimeter size for the post-operative residual used to define low from high risk medulloblastomas. What about recurrent medulloblastomas? In recurrent medulloblastomas, the survival is very poor. As you can see, overall survival in this publication is 18%. Survival in recurrent medulloblastomas in the recent SIOP study in 2016 at the Neuro-Oncology have shown 72 patients with relapsed medulloblastoma found that surgery was significantly associated with prolonged survival following relapse, but radiation therapy and high-dose chemotherapy were not. This publication by the group of Eric Buffet showed out of 550 cases, there were relapses of 173 cases. Neither the metastasis nor the histology at presentation were associated with any risk of relapse. So does the extent of resection matter? The overall survival of recurrent cases at 1 year was 38.2 and at 3 years, 16.9. Remains the question, does the extent of resection matter even in relapses? Is there any rule for surgery again for recurrent cases? As a current consensus, when we have a recurrent medulloblastoma, if the disease is limited to the CNS, we go for surgery again. If we achieve gross total resection, we end in the tumor board discussion and either autologous stem cell with chemotherapy or chemo plus radio. If we achieve incomplete surgery, then we go directly for radiochemotherapy. What about if the disease is outside the CNS or metastasizing external to the CNS, then it ends in palliative and supportive care. So the pattern of recurrence has been studied in a publication in the Lancet Oncology to see if the recurrence is in the same tumor bed or outside metastasizing, and it's shown that the majority were metastatic and outside the tumor bed, which means that did local control achieved by gross total resection matters? What is the indication of a redo surgery? Early redo, when we do a medulloblastoma and an immediate post-operative MRI showed a residual of more than 1.5 centimeter, then we take the patient again to the operation for a resection. Late redo, if there is a new recurrence or a new tumor after, then we end usually in a biopsy or a resection of a focal recurrent medulloblastoma to confirm the diagnosis. So again, did this patient benefit from re-resection? Those with early redo, yes, they did. According to the numbers, early redo for tumors more than 1.5 centimeter will benefit from the progression and the overall survival. What is the importance of a biopsy in a recurrence? Can the recurrent disease be diagnosed only by clinical and MRI findings? This is a publication showing to stress on this case report, which have shown leptomeningeal and multifocal deposits in this MRI, assumed to be a recurrence, started on steroids and after showed radiological improvement and a clinical improvement, which means that not each MRI finding should be considered the recurrence, except after confirming by a biopsy or a tissue. Another publication, again, with this axial T1 showing on the left side, enhancing lesions, which consistent of medulloblastoma relapse. And then the image on the right was taken 18 months after last dose of chemotherapy and demonstrate complete resolution of this enhancing lesion. So biopsy at the presumed relapse of a child with medulloblastoma should be seriously considered before considering it a recurrence and starting retreatment. Does metastatic lesion have different genetic anomaly or gene expression from the original tumor? According to this publication by the group of in the same Lancet Oncology paper, it showed that the same molecular subgrouping recurs, which means when his first tumor is sonic hedgehog, it comes again as sonic hedgehog. If it's a group 3, it comes again at group 3. So the molecular subgrouping remains the same even in the recurrence. There are some case examples which I want to show. This is a tumor of a medulloblastoma, posterior fossa. That's the preoperative MRI. That's the surgery. As you can see, the patient is prone, right cerebellum, left cerebellum. That's the tumor coming out between the vermis. And we start first by dissecting between the cerebellar normal tissue and the tumor, and creating planes all around and inserting the cottonoid to protect the normal cerebellum. No retractions, because this affects the dentate nucleus and the edema, which is considered a cause or a major cause now for cerebellar mutism. And trying to outline the tumor borders from the beginning helps in complete resection without leaving a residual or violating the normal tissue. Surrounding the whole tumor, as you can see in the video, and trying not to put retractors as much as you can, and getting the tumor in toto or as a large piece, always protecting the brainstem with cottonoid beneath. Now you can see the aqueduct open, the two cerebellar hemispheres, the brainstem clear, which indicates no single residual left. We have also shown this in this is a preoperative ultrasound done intraoperative, sorry. This is the tumor, that's the tent, and that's the right cerebellar hemisphere. That's again the tent. And you can see the tumor in the middle here. And that's an intraoperative ultrasound on the right side here showing complete resection when filling the cavity with fluid to show that there is no presumed resection. Of course, the MRI later on showed the same. This is another case of a 1-year-old male. This is a tumor in a 1-year-old male. That's the immediate post-operative. That's the tumor. Again, creating the planes is the aim, and clearing the whole field from the tumor. Another 11 months female with medulloblastoma. That's the preoperative image. The immediate post-operative image showing a small enhancement here, which is a residual smaller than 1.5 centimeter attached to the brainstem left behind. Another case in a 16 months old female medulloblastoma. In this case, again, we just start creating the planes, We start creating the planes between the tumor, and then the introduction of the endoscope helps us to see the attachment of the tumor to the cerebellar peduncle on the right side, where sharp cutting of the connection between, as you can see here, endoscopic magnification showing an attachment of the tumor to the right cerebellar peduncle, middle cerebellar peduncle, which has been sharply dissected by scissors under endoscopic magnification in order to achieve a safe complete resection, and inserting the cottonoid, advancing it step by step, using the CUSA in between, and finally inspecting the aqueduct by the endoscope. And that's the immediate post-operative image showing complete resection. This is a 3-year-old male also presented in 2019 with this classic sonic hedgehog medulloblastomas, and that's the post-operative images. This has shown, this is the last follow-up after 6 months showing no recurrence. This is another case, 7-year female presented in May 2019 with classic Wendt type medulloblastoma. That's the preoperative images. That's the post-operative images. You can see gross total resection. Again, a follow-up in December 2021, still no recurrence. Another case of a desmoplastic medulloblastoma in a 3-year-old female. Gross total resection, January 2009, and this is the same case in 2016, which is considered a survivor. Case 4, this is another 3-year female, anaplastic large cell. That's a gross total resection, 2015, and that's 2021, no recurrence still. This is another 15-year-old male adolescent complaining from headache, unsteady gait, and showing this cerebellar mass. The patient underwent surgery and gross total resection was achieved. And this was a medulloblastoma with extensive nodularity. And again, this is a small hematoma in the tumor bed. 6 months follow-up show no recurrence. But again, 3-year follow-up MRI showing extensive regrowth of the tumor bed, again at the same place. Biopsy confirmed medulloblastoma, and we started the patient on the chemotherapy afterward. 6 months post-recurrence showing control of the tumor bed. This is another 9-year-old male child who presented with headache, blurring of vision. Urgent shunt was performed, and this MRI preoperatively showed this tumor, gross total resection. 3 years follow-up, he had a metastasis in this area. We have to confirm the diagnosis, as I mentioned, so we did a stereotactic biopsy to show this is an active tumor, but the patient received another session of chemotherapy, and unfortunately, he died in 6 months later. When the metastasis is outside the tumor bed, it's one of the worst prognoses. So does metastatic lesion have different genetic anomaly or gene expression? This we said that it is the same as the primary tumor. What is the future direction for molecular exploration? Dissection of the molecular genome highlights attractive therapeutic option. The molecular exploration delineates multiple molecular keys that might be targeted as the sonic hedgehog, Wnt, PI3K, mTOR pathways, epigenetic dysregulations, and more largely translational concepts across brain tumors like anti-angiogenetic strategies or personalized medicine. That's the future direction which we come out from this molecular exploration. Is there a new consensus regarding the management uprising? How does or will the development of molecular signature influence how we approach resection of the primary tumor mass? As target therapy become commonplace, will there be a different role for surgery at the time of presentation and recurrence? As the recurrence is likely not going to be sensitive to the target therapy, and we will need to identify what it will be sensitive to. The role of vismodegib, which is an inhibitor of the hedgehog pathway, is under further examination in an ongoing phase 2 trial for adult patients with recurrent or refractory disease. In this way, sonic hedgehog, the 5-year overall survival, the group 4, 5-year overall progression-free survival, and the group 3. This is a risk-adapted therapy for young children with medulloblastomas. And as you can see, the low local relapse rate and similarly high distant relapse rate of the intermediate risk patient hints at effective local control but absent distant control from local radiotherapy, which may raise the point that total resection matters in local control, especially in absence of radiotherapy below the age of 3 years. So as a conclusion and a take-home message, the gross total resection of medulloblastoma matters, and resurgery in the recurrent case also matters, so long as it is limited to the CNS. We recommend clinical trial cohort with different lines of therapy and extent of resection, checking the outcome in relation to the observed molecular pattern. And of course, a multi-center study should also be held for retrospective assessment of surgery for recurrent medulloblastomas in the different molecular subgrouping. Thank you.
Thank you. Thank you very much, Professor El-Beltagi. That was a fabulous lecture covering every aspect of medulloblastoma. It really is a great lecture, and I'm sure that you'll review this many times. I just have a small question, which is just for your thought. I think in France, they are trying to do a study where rather than doing surgery for medulloblastoma as the first option, I think it's going to be a randomized study. I'm not involved in it, but they are going to do a biopsy, and then if it is a medulloblastoma, then give a chemotherapy first, try to shrink it, and then operate. This is with a view to reduce cerebellum mutism. Your thoughts on that strategy?
Yes, I mentioned if you in the beginning that it might be that we are over-treating some of this after the development of this molecular subgrouping in some certain sonic hedgehog, that the direction is toward a biopsy, and when it goes with one of the good prognostic subgrouping, then we can go for the radiochemotherapy directly. So this might be a future direction, of course.
That's great. Thanks. Thank you very much. That's brilliant. If there's any more questions for Professor El-Beltagi, could you please put it on the chat box? As I said, all the lectures are on the YouTube, so you can. These are very, very comprehensive lectures. It takes hours to go through and digest it. So that's the nice thing about these webinars, that they actually become a book, in the sense that they are physical. They are there, that you can always refer back to. Thank you very much, Professor El-Beltagi.
Thank you, Naren.
Thank you.
Thank you. Thank you.
Thanks. The next lecture would be from Dr. Mark Krieger. Dr. Krieger, you should be able to share your presentation, Dr. Krieger.
Hi, how are you?
You're okay. I think Professor Beltagi, you couldn't stop sharing. Thanks. That's great. Thank you very much, Dr. Krieger. It's a real honor to have you with us. Dr. Krieger is the head of pediatric neurosurgery at LA Children's Hospital, past chair of the Joint Committee of the AANS and CNS for pediatric neurosurgery. Pineal tumors, they are the most complex ones to operate, and they are not so common, certainly in the Western world. So it really is a technically challenging, and also in terms of management challenge, how you medically as well as surgically. And so it really is I'm really looking forward to your lecture, Professor Krieger.
Thank you. I will try to get my slides up. Hopefully this works. Are my slides showing?
Yes, it is. Yeah.
That's great. Thank you. So it's such an honor to be able to participate in this course. So I want to thank the organizers, and including Naren and George Jallo. So thank you very much. I initially was planning on speaking about a half hour from now, but I guess we're running early, so I'm happy to go through it right now. My goal is basically to talk in the next 20 minutes about different types of tumors that we see in the pineal region, surgical approaches to them, and expectations of outcome, and then leave time for questions and answers afterwards. So I have nothing to disclose. So I think everyone on this call understands what we're talking about the pineal region, right? So the pineal region is in this area where the pineal gland normally is. Sometimes the pathology comes from the pineal region, pineal gland itself, but sometimes it comes from the surrounding tissues, and sometimes it comes from even tissues that are foreign to this area. But this is what we're talking about. When we look at abnormalities in the pineal region, it's important to keep a couple of things in mind. Number one is incidentally discovered cysts are common in this area, and that they are relatively don't require treatment. That might be a little bit controversial, but I would still hold to that. Tumors in this area are relatively rare, and if you look at all series, it probably represents less than 1% of all intracranial tumors. Primary tumors of the pineal gland, which would include the pineocytomas, pineoblastomas, and the ATRTs, are less than 30% of these tumors. It's important to keep in mind that histology determines outcome, and that in this region, tumors are more common than they are relatively in adults, with germ cell tumors as the predominant form of that. So that's sort of my main highlights for this. When you look at a breakdown of the different types of tumors in this area, right, they're broken down into three main categories of children. Number one will be germ cell tumors, and these include germinomas and non-germinomatous germ cell tumors. Pineal parenchymal tumors, which include the pineoblastoma, pineocytoma, PPTID, and the ATRTs as a subclass of the pineoblastomas. And then tumors of adjacent structures, such as astrocytomas and lipomas. These are just typically tumors that happen to be in the area, but have no special predilection for this area. I won't be talking about this last category as it's covered in other areas, but I will be spending some time on the pineal region tumors and the pineal parenchymal tumors. I think as a neurosurgeon, when you're presenting with a tumor in this area, the first question is, what is it that we're looking at? What type of tumor is in this? And the concomitant question should be, can the diagnosis be made by other means? So the type of histology in this area is determine your goals of treatment and your various forms of treatment. And so you really want to know what these things are before you get into them as much as possible. And I want to talk a little bit about other means of diagnosis short of surgical biopsy. The next question you should be asking yourself is, does extent of resection really matter for the histology that you're dealing with? In other words, do I just need to do a biopsy, or do I need to try to get this whole tumor out to to come up with the best possible outcome? So again, if you knew exactly what the pathology was in this area, you would know how best to treat it. The problem is we commonly don't. The different tools in your surgical armamentarium in this area include stereotactic biopsy, endoscopic biopsy or resection, or open surgical resection. And the choice of the procedure really depends on the goals of surgery and the risk-benefit analysis. So I want to just talk a little bit about diagnostic tools first from imaging. So CT scans are still helpful in this area. One is, oftentimes these children present with nonspecific symptoms and you need to find out what's going on quickly. Two is they can tell you if there's hydrocephalus present, and the hydrocephalus may require somewhat urgent treatment. But three, and I think that this is very important, is it could tell you the possibility or the likelihood of calcification in this area. And I think that this is important because it can help you differentiate between the different types of tumors in this area. But it's also important because most forms of chemotherapy are not going to get rid of the calcification. And so if you see calcification up front, you should expect that the calcification is still going to persist even after active treatment. And I think that that's important to know. Residual calcium may not mean that there's residual tumor, and that's important to know up front. Of course, MRI scan is going to be the hallmark of treatment, and you can see the pineal tumors in these locations, and they all look different. What we found is that advanced imaging makes a big difference. So diffusion-weighted imaging is very helpful to us in differentiating the different types of tumor. Of course, DWI helps determine the cellularity of the type of tumor in this area, and this could differentiate between the different types. So these are some of my favorite pineal tumors that I've seen, and you can see that the DWI is different in all of these cases, and this helped make a diagnosis. ADC maps are also helpful for this, and they can help further the information from DWI. We have used advanced perfusion imaging, such as DSC, and DSC is dynamic susceptibility weighted contrast perfusion imaging. And this can really tell you the vascularity of the tumor. So if you look at the image on the left, you might think that this was a benign cyst, but when you see this increased vascularity to it, it points to it being a more active type of tumor. Spin labeling could also help, and you can see that this tumor has a high degree of signal on spin labeling, and this points to a more malignant process. Our group has also found that MR spectroscopy is very useful for determining these different types of tumors, again, helping you know what you're getting into before you get into it. So what we found, and others have confirmed, is that taurine is seen in pineal blastomas and to some degree ATRTs. And so when you see this taurine peak in a tumor, it helps you determine what you're dealing with. This is another patient that had a high lipid lactate, and this pointed to a more aggressive type of tumor. In this case, it had some taurine peak, but it was an ATRT. We believe that using all these different diagnostic techniques together can really help you know what type of tumor it is before you get into it, and help you plan your surgical approach. And this just shows that we had a highly malignant tumor here, and this wound up being an ATRT based on all of these imaging things. In addition to imaging, tumor markers are very, very important, especially given the high predominance of germ cell tumors in children. And so we always look at beta-HCG and alpha-fetoprotein in both the serum and also in the cerebrospinal fluid of these tumors. Placental alkaline phosphatase is an important marker of these cells, but most people don't use it because it's in such low rates in CSF or blood that it's hard to use it as a diagnostic modality. But all of you should have this chart in hand to determine what it means when you send these markers out. And this could be really useful between determining a pure germinoma, which can have some weak beta-HCG positivity, versus a more malignant non-germinomatous germ cell tumor, which would see high levels of beta-HCG and alpha-fetoprotein. Again, this will help determine what your treatment modality would be. So your surgical approach, there's certainly more than one way to skin a cat to get to these things. But the surgical approach really depends on what your goal of therapy is. So if you have a tumor that's going to be treated with upfront chemotherapy or radiation therapy, you probably just want to biopsy it. But if you have another type of tumor that requires an aggressive surgical resection, you're going to want to consider the open surgical approaches. And the main surgical approaches are the supratentorial interhemispheric approach, the supracerebellar intratentorial approach, a transcallosal approach, or a fourth ventricular approach. And those are depicted in this slide. And you can see the transcallosal approach, which is good for getting tumors that extend anteriorly into the third ventricle, the supratentorial supracerebellar infratentorial approach, which is good if you have a high riding tentorium and good access to the pineal region. The interhemispheric approaches, which can come from a high visibility approach or a lower trajectory for lesions where you have more external projection behind the corpus callosum, and the venous anatomy is favorable, as well as the tentorial anatomy. And then sometimes these extend low enough that a fourth ventricular approach would be appropriate too. There are cases where we've had to use different ones of these approaches in conjunction, a multimodal approach, to get gross total resections where indicated. And again, when I'm looking at these tumors, I tend to look at where the tectum is in relationship to the tumor and where the tentorium is in relationship to the tumor to help guide my approach. The pineal region anatomy is super important when you're determining your surgical approach, right? And so we all see these little things that are in that area, but the surrounding vasculature, and particularly the venous anatomy, is very, very important in guiding your approach. I will say that even though these are, viewed as difficult surgeries because the tumor is deep, many of these tumors respect arachnoid planes. And so even if something looks invasive, it may not be. And even if something looks like it's attached to the veins, it may very well be separable from that if you are able to maintain the arachnoid planes. So these pictures just show the importance of the venous anatomy. Obviously, you want to look at the sinuses in terms of getting in. You want to have some familiarity with where the basal vein is, the internal cerebral vein, and the great cerebral vein as you go in. And the relationship of these things should be very clear to you before you go in so you can help determine your surgical approach. This is just a different illustration to emphasize the importance of this. Again, the veins that are around the cerebellum are less important than the deep veins, and those are the ones that you have to respect when you're going in for these tumors. And again, if the arachnoid planes are preserved, you're able to get in there fairly easily. I would mention positioning, and so many of these tumors are performed in an interhemispheric approach or a supracerebellar approach, and I think positioning is very important. We very rarely do these surgeries in a supine position and really prefer the lateral position. And the advantage of the lateral position, and this is an interhemispheric approach, is that you could often use the falx or the tentorium to hold up the contralateral hemisphere or the contralateral structures as you get in. And that makes retraction much more easy. In my experience, I started out using fixed retractors throughout these surgical procedures. And now it's very, very rare that I would use a fixed retractor. I find that by aspirating CSF and having good anesthesia management, we really can get in there without causing any stress on the surrounding brain. One little approach that I do is I'll oftentimes ball up a surgical patty and use that to help retract over a broader distance. And you can see that on the right side of this field. I've also used endoscopic assisted approaches when we get in there to look around the corners and to see in deep spaces, and we found that to be very useful, and of course, dish it to the microscope. So when you're looking at your outcome, you're obviously balancing surgical morbidity and mortality with your tumor outcomes. And it's important to know what type of tumors you're looking at and what your expectations are. So starting with the germ cell tumors are relatively rare in adults, but in children, and particularly adolescents, they're particularly common. Most of these are germinomas. A smaller percentage are mature teratomas, and about 20% would wind up being non-germinomatous germ cell tumors, embryonal carcinomas, choriocarcinomas, yolk sac tumors, or some combination therein, a malignant teratoma. The neuroradiology can help. These are typically dense on CT scans with irregular margins and possible calcifications. But of course, the MRI is going to be the hallmark of looking at these things. So germinomas are the most common type. They may contrast enhance, usually solidly. They may engulf the pineal gland. They could actually extend into the hypothalamic region or have multifocal disease and may present with diabetes insipidus. They can be disseminated. They can present with hydrocephalus, with papilledema. You could have Parano syndrome. Germinomas have a fair degree of controversy because they're exquisitely radiosensitive. So if you give a blast of radiation to these, you'll cure them. The idea is, though, if you want to limit the amount of radiation we give people, we can use chemotherapy as a radiation-sparing adjuvant for many of these cases, and the diagnosis is controversial. Children should not die of germinoma. They should be able to be treated with a combination of radiation and chemotherapy, and you want to make sure that your treatment is tailored towards that. So this slide just emphasizes that point. Non-germinomatous germ cell tumors, however, are very different. So our prognosis has improved somewhat in these tumors, but these are less radiosensitive and less chemosensitive than the other tumors. They can be mature teratomas, and you could see sort of a huge tumor of this sort, and there's something called the growing teratoma syndrome where they can grow. But they could also be immature teratomas, and the goal of surgery is less clear in those, but they have a worse prognosis. Typically, an endoscopic biopsy with CSF markers being sent and a possible endoscopic third ventriculoscopy at the same time is going to be the initial approach if you knew that you were getting into a germ cell tumor. So treatment would usually be biopsy, chemotherapy, and then either reduced chemotherapy, second look surgery where indicated, or radiation therapy. This is an old paper out of the New York group, and it looked at second look surgery. And I think that they found that most of the second look surgeries after successful treatment just resulted in residual scar. So there's a role for second look surgery, but rarely was it for residual disease. I'm sorry about the sloppiness of the slide, but this looked at long-term outcome in germinomas and non-germinomatous germ cell tumors. And there's mixed messages on this. This slide looks at 5-year survivors of these. So if you survive 5 years of non-germinomatous germ cell tumor, you're probably going to have a long-term survival. And if you have a 5-year survival for germinomas, those can recur, but overall the prognosis over 25 years is pretty good. But again, non-germinomatous germ cell tumors have a very variable outcome. Germinomas should be cured by therapy. Looking at other pathologies, pineal cysts are common in this area. These are typically benign lesions. They very rarely grow. They rarely cause problems, but they're considered atypical if they're more than 1 centimeter in size or have heterogeneous enhancement or loculations. Again, I think advanced imaging can really help differentiate pineal cysts from more malignant tumors. Pineal cytomas are a little bit different. These are benign tumors of the pineal gland. Complete resection is curative. They typically have a benign disease course. Because they're almost always resected, it's sort of hard to know the natural history of these. But again, surgery is the hallmark of these for treatment. This is an old study that looked at outcomes. You could see that with gross total resection, there was almost complete survival of these patients. Some people tried biopsy and radiation therapy with less good results. And again, as I mentioned, the natural history is unknown just because these are typically resected completely and not followed. So moving into the more malignant tumors of the pineal region, I'll start with pineoblastoma. And these are small blue cell tumors of the pineal region. They can present on initial presentation as disseminated in 16 to 45%. They may be locally invasive. And just like our other stories about medulloblastoma, the extent of resection may be important. Surgery, though, has had an unclear impact on outcome. There hasn't been really a great study that's proven a benefit one way or the other. Radiation therapy is fairly standard, and chemotherapy is not as efficacious in these tumors, but maybe for some molecular subtypes. If we look at some small series of this with aggressive surgery, chemotherapy, and radiation therapy, you can have pretty good long-term survival, and so I think aggressive management is indicated. This is, again, a 10-year-old study that looked at outcome for pineoblastomas, and age played a large role. So the older children did well, younger children did less well, and we're working on molecular studies to help differentiate between these groups. And again, just studies showing that gross total resection may have a benefit in this group. These are some of my favorite pineoblastomas. They could have very variable appearances. They could have calcium. They could look like they're invasive. They do have a taurine peak on MR spectroscopy, which uniquely distinguishes them. They can look invasive, but even if they look invasive, aggressive resection can play a good role in getting them out. So you may not think you can get them out, but you can. But sometimes they're invasive, and you really have to rely on your surgical adjuvants to be able to get them out. Induction chemotherapy may play a role in making it easier to take these out. And so this was a tumor that had induction chemotherapy with stem cell transplant, and then was able to remove the residual after that. Second look surgery can play a role also. We've had some good results getting second look surgery, getting a gross total resection on those. But high dose radiation therapy can cause devastating effects on the brain, as you can see from this poor encephalic area. Sometimes, this is one of my favorite cases, this looked like a pineal cyst, but our advanced imaging showed it was malignant. It wound up being a pineoblastoma in the early stages, and we were able to get it out. They can mimic other tumors. I think most of us would think that this was a germinoma, but it wasn't. They can have calcification. They can have spine metastases. Sometimes we give extra doses of contrast to be able to pick out the spine metastases in these cases. And the metastases can go away also with the chemotherapy. Again, if you have residual calcium, it doesn't necessarily mean that you have a residual tumor, but it would be good to know that the calcium is there in advance. ATRTs are a smaller group of blue cell tumors. I think we're learning more and more about these over time. We're learning about the molecular grouping of these, and I think that that will help us manage our therapy. We used to think that this was a devastating outcome, but now that we know that some groups probably have a satisfactory outcome with regressive resection. And this just is a little bit of an older study looking at outcomes for ATRT, but I think we have better outcomes now. These ATRTs can be very heterogeneous. But even if you have an awful looking ATRT like this, you sometimes can get it all out with aggressive surgery and treat the hydrocephalus at the same time. Staged procedures sometimes work. This was an ATRT. We were able to get part of it out through the third ventricular approach. You could see the callosotomy, and then the rest through a posterior approach. I would just mention trilateral retinoblastoma, since this comes up occasionally. You can see this is a child who has tumors in both eyes and a pineal region tumor. And this typically is a very aggressive type of lesion. You do want to know what it is before you treat it, but aggressive therapy can result in some survivors. And this is a resection of that. The question is, do you need to biopsy these if you have bilateral retinoblastomas? And we have found, especially with some tumor syndromes, genetic syndromes, that you do want to biopsy because other actors can turn up in these areas. So hopefully I was right on time. That concludes my report. I will stop sharing there. And if it's okay, I'm happy to take questions.
Thank you very much, Dr. Krieger. That was a fantastic talk, lecture on pineal region tumors. It's I mean, it really is fantastic because.
Thank you. It's a lot of information in a short talk.
Absolutely, but you covered everything, and it's. I hope that not only residents, fellows, but consultants will appreciate this talk when they next time see a pineal region tumor, or then they can quickly review this rather than trying to go through a book chapter that is about 30 pages long. And so this is a great service. That's number one. And number two is a general question before I come to specific question, is that, I have been in Birmingham Children's and Bristol Children's, now in Oxford, we don't see so many pineal tumors. And how do you, first of all, in the days when I started neurosurgery a long time ago, you were allowed to do an operation, and even if you did not have that many operations that you had done, or that often that you had done, and the senior consultants used to act as though they are the gods given, and they will just go in, and if there was a complication, that was a complication. But the modern world doesn't accept that anymore, and I don't want anyone to operate on a pineal tumor if they haven't been operating on many of them in a year, let alone one or two, or even one every 2 years. But in the same time, how is someone going to ever be able to operate? So what are your thoughts on that, Dr. Krieger?
Yeah, so I think it's an important issue. The difficulty in operating in this area is the surgical depth, right? Mm-hmm. So oftentimes you're at 9 centimeters when you're operating to get a full extent of resection on this. And, that's a lot. And you're going through a small aperture to get there. And I think that does require technical expertise. The important thing for me, and I can't make this point strongly enough, is that whoever is taking care of these lesions needs to understand the different types of pathology in this area. And in many cases, the most important thing is to treat the hydrocephalus emergently and to try to come up with a diagnosis through minimally invasive means before surgery happens. So the worst thing that happens is the patient comes in and they get a shunt right away, which limits our surgical corridor even for a biopsy. Or somebody thinks that they're going to take this on and do an aggressive surgery up front when it's a germinoma that would never need an aggressive surgery. So I really would, number one, hope that all neurosurgical trainees and all practitioners understand the types of pathology there, and that in many cases, an ETV with or without a biopsy with CSF sampling and serum sampling is the absolute first step. The second step might be advanced imaging to determine if these are ATRTs or pineoblastomas. So I think in this day and age, you should really know what you're getting into before you get into it. In terms of the aggressive surgery resection, I think that these all require advanced oncology services. And I think that those patients are best treated at regional referral centers. And so I would hope that, it's a combined team. It's a surgeon along with the oncologist taking care of these patients. And I feel that because you need the strong oncology backing, that this should really happen really at centers of excellence that have the expertise in these areas. So I hope that that answers your question, and not in an arrogant sort of way, but in a patient-centered sort of way.
I think in terms of the patient-centered way, just to follow up on it, that how do you that in the modern day gets the learning curve, because you have to be there's not much when patient expectations are high, rightly so. That's what I would expect if it was me or my family. And then because the attendings who are doing them haven't done many themselves, they are not going to really give the cases to their trainees or even their junior consultants. And where do you get into that learning curve? Should be I know that in America it's a different system, but in Britain we have got NHS. Whether this is for example, for a country like Britain or France, whether it should be centralized to one or two places where, one center does these things. Am I being? What's your thoughts on that?
Yeah, I mean, unfortunately, I do. I think that these things are rare enough that I think that they just need to be treated at a few centers that have high expertise. And this is not just about the surgeon, but this is about the whole team having experience dealing with these.
Thanks. And then the other thing, one of the commonest patients I see in my outpatients clinic is the pineal cyst. And, I rarely treat pineal cysts. Rarely, I don't, unless they are causing hydrocephalus. Is there ever a condition where these patients are having intermittent aqueduct closures? That's my only worry sometimes. And then, you have got one or two surgeons who operate on all pineal cysts. What's your thoughts on that thing?
Yeah. Look, I follow them. I don't just see a patient and send them home. So I do follow them with surveillance scans just to make sure they're not growing or causing symptoms. I would think that if somebody presents with intermittent compression from a pineal cyst and hydrocephalus, it's somewhat controversial, but probably the most definitive treatment would be an endoscopic third ventriculostomy. So I would be more inclined to do that ahead of doing a cyst removal. I think it's a more benign procedure and more productive. In terms of cyst removal, I mean, 10 years ago, before we knew better, I certainly removed pineal cysts for headaches, but I don't think I've done any of them in the last 10 years. If somebody had a Paranode syndrome or direct septal pressure, I think then I would consider doing a fenestration on these. But again, the goal of surgery is fenestration and not total resection. I've definitely seen children severely harmed by aggressive surgical resection of these pineal cysts, either through damage to the venous structures or to the thalami or to the tectum and brainstem itself. And I really would caution against an aggressive resection of a pineal cyst.
Thanks, thank you. Just following up on that, in terms of headaches, do you think these patients who have headaches, they are usually an incidental finding with these pineal cysts from your experience from your olden days? Thanks.
Yeah, in the absence of hydrocephalus or the absence of ophthalmoplegia or papilledema, I think that they're incidental, and I would not recommend treatment for an incidental cyst. I mean, 20 years ago, I was doing close to 50 temporal arachnoid cyst fenestrations per year, and now I do pretty much none.
Yeah.
And I haven't, had patients with big problems. So I think that in many cases, these are incidental to the headaches in the absence of tectal signs or hydrocephalus.
Thanks. Can I just bring in Professor Beltaghi? Professor Beltaghi, do you have any comments to make?
Thank you, Dr. Krieger, for this interesting presentation. I just want to ask you if you have any experience with the proton therapy for pineoblastoma in comparison to radiotherapy. So have you any cases that had a proton therapy, proton beam after? And do you see a difference?
Yeah, I personally, I'd be interested in hearing your experience. I personally don't have any differentiating experience between them. We just don't have that available. Have you found it beneficial or?
Actually, I sent 2 patients after, but one of them was pineoblastoma and the other was a medulloblastoma for proton therapy. I sent them to Germany, but still this is too early to get a difference. It's just 2 years follow-up. So
yeah, it's, you know, it's like so much of that literature. It's just hard to know, right? It's, you know, small series and variable outcomes and all of that. So theoretically, it sounds like it would be useful, but I just don't have that data.
Thanks.
Yeah. Another thing, in case of an immature teratoma in the pineal region, if you got a biopsy and then you start chemotherapy and the tumor markers normalize with a residual of 1.5 centimeter left behind after normalization of the tumor markers, do you still go for a second look and remove this even with the risk of surgery, or
Right.
you send for radiotherapy directly?
Yeah, so it's a tough question. You know, I think that most of the studies show that if there's residual with the markers normalized, it's most likely either scar tissue, residual calcium, or mature teratoma. And so we get in debates at our place about what to do about mature teratoma. And certainly some mature teratomas grow, but certainly some mature teratomas don't grow. And so the goal of second look surgery is tough. At our place, because of the protocols we're under, it affects the amount of radiation therapy afterwards. So we'd be fine giving a very focal, small dose of radiation therapy if we knew that we did not have residual active disease. But it's a much higher dose of conformal fields if we think that there could be residual tumor. So in those cases, I've done a second look surgery to prove that it's not residual active tumor, so that lower dose radiation therapy can be given. The question is, do you need any radiation therapy at that point? And I think our team feels that there should be in the latest study, but I can't, you know, vouch for that.
Yeah, thank you.
Thank you. Dr. Krieger, I have a final last question. I was speaking to Dr. Kevin Cockcroft from Penn State, gave a lecture on aneurysm surgery, and he was mentioning that he's using exoscope to do it, and the only thing is ICG can't be used, but otherwise it's you know, he finds it much better than microscope. Do you think for these spinal tumors, exoscope have any advantage? Have you used them, or do you contemplating using them?
Yeah, so, you know, so we've used it as an assist, right? So we put a scope in there, you know, to look around the corner or to look underneath the veins and that sort of thing. I still find in my hands, and maybe it's just my training or maybe I'm too old, but I find that the amount of retraction that I need and the amount of arachnoid dissection that I need and the delicacy that I need to do around the veins, I could do much better with an open approach. And I think the other thing is, you know, when you're using a scope, you have very good visualization at the tip of your instrument, but not great look going in. And so, you know, sometimes I've heard of surgeons who have avulsed veins or not paid attention to the things that are on the way in at a deep depth when they're using the scope. So again, I think that there are some very talented endoscopic surgeons who could do a great job with that. I'm just not one of them.
Thank you. I think it's basically which tool suits you and which approach suits you. And on that question of approach, Professor Juha Hörnesniemi in Finland, he always did this, you know, his modified pterional approach for almost all aneurysms. And his feeling was that if you know one approach very well, that's better than knowing 10 approaches with a little experience on each of them. And for pineal tumors, do you think that a person should be a master of one approach, or they should try to modify the approach to suit the tumor?
That hasn't been my surgical philosophy. So I certainly would never advocate somebody doing an approach that they're not comfortable with. But I think that the sort of the geography, if you will, of these tumors determines what approach is best. I really do think that there's a best approach for each tumor individually. And it depends on, you know, some degree of the patient's anatomy, what the tentorium looks like, what the veins look like, what the tectum looks like and where the tumor is. And there's such variability as to where these tumors lie. I mean, some of them could be almost exclusively in the third ventricle, and some of them could be in such a way that it would be hard to reach above the tentorium. And some of them extend so far inferiorly that a fourth ventricular approach would be the best way to do it. So I feel that you have to tailor your surgical approach to these tumors given the depth of where they're at. I feel very comfortable with interhemispheric approaches because we use them for craniopharyngiomas and we use them for other tumors in this area. So I'm comfortable with that. And then I feel very comfortable with the supracerebellar infratentorial approach in the lateral position, since I do a fair number of those. But I can't endorse, I agree with what you're saying about Dr. Kofkar, that you should have things that you're comfortable with. I just think that these tumors really demand a tailored approach to them given their anatomy.
Thanks. Just the last point, and I'm like an alcoholic on the last point. Sometimes when I watch pineal surgery, it doesn't matter which approach that's thought to be the best suited for it. But then you find at one point that they are overreaching. It was good for most of the tumor, not for the last bits of the tumor, but then you are overreaching that approach and getting into trouble. Do you think that there's a place for using one approach and then using another approach for the other area than trying to just push that envelope for whole of the tumor?
Yeah, absolutely. And I hope I didn't give the wrong impression, but when I do surgery, I spend a lot of time trying to figure out what the diagnosis is based on tumor markers and based on advanced MRI imaging and all that. I find that I'm right a lot, but I'm wrong a lot too. And the same thing with surgical approaches. We could spend a lot of time talking about a surgical approach, but sometimes it's really hard to tell until you get in there what the anatomy is going to look like. And especially in this area, where you have very important veins around the corner and very important structures, and it's at depth and you get tired, right? I mean, operating at 9 centimeters is much more of a tiring procedure than operating at 6 or 7 centimeters. I strongly endorse what you're saying. If you find that you're limited in your approach and you're limited in your resection, it's just best to come back another day, re-image in between, and recalibrate as to the approach.
That's brilliant. Thank you very much, Dr. Krieger, for
My
this
pleasure.
fantastic lecture and for extensive. Dr. Krieger, if you can hold on, we have got. I'd love to hear your thoughts on the next lecture from Dr. Elias Rizk. Dr. Rizk, do you want to share your presentation, please? Dr. Rizk, can you hear me? Oh yes, he's come. Hello, thanks, Elias. Elias, we can just see your screen. It says started screening, but we are seeing a black screen. Hello, Elias, can you hear me? I think your audio has a problem, Elias. I think he's trying to reboot, I think. Let's see. While Dr. Elias is trying to reboot, as I said, that I think the resource of this today's session or today's meeting is so good that I hope I will index it when I put it on the YouTube, so that anyone wants to have a review at any point can easily, quickly click and go and see. Elias is back. Hello, Elias. We can't hear you, Elias.
Can you hear me?
Oh, yes, thanks. Do you want
Sorry.
That's great. Do you want to start from the first slide? I think.
Yeah, we're still on introduction now. So the topic that I'm trying to present today is optic nerve gliomas. They're a little bit rare of a tumor that you don't see on a regular basis. They usually encompass about 1% of all CNS tumors, but in pediatrics, they're slightly higher, 3 to 5%, and that's mostly due to the neurofibromatosis group of patients that increase the visualization of these tumors in our practice. 65% of these patients present at the equal as far as frequency between males and females. The majority of these tumors are pilocytic astrocytomas, but sometimes you can see pilomyxoid tumors, and they're a little bit more aggressive in their nature as far as progression. In general, pilocytic astrocytomas rarely metastasize, but there's been some reports from St. Jude's about 5 to 10% of pilocytic astrocytomas generally metastasize, and screening of the neuraxis might be appropriate in that patient population. So as you can see, the distribution of these tumors are spread throughout the visual pathway, but mostly it's between the optic nerve chiasm and hypothalamus, or optic nerve and chiasm. You also have to screen the neurofibromatosis patients, because a third of them over the lifespan can have neurofibromatosis associated optic nerve gliomas, and they usually have a different course than the just the general optic nerve glioma that you see without the associated neurofibromatosis. As far as clinical features, usually they present with visual deficits or acute visual loss, sometimes of the hemorrhages. If it's isolated to the cone of the globe, sometimes you can go and have on the eye. Sometimes with those findings, typically with acute hydrocephalus symptoms, headache, nausea, vomiting, blurry vision, and difficulty keeping the patient in a stable neurological examination. Patients can also present with
I think we lost Dr. Elias. Hopefully he connects back again.
Sorry.
That's okay.
So the clinical features that they develop, most of the time they have some form of endocrine abnormalities, dysfunction. Hello?
Elias, hello, Elias. We can't see your slide.
Sorry about that.
That's okay.
Share the screen. So clinical features, you can have endocrine abnormalities, gonadotropic dysfunction, thyroid stimulating hormone dysfunction, less so the acute DIs that occur, but mostly after an operation that involves the hypothalamus potentially. Like I said, most commonly the growth hormone and precocious puberty. Patients will present more so on that end if they have neurofibromatosis. And like I said, diabetes insipidus is rare as an acute presentation. Diagnosis is often delayed, and those tumors are very large sometimes on discovery. This is a patient I saw with Dr. Diaz. This is a diencephalic syndrome. Dr. Diaz is my mentor at Penn State, and this patient presented with typical diencephalic, happy baby, and has normal intellect, normal linear growth, but they do have wasting and decreased caloric intake over time. And this is attributed to the leptin ghrelin system, most likely with a dysfunction in that location. So if you see that, or even sometimes a bobblehead type of a presentation, just like a supracellular arachnoid cyst, these patients can have these type of presentations. On imaging, you can have an enlarged optic nerve canal or even a J-shaped sella turcica sometimes. That's a typical presentation on plain x-rays. It's kind of rare in our unit, but most of the time we see CT scans and you can see those on the scout images eventually. The CT scan shows, again, the enlargement of the optic canal. You know, it's about 2 to 3 millimeters in width, but in a patient with an optic nerve glioma, it's slightly enlarged. It is a hypodense, and if you see signs of calcifications, other differentials should come about. Standard MRI or brain. You can see the bilateral optic tract, nerves, and also the chiasm itself, in the cerebellar and retrocerebellar area and compression of the midbrain. Typical findings sometimes in early optic nerve gliomas is the moustache sign, where you see the optic chiasm itself slightly dilated and more enlarged in that location, and manifests in younger individuals when you see those early on, especially when you're screening for NF patients for the presence of optic nerve gliomas. A lot of preoperative imaging that could help. Sometimes you can get CTs and MRAs to localize the appropriate vasculature in that location. Or if you want to take this to a little bit more of a detailed analysis, ADC imaging has been really helpful in trying to parse NF-related optic nerve gliomas versus hamartomas in that population, or even changes of the NAA peak, or even choline creatinine ratio increase in patients with optic nerve gliomas. Like Dr. Krieger has said, you know, the diffusion-weighted images in the ADCs have been particularly useful, and it's been shown, like I said, to differentiate some patients with hamartoma compared to optic nerve gliomas, especially in NF patients. The differential is very broad. Obviously, anything that you can, a lot of stuff that you cannot imagine can also happen. But you know, common things are common, and you know, history repeats itself. Doesn't repeat itself, but sometimes, a lot of times, it rhymes. So you know, you have a cellular mass. The typical things to worry about are pituitary adenoma.
Hello, Dr. Rizk. Your sound has gone.
Still able to hear me?
Yes, yeah, just about.
So, for ophthalmology with regular yearly scans, and if there's any changes in their visual fields, then potentially obtain further imaging. There's some role for visual evoked potentials with increased sensitivity and method detections of the optic nerve gliomas, and electrophysiological measurements and the integrity of the visual pathway. But these are usually at you know, specialized institutions, veterinary care centers, not in the regular individuals or ophthalmologists in their offices that requires special units and machines to be able to complete this. Usually the screening continues until the age of 7 in NF patients because the first 6 years of life usually has the maximal risk of development of these optic nerve gliomas. And MRI of the brain and orbits should be used to confirm the diagnosis of optic gliomas once the abnormal examination is conducted. Treatments of incidentally found lesions can be followed with serial imaging, especially with NF tumors. And there's a paper from Senker that showed that the diagnosis in patients with neurofibromatosis and optic or thalamic pathways or optic pathways lesions, you could initiate therapy without the need of a biopsy treatment. But a lot of times, if you see those in NF patients, it's a wait, rescan, and watch. And if there's any new changes, then address those. Because what is typically a progression? You know, you have two definitions of progression: radiographic progression, which is defined in the literature as increase in tumors, optic pathway extension, hypothalamic involvement, or change in the pattern of enhancement. But more so important to us is the clinical progression. Is there a neurological change? Is there visual change? Any neurological changes with the visual fields or even new endocrine dysfunction in the patient? As far as treatment goes, you know, surgery-wise, we are surgeons. Most everything we try to tackle is try to help implement some form of surgical intervention. But in those, the workhorse for those tumors are chemotherapy, and this is the first line therapy with fewer side effects than radiation. If you less than 3 years, then only treatment because the intellectual 5-year recurrence with chemotherapy is about 60%. So it's pretty good in that patient population. In patients that we can try radiotherapy, it's usually delayed after they have some form of growth. You can add on radiotherapy, especially patients with thalamic pathway lesions if they're growing. And in the NF population, usually the initiation of therapy is generally made, like I said, without biopsy and are guided by ophthalmological examination and imaging examination. The typical course is cisplatin or carboplatin and vincristine, which is about a 10-week induction phase, followed by 48 weeks of maintenance. And like I said, more than 60% progression-free survival at 2 years, 75, and at 3 years, 68, and at 5 years, it's about 60%. The 10-year survival just on chemotherapy is usually between 74 to 96% after chemotherapy with and without surgery. And chemotherapy improves quality of life by eliminating or delaying radiotherapy. What about radiotherapy? Some individuals do require therapy, especially with relapse and after completion of chemotherapy. And you have multiple treatment modalities, including external beam, stereotactic, or even proton beam therapy. Radiation therapy usually provides a better longer-term tumor control, so you have another option before you implement some form of surgical intervention. And the progression-free survival is about 5 years if you add on radiotherapy in the patients who had some form of growth after chemotherapy. Concerns with radiotherapy are obviously with the early brain and development, lots of delayed side effects. You can have pituitary dysfunction, cerebrovascular complications with moya-moya development, especially with the NF patient population, neurocognitive, endocrine, and hypothalamic dysfunction. And especially in the NF patients with radiotherapy, they have a higher than average risk of developing all the following that we described prior. Radiation dose is about 40 to 60 grays divided by 1.8 to 2 gray fractions. And usually patients do well in the teenager delayed adulthood type of presentation. As far as negative indicators, usually if you have a tumor that's rapidly growing, especially at an early age, PMA like a pilocytic subtype, tumor location, especially in the chiasm of the hypothalamus, and has lots of microvessel density on histopathology are predictors of bad outcomes. So what is the role of neurosurgery in treatment of these optic nerve gliomas? One is obviously biopsy diagnostic and also potentially resection or gross total resection in amenable lesions, but a lot of times it's debulking that is usually the preferred route to save the patient any hypothalamic dysfunction in the long term. You know, you have a child, they need to develop first and grow, so that will be, they have to grow and complete maturity before you can install on them some form of hypothalamic pituitary dysfunction. The approaches are variable. You can do the subfrontal approach, the terional approach, the lamina terminalis approach that we saw earlier, the interhemispheric approach, the transfornacial approach, or even the endoscopic, where you can do biopsy of the lesion, or even a septostomy to connect both ventricles in acute hydrocephalus and treat the hydrocephalus that a lot of patients present with. How about the secondary interventions? We talked about the treatments of the tubular effects, including vascular complications. That's a big moya population that you need to keep a close follow-up on, and also the hydrocephalus that they usually present with. So lots of follow-up from a surgical standpoint, especially when you get a neurofibromatosis multidisciplinary clinic. It's very important to keep close follow-up with these patients and have regular screening with visual examination and plus or minus MRIs when indicated. There is some surgical circumstances where you can go in and try to excise optic nerve glioma, and that's where you and your ophthalmology / oculoplastic surgeon can combine your expertise to be able to remove an intraconal pure optic nerve glioma that's causing some form of visual distress, proptosis, or growing after chemotherapy has been initiated. The secondary objectives is preservation of the vision on the contralateral side, and thus the intervention itself is not just for cosmetic reasons and keeping the patient from developing proptosis. And to achieve this end, the neurosurgeon obviously needs to be familiar with this regional anatomy. And Dr. Roton had a very nice textbook that he published a while back with a very detailed surgical approach of the optic globe. So if you have a chance, definitely get your hands on this textbook and review the wonderful images that he has. So, this is just the caricature of the optic nerve itself, and you see the annulus of Zinn here with all the 6 intracranial muscles, and it's mostly attached on the superomedial portion of the nerve. And this is where you do your incision over the annulus of Zinn, but you have to resuture it back again, otherwise you'll end up with worsening proptosis. You also need to be familiar with the vascular anatomy. So the ophthalmic artery diverges and provides the short and long ciliary arteries and also the central retinal artery that comes in about a centimeter after the annulus of Zinn and travels from lateral to medial on the dorsal surface of the nerve. You also have the superior ophthalmic nerve, which is outside the annulus of Zinn in the superior orbital fissure. One of the first structures you're going to see when you're getting into the optic nerve from an intracranial approach, something to keep in mind of the vascular anatomy. And to add on top of this, you have the multiple nerves, including the first division of the cranial nerve with the nasal, lacrimal, and frontalis division of the nerve. You have the superior nasociliary nerves in this location, and the superior third nerve innervating the superior and levator palpebral muscle in that location. So putting all these together, when you're doing that approach, you have to be aware from a superior approach, after removing the orbital roof, this is where your oculoplastic surgeon will assist with multiple retractors. And when you've done this before, the actual fat creeps in from every location. So you need really good retraction and assistance to be able to isolate the nerve, expose it appropriately, cut the annulus of Zinn and the optic sheath itself, and be able to resuture it, and you can completely excise the tumor, especially in the patient who has no vision in that eye. And again, cutting the nerve and resuturing back again so you don't develop proptosis. So in summary, surgery and the subfrontal approach with orbital unroofing and excising the affected nerve, and avoid damage to the LPS and oculomotor nerves to avoid undesirable proptosis. And reconstruction of the optic roof is usually done either through a split thickness graft, or you can put some titanium mesh in that location to be able to remove any pulsatile proptosis that can develop in a delayed fashion. Other circumstances are chiasmatic hypothalamic tumors. Usually 50% present with obstructive hydrocephalus. We just had the first case that I showed the first slide on. And it's important to, do what's safe. If you're not comfortable with a septostomy, you can always do a double barrel shunt. If you're, done it before and able to do a nice fenestration anterior and superior to the foramen of Monroe, then you can save the patient another piece of hardware. Surgical treatment, usually it's debulking to, try to decompress the nerve, but really there's no role to be heroic in this circumstance, especially with the effectiveness of chemotherapy. So important surgical take-home messages from this talk. You have to be humble, and these are formidable tumors, just like the craniopharyngiomas that we talked about, or any other tumors that we reviewed today. Incomplete surgical resection doesn't mean that you're not a good surgeon. First, you need to look at the quality of life, treatment options, discuss this in multidisciplinary teams, review it with your colleagues, get their opinions, and provide, tumor specimen for histological verification, cytoreduction, or even treatment of increased cerebral CSF obstruction. And keep in mind that this is not a zero-risk surgery. Like Naren said a little bit ago, like everybody's expecting to have minimally invasive zero-risk surgery, and these are very difficult cases. You look at the craniopharyngioma, and post-operatively, you end up with 90% endocrine dysfunction, and somebody who's completely normal at times presents with acute hydrocephalus. That's the only finding on their initial presentation. And it's a humbling experience. And if you're not seeing those and dealt with them and had a multidisciplinary service to help you assist manage these patients, it's kind of hard to do it on your own. Thank you very much.
Thank you very much, Dr. Rizk. That's you covered all aspects of it.
Sorry about this.
That's okay. And I didn't let you know, but the half of the lecture we didn't see the slides, but certainly your oral presentation was more than adequate for all of us who are from neurosurgery. What you were saying.
I can share it with you and send it to you, Naren.
Absolutely. That's okay, not a problem. Thanks. If you send it to me, then I will send it on with Dr. Sinha's presentation as well. In terms of, I remember when I was a trainee, we had a patient with an optic pathway glioma around the optic chiasm, and then developed, hydrocephalus, and it was very high protein in the CSF. Is that something that you have come across, or with these kinds of tumors?
I don't know if it's a pilocytic tumor that you dealt with, but typically the regular run-of-the-mill JPAs, I do not see elevated proteins with them, but I'm not sure if this is a common thing amongst my colleagues here, but usually it's more of the pilocytic ones that are more aggressive that could potentially come in with high proteins. The schwannomas, vestibular schwannomas can also have obstructive or communicating hydrocephalus. So there's some form of potentially arachnoid scarring or inhibition of absorption of the CSF that could potentially also lead to the hydrocephalus in these patients.
Thanks, thank you. First of all, Professor Klein, are you still there? Professor Klein, do you have any comments on the talk of Dr. Rizk, and any from your own experience, any tips and tricks with these very challenging lesions? Sorry, I can't hear you, Dr. Klein. We can't hear you.
Sorry.
Oh, thanks.
Is it better? Thank you.
Yes, thanks.
So in France, you are not allowed to do radiotherapy in optic pathway glioma in an NF1 patient. And I think we have to be very cautious in terms of resection. Hypothalamus is very, very close to to the surgical place, and we have the policy to have what we call an objective result. So we debulk just the tumor, and with that policy, with that philosophy, we have changed what I call the natural history of optic pathway gliomas. So chemotherapy will become more effective, more efficient, and we see less and less catastrophic situations.
Thanks.
I don't know if the others share the same experience, or
Dr. Krieger and Prof. Dr. Krieger, do you have any comments?
Yeah, no, I would agree. I think, you know, surgery is limited in our experience. It's very much changed over time, but limited where the diagnosis is uncertain, right? So sometimes you can have a ganglioglioma in these locations or another type of lesion that can mimic it. But in most cases, it's fairly straightforward. And then surgery is also indicated for a molecular diagnosis. So we know for many of these tumors, you know, the old carbovincristine regimen is very effective, but not in all cases. And we're finding increasing efficacy with, you know, BRAF mutation treatment and things of that sort. And so, you know, obviously you can't cure these through surgery. You can treat the hydrocephalus and you can make a diagnosis, but the hope is that control will be improved over time with better agents.
Thank you. Professor Beltagi, do you have any
Yes, I totally agree with Dr. Krieger and Dr. Klein about the chiasmal gliomas. We have published 65 cases 3 years ago in the World Neurosurgery, where we started first with the debulking, but we had many hypothalamic manifestations ending up in problems in the sodium and potassium and in the sleepiness. So it ends up that we concluded that the control, just the rule of surgery is to get a tissue diagnosis, spare the vision and the hypothalamus, and continue with chemotherapy. And it proves to be low-grade protocol chemotherapy to have a very good control on these tumors and long survivals with preservation of vision for these kids. Only the pilomyxoid type, which is more aggressive, that needs some aggressive debulking. But otherwise, I would recommend the tissue diagnosis, either endoscopic, clearing the hydrocephalus, and to continue with chemotherapy, a low-grade protocol chemotherapy.
That's great. Thank you very much to Dr. Elias Rizk and all the commentators. So this brings us to the end of day 2, 7 hours of session, and we pretty much covered, I think, about 15 tumors. I will send you the link for the YouTube channel where it's all been recorded, and I hope I will also index it so you can easily jump to the different lectures. And I will get the presentation of Dr. Sinha to you. It might be this week or next week, but certainly within the next 4 weeks, I will increase the volume and then send it to you, and also Elias, Dr. Rizk's PowerPoint presentation. So really, thank you very much. I really appreciate value all the expert speakers who have given their time to take us through these pediatric tumors, brain tumors, and it really is an amazing treatise on this area that people can, as soon as they have a patient of, then they can just review the talk and get a broad idea before concentrating on that tumor. Tomorrow, once again, we are starting slightly early at 12 o'clock. We are getting 5 keynote lectures. The first one is from Professor Eric Buffet from Toronto. He's going to talk. He's a world-class, as you all know, oncologist. He's going to talk to us on his philosophy of how to reduce tumor burden through either surgery or through chemotherapy, so that radiotherapy is not, could be minimized. That should be fantastic. Then after that, we are going to get Dr. Al Cohen giving a lecture 1 hour on the advancement in pediatric brain surgery, and also looking forwards. So that should be once again a treat. Then we have got 2 neuro-oncology general talks. One is from Dr. Ibrahim Kodami. He is at St. Jude. He has done a lot of work on late diagnosis and how to diagnose tumors early. Certainly in Britain, we have had problem of late diagnosis of brain tumors, pediatric brain tumors, and particularly during the COVID time, it has been even more delayed, so that should be good to learn what strategies that Dr. Kodami had looked at different practices and see how they can be implemented. And then also from St. Jude, Dr. Daniel Moira. As you know, St. Jude has quite a large global education program. I also went there for a month. They give scholarships to people from other countries to come and spend at least a month in their department. And so we will learn from their educational efforts what they have achieved. Then we have got 2 lectures on, one is from Dr. Jallo and one is from Professor Dia Pujari on the complex cases that they have treated and what they have learned. So that should be a fantastic evening, and look forward to having you if you are able to, but otherwise I will record it and you can always review it. So thank you very much, everyone, to the speakers, to the participants, to those who had been commentators, and look forward to seeing you tomorrow. Bye for now. Cheerio.
Thank you, Naren. Thank you. Bye.
Thanks. Thank you very much, Professor Beltang. Thanks.